artery. After mobilization of the vertebral artery, bilateral C1 lateral mass and C2 screw were put under image intensifier guidance. C1 lateral mass and C2 pass screw, which is a classical technique to fixate for posterior fixation of the C1 C2 joints. After putting the screws, the rod was put between C1 lateral mass and C2 pass screws so as to fixate it. No spacer was used in this technique. So screws are being put on the bilateral sides. After putting the C1 C2 screw, so as to fixate it. No spacer was used in this technique. After putting the C1 C2 screws, the C1 laminectomy was also done. Second, video. So the same thing being demonstrated. Screws are being put and down, rods are being put on both the sides so as to fixate it, and we can reduce the dislocation between atlas and axis joint. And this is the final symmetry, and now C1 laminectomy being done to decompress the spinal cord so that the compression is relieved over the spinal cord. Rods are being put on both the sides so as to fixate it, and we can reduce the dislocation between atlas and post-operative course. Patient was discharged on POD 9, and patient is neurologically same with 4/5 power in right upper and lower limb. Wound is healthy and having no discharge. So post-operative course was uneventful. Thank you. Thank you so much. Post-operative course, patient was discharged on.
What is your opinion on laminectomy before placement of screws and before after placement of screws?
Sir, as far as I believe, if we do laminectomy before placement of screws, it can make spine slightly more unstable because of the spine, or especially cervical spine.
The whole idea is that the spine is unstable, that's why you're fixing. So if you put the screws before the in case you want to do a laminectomy and you want to put the screws, putting the screws actually makes it more mobile because you're manipulating the C1. It moves a lot and causes micro trauma. So what do you think about it?
Yes, sir. It can make the spine more mobile, but once we fix it with the rods on bilateral sides, there is some sort of fixation that comes in a particular position where the atlantoaxial dislocation is minimized, and once that fixation has been achieved, then if we do C1 laminectomy, it will be better for reducing the instability of the cervical spine and also to decompress the spinal cord.
The question was if you do a C1 laminectomy before putting screws, because while putting screw you will be pressing on C1 C2, so that will cause a cord compression as well. So whether you do a laminectomy before or after, that was the question, but it's fine. I mean, any other questions? Okay.
Thank you. Thank you.
We call Dr. Priya, the next presenter. She will be presenting a video on type 1 split cord malformations. Whether you do a laminectomy before or after, that was the question, but it's fine. I mean, any other questions? Okay.
Thank you. Thank you.
We call Dr. Priya, the next presenter. She will be presenting a video on type 1.
Good morning, everyone. So I'll be presenting on basically a case of type 1 split cord malformation. So this child was a 3-year-old girl who presented with tuft of hair at back since birth, which was noticed by the parents. On imaging, there was a bony spur which was extending from D12 posteriorly. Basically, it was a ventrodorsal spur. Type 1 split cord malformation. And on the axial imaging also we can see these are the two thecal sac, the two cords, two hemicords, and then this was the split. This is at the level of the D12. This is the plain CT of the patient, which also is suggestive of the same. Here at D12, this is the spur, which is arising ventrally and then going towards the spinous processes. And then this was the split. This is at the level of the. So it was type 1C Mahapatra and by Mahapatra and Gupta classification of type 1 split cord. So in this patient, the patient was placed prone and then the incision was marked from D11 to L2, and then the spinous processes and the lamina were exposed, and then the laminectomy was done using bone CUSA. This video is after the laminectomy was done. So here we can see this. Here, this is the site of the spur. So above the spur, there was some soft tissue which was removed carefully. After removing the soft tissue, the bony spur was delineated, and then using upcut, it was removed in a piecemeal fashion. Then again using dissectors, the bony spur was separated from the two hemichords and was removed using fine nibblers. After removing the soft tissue, the bony spur was delineated. So this is the bony spur which you can see very clearly. So here we can see it is present actually at the inferior aspect of the hemichords. So therefore it is type 1C classification. So then after removing whatever part of the bony spur we could remove, then the dura was opened above and below the spur. So this is the bony spur which you can see very clearly. So here we can see it is, and then all around the, at the level of the spur, it was open all around the spur. Therefore it is type 1C classification. So then after removing whatever part of the bony spur we could remove, then the dura was opened above and below the spur. So here we can see this is the bony spur, and then all around the, at the level of the spur it was open. And also we can see now the two hemichord. This is one hemichord, this is the other one. Then after carefully separating the spur from the two hemichords, it was removed in a piecemeal fashion. And here we can see that we have reached the posterior aspect of the spur. And then by carefully disconnecting the spur from the posterior aspect using a bone nibbler, the spur was removed. The spur from the two hemichords, it was removed in a piecemeal fashion. And here we can see that we have reached the posterior aspect of the spur. So this is basically a bone CUSA which is being used. Disconnecting the spur from the posterior aspect using a bone nibbler, the spur was removed. So this is the last part of the spur which is being removed now. So that both the hemichords were free and there were no other tethering elements. So this is basically a bone CUSA which is being used. So this is the last part of the spur which is being removed now. So that both the hemichords. So now we can clearly see the two hemichords here, and then using bone wax, hemostasis was achieved, followed by dural closure. And in this case, there was a low-lying cord also, so we had done detethering at L5 S1 level, and post-operatively patient had no deficits and were discharged on post-op day 5. Thank you. Using bone wax, hemostasis was achieved, followed by dural closure.
Well presented, Priya. Any questions?
There was a low-lying cord also, so we had done detethering at L5 S1 level. And
Among the splits, which do you think has the maximum chance of deterioration
type 1D.
and why?
The type 1D, because in that the dura as well as the hemichords are they are closely adherent to the spur. So in those cases, when you manipulate the spur, there are more chances of deterioration.
Among the splits, which do you think has the maximum chance
Hello.
of deterioration?
Yeah, very nice presentation. Just want to know what was the post-operatively, was there any CSF leak?
No, there was no CSF leak in the post-operative period.
Okay. Because anterior dura, if we are not suturing very well, they could end up in CSF leak.
Yeah, basically I think at the end I showed the bone wax was put, and I don't think there was any CSF leak anteriorly, intraoperatively also, as we could see. No, there was no CSF leak in the
Okay,
post-operative
thank you.
period. In this case, we didn't, yeah, and we don't usually, yes.
But do you generally tend to always close the anterior dura?
No, sir.
So we don't close the anterior dura. Normally it is recommended to close posteriorly. So you make a split into a single dural sac with both the hemichords inside. So that is the main idea, so that the tethering doesn't happen. In future, if they want to go ahead with a deformity correction, you have to do the split first, followed by deformity correction. So we don't close the anterior dura. Normally, it is recommended to close it.
Okay, thank you, Priya.
Make a split into a single.
Next,
With both the
I will like to call Dr.
the tethering doesn't happen. In future, if they want to go ahead with a deformity correction, you have to.
Dr. Tejas is there.
Followed by deformity correction.
Dr. Vedang. Dr. Anish. Next, I will like to call Dr. Dr. Tejas is there. Dr. Vedang. Dr. Anish.
Good morning, faculties. So I'll be presenting a case of Mr. A, 40 years old male, who presented with complaints of lower back pain and difficulty in walking since 2 years, complaints of numbness since 1 year, complaints of slipping of sandals since 1 month. On examination, the power in the lower limbs were 3/5, and the tone was increased in his lower limbs. On MRI, there was a D10 to D11 lesion with holocaust serrings present for the patient. T1 hypo, T2 hypo, and T1 contrast, it was enhancing. Patient was planned for laminectomy and excision. It was diagnosed to be an AIIMS as well. Planned for laminectomy and excision. Patient was placed in prone position. After laminectomy, dura was exposed. Dura was open. This is the cranial caudal, and the dorsal roots are visualized. Midline myelotomy was performed, and on myelotomy you could see the tumor, which is visualized. And subpile stitches were taken to expose the tumor. This is the cranial caudal, and the dorsal roots are visualized. There was continuous, using sharp dissection, the tumor was delineated, and dissection was started from caudal to cranial to separate the tumor. You could see a whole part of the syrinx present in the cord. Using sharp dissection, the tumor was separated from the cord, and there was a good plane seen between the cord and the tumor. And dissection was started from caudal to cranial to separate the tumor. On continuous sharp dissection, you could see on the cranial end, now we're dissecting on the cranial end, separated from the cord, and there's a good. This is the part where most likely where the origin of the tumor could have been attached to the cells. So a sleeve of tumor was left behind, and then it was coagulated post that. On the cranial end, now we're dissecting on the cranial end. Hemostasis, this is a tumor, this is the part where the tumor has been attached to the cord, and a sleeve of tumor was left behind, and then hemostasis was achieved, and then the pyre was closed, and then it was coagulated post that. This is a part of the small sleeve which was coagulated, and hemostasis was achieved, and a sleeve of tumor was left behind, and then hemostasis was achieved, and then the pile stitches were taken, and the pile stitches were closed, and then the dura also was closed post that. Post-op, patient was followed up after 25 days. Patient's power improved from 3 to 4/5, and the spasticity also had reduced. Thank you. Pile stitches were taken, and the pile stitches were closed, and then the dura also was closed post that.
Thank you, Anish. There are several questions. I think we will take one by one.
So how did you identify the midline? Like to do the myelotomy?
So from the dorsal roots were present. So from there, the midline was visualized
How?
midway up.
Thank you, Anish. There are several.
What are the two ways of identifying the midline when you're doing the myelotomy?
The dorsal medullary vein could be visualized. That will be the midline.
That's a question we frequently asked for you in your exams. So you better brush up your knowledge.
What you didn't use the in-job neuromonitoring and in-job ultrasound or the CUSA, these three things?
So the thing is, on that day, there was IONM was not available, so due to different reasons, it was not available. So we didn't use IONM at that.
You didn't use the in-job.
By sharp dissection, the tumor was separated, so
in-job
QSA was.
ultrasound or the QSA, these three.
So what was the histopathology?
So histopathology was grade 2 ependymomas.
And the some tumor was left behind, right?
Yes. A sleeve of
So
tumor.
how do you follow up, and is there any requirement of adjuvant therapy?
So we follow up for every 6 months to check an MRI, get a check MRI to see if there is progression. Histopathology was grade 2 ependymomas.
And
Progression in size.
tumor was left behind. Yes, in size then. So how do you follow up, and is there any requirement of adjuvant therapy?
So we follow up for every 6 months to check an MRI. If patient is asymptomatic, we don't. Progression in size.
You reoperate or you go for adjuvant therapy? How do you manage if it recurs, increase in size?
So mostly we give patient is asymptomatic, we don't.
We would consider adjuvant chemotherapy following this. So probably we will be also having that in mind. But it was a very small lobule which was actually coagulated. So hopefully we will just first observe, and then if there is increase, then probably we'll consider. He actually presented with spastic paraplegia, almost. So just he had some power, so around 2/5. Any more questions? Okay, so it's the last presenter. Is there a last presenter, Dr. Sarvesh Yadav? No, he's not presenting. Okay, so I think we are. Thank you very much, and we come to the end of this session, and I thank my co-chairs for being here on so early in the morning. We can move on to the next session. We close the session. Thank you.
Okay. So after this session, there would be a tea break. Then after tea break, we will start the case discussion for today's OTs. Okay. So there would be 15 minutes tea break. Then we will start the sessions.
We close the session. Thank you.
So after this session, there would be a tea break. Then after tea break, we will start the case discussion for today's OTs. Okay. So there would be 15 minutes tea break. Then we will start the sessions.
इसमें क्यों डाल रहे हो ये वाला? तो ये अलग होगा ना, केस डिस्कशन अलग है, वो उनकी प्रेजेंटेशन। चलो ठीक है, ठीक है सर। ये वाला ना? OT-2 8 स्लाइड्स हैं सर। सर वीडियो भी है? ये सर वीडियो। सर स्क्रीन पे आ रहा है सर, टाइम लगेगा, दिखा दो। एक मिनट सर। हाँ जी, दोनों में सर। हाँ जी सर, एक में
morning, everyone. Welcome back. We'll be starting with our next session for the morning, which is live operative case discussion and short talk on how I do it by respective operating faculty. Now I'd like to invite Dr. Sarvesh Yadav to discuss the OT-1 case.
Good morning, respective faculties and dear colleagues. I will be discussing the case of OT-1. Patient is a 12-year-old male child, a resident of Gwalior MP, and he presented with, to us with the complaint of progressive right side lateral curvature of the dorsal spine since birth. And he was evaluated outside in the private hospital, where he was diagnosed with D12 hemivertebra and a kyphoscoliosis, and underwent D11 to L1 fixation with pedicle screw and rod and D12 vertebral body resection last year in May. And post-surgery, after 2 months of the surgery, he again started having deformity in the mid-back, which was progressive in nature. On examination, patient was conscious for any time, place, and person. His height was 141 centimeter, and on there was a 10 centimeter midline vertical healed scar over the back, and with a prominent dorsal kyphosis and a scoliosis to the right. And on motor examination, which was normal, the power in all 4 limbs by 5 by 5 in, with no sensory deficit, and gait was normal. There was no bowel or bladder involvement. So this was the diagram of the picture, which shows a scoliosis towards the right and a midline scar with a component of kyphosis. This is the whole spine X-ray, which shows the previous implants in the D11 and L1 vertebra with the curvature towards the right and a corpse angle of 31 degree. This was the CT scan done now, which shows the there is the hemivertebra at the level of D12, and there is a kyphosis towards the right, and with the scoliosis towards the right, and along with kyphosis. And on MRI, there was a slight cord compression at the level of D12 vertebra, and with no significant compression. And so this was the history. Now I will call Professor Colesso for his operative technique.
I try to remove pedicle screws, try to do posterior osteotomy, multi-level, and make instrumentation from T5 to L4, and try to do correction. Maybe it will be depend from situation, maybe try to resection hemivertebra of the apex of the curvature with cage, maybe, but I try do without it.
So you will be planning a corpectomy and then putting a cage on one side?
I try don't do it because in standing position deformity very high. In lying position it's more or less. That means that this deformity not very rigid. When we do instrumentation from T5 to L4 and multi-level posterior osteotomy, I try to make correction without vertebral body resection, without VCR. If will be difficult to make correction, I think try to make resection vertebral body with cages. What about the role of dynamic correction in this? No, dynamic correction is kyphotic direction. It's a contraindication for dynamic correction. Only idiopathic scoliosis, thoracic, thoracolumbar, lumbar. It's. I'll show long-term results, follow-up after dynamic correction today.
Professor Colesso, what would be your lower limit of fixation here? Lower limit of fixation.
I'm going from T5 on the up TL4.
T5 to
each vertebra.
T5 to L4.
L4.
Why not L3? We stop at L3.
I think it's too short because we should make correction more as possible. And if you stop at L3, it's very short will be power for make correction. L4 is optimal because vertebral body is too small, and for more stable pedicle screws, I think we should to use as more as possible.
Okay. So he is a growing child. So any further direction? What about the screws if he is growing? So do we need to remove?
I think that when we're introducing pedicle screw in each vertebra, it's no problem for growing spine because vertebral body begin to grow inside invertebral disc, and usually we haven't any problem with this.
Okay.
Of course, the high patients is not too big, but we have no choice to decide it in another way.
So which is the apical vertebra you are considering here? Which is the apical vertebra, apex vertebra here?
I said that I try, don't touch vertebra on the apex. I think it's possible make correction from on the posterior osteotomy because no fusion in anterior part of the body. And when I make traction to patient, deformity decrease.
So I'm just asking, what is the maximum concentration of the screws you are putting? At which level you are putting the maximum concentration of the screws? You are skipping some levels?
I try to introducing screws each vertebra. Maybe from the I try to introduce screws.
Come on the stage. Come on the stage, sir. So this way.
It's the stand position and curvature quite big, but can you change position to CT? Here is up part of deformity and lower part decrease in 2 times. Of course, here fusion, but not so solid because invertebral disc is without fusion. If we do resection posterior part and introducing screws here, 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 till 5, and step by step we decrease this curvature, I suppose. If it will be impossible, I'll do resection of the vertebral body here, introducing cage and make correction.
Do you also check for sagittal balance, or that will be done later?
Balance? Can you show stand position X-ray? Actually, balance is quite good. Position the body is quite good, but just kyphosis because he is too young, and without degenerative disc disease in lower part, and more or less good muscle function, young. That's why balance is good. Thank you. Thank you.
Thank you, sir, Professor Golaso. Now I invite Dr. Pavna to proceed.
Now I'd like to invite Dr. Puranjay to present OT-2 case, which is to be operated by Professor Suri sir.
Good morning, everyone. I'll be presenting OT2 first case to be operated by Professor Suri sir. Patient is a 46-year-old male. He has a progressive bilateral lower limb weakness since past 10 months, which is he's more symptomatic towards the left side. He also have funicular type pain in bilateral lower limbs with a band-like sensation in upper abdomen. He has developed post-void dribbling occasionally happening since past 2 months. On examination, sensory level is at D6. Below that, he has 10% loss of pain, temperature, and touch, however, no loss of proprioception. And on motor examination, he has grade 1 spasticity. Power in right lower limb in that hip, knee, and ankle is 4/5, and left sided 4 minus by 5 is there. And his hyperreflexia in knee ankle joint with extensor plantars. So on imaging, on T2 at D2, D3 level, we can see cord expansion with the intramedullary lesion with a heterogeneous T2 intensity with a few hyperintense component. I will show the Excel run. On T2 at D2, D3 level, we can see cord expansion with the intramedullary lesion with a heterogeneous. So on further contrast imaging, there is a heterogeneous enhancement is there on the lesion. For the discussion part, I will invite Professor Suri. On further contrast imaging, there is a heterogeneous enhancement.
Morning. Well, this is a classical case of a D2-3 intramedullary lesion. Classical looks like an ependymoma. It has a developing syrinx or edema above. There is already a syrinx which is coming down. It's slightly heterogeneous. There is a good amount of contrast enhancement. If you see, if you're just pushing, and it's pushing the normal spinal cord laterally. Yeah. Developing syrinx pushing the edema above. Yours or mine? Already a syrinx which is pushing the. So it has more prominence posteriorly. Pushing it. So. Radiological impression is an ependymoma. We checked with our neuroradiology professor, Dr. Garg as well. So it's a straightforward case in which we'll be operating in prone position, do a laminoplasty, a level above, maybe half a level below. So 3.5 levels of laparotomy. Then the main ideas, especially for the youngsters, main thing is a pure midline approach. But we have to understand that because of the anatomy of the tumor, it may be pushing on one side. So you have to identify, the midline is not your midline or the patient's midline. It is actually the cord's midline that you have to identify by looking at, when you do the laminotomy, open the dura, you must see the root entry zones in either sides. And then you actually identify the midline. Usually it is covered by a small posterior midline vein, but sometimes it's not there. But still then, you have to identify the midline, open the pyre there, try to separate the two fasciculi and the posterior fasciculi, and then you create you open the septum and you create and separate. Do not burn it with a cautery or in laser or anything. It's better to separate it and then find the tumor. Then go on either side of the tumor and then try to separate it from the normal cord. There are two schools of thought here. Either you take it beyond on both sides and take it above and below, and then you take out in mass. That is one, and total excision. Another school of thought is which you can depends on your tumor. The central tumor is pretty bulky, then it's better to, after you've defined both the sides, just decompress in the middle, and then you dissect from the anterior portion. The dissection of the anterolateral is the most important. You cannot, at the cost of tumor removal in toto, you cannot be bluntly dissecting on your anterolateral. That is the anterior spine, that is the corticospinal tract. You cannot, because there will be some great weakness if you're there. We will have intraoperative monitoring in this case. We'll be monitoring, and we'll keep on showing you those images. And that is where there's a perforator of the anterior spinal artery is there, especially when you're on the bang anterior surface, the anterior midline. That is where you have to be very careful that you do not breach the pia there, number one. Number two, do not coagulate any perforator coming directly from the anterior spinal artery, because you'll land the patient in practically paraplegic then. So we'll do the case. Any questions from the house? That is where you have to be very careful that you do not breach the pia there, please. Number one. Number two, do not coagulate any perforator coming directly from the anterior spinal artery, because you'll land the patient in practically paraplegic then. So.
Morning. It'll be a nice dissection, I'm sure. So this is at T2-3 level, vertebrae. Why can't we just get away with a laminectomy and when a laminoplasty? Because laminoplasties are generally done for prevention of long-term, kyphosis or something.
You can.
T2, T3, yeah.
But being a training program, I always say, okay, you take the lamina back, put it back, and it's pretty straightforward. It's not something, you just have to take a foot plate drill and take out one side, and maybe, because there's cord expansion, I would not like to do the foot plate on both the sides. Put on one side and one just a drilling on the other side, and we'll have a plate, and that can be just fixed with many plates, not a very major thing there.
So the other question is...
But you're right, you can do away with a three spine.
The other question, Professor, is in your IOIMS...
Sorry to interrupt. And it actually, especially there is no diagnostic doubt here, but yes, we've had some cases mimicking ependymomas, but we landed up as a pilocytic astrocytoma. These are cases, in total resection is not there. You have to do a radical decompression, and it ends where the plane is there. These tumors are benign, but they have a possibility of recurrence. Laminoplasty actually helps. If you're going in again after 5 years or so, you can actually go back and again. But if you're doing just laminoplasty, you're practically landing on the dura. Sorry for the second.
No, I understand. Good point. The thing I was talking about is your IOIMS protocol. Do you routinely do D-wave in your center? And what's been your experience when you use D-wave? Is it a mandatory? Not some. If you give me some IOIMS protocol data or some idea, and especially for the youngsters.
The D-wave is there always. You'll be seeing that, and now we are lucky that our IOIMS is taken care by our physiologists actually. There's a big physiology department, and there's a section which is headed by Dr. Ijarial, and he actually is looking into neuroelectrophysiology. He's doing a lot of this work for the last maybe 10 years with neurosurgery, with orthopedic spine, as well as with trauma surgery. And he has some residents who are interested, and now the good thing is they have now 15 positions of clinical electrophysiology, not clinical physiology will come in as residents. That will be really helpful for us. So they're just going to join, I think, another couple of weeks. And so then there'll be a lot of, at the moment we have one resident from them and managing 2 or 3 ORs, and then we can actually think of buying more machines. As a protocol for all IOIMS, we're doing all IOIMS for tumors in the spine, for D-waves, and even for cranial monitoring. And cranial nerves we are doing for 7th, the nucleus on the brainstem as well as on the 7th nerve. I've done on 6th and on the 12th, and there's electrodes on the endotracheal tube for the lower cranial nerves. Then for the peripheral nerve injuries, we're using for that, and we require them for the D-wave and the APPs. It's a pretty good job, but you're right. Do we stop surgery if the D waves come down? It is a matter of, it depends. If it is an ependymoma and everything is an ependymoma, I will not stop surgery. I would go back to that later. If it is a pilocytic astrocytoma or a lipoma, I would stop surgery at that point.
Do we stop surgery?
Professor Dr. Ajinkya from NIMANS. I'm a senior resident. Actually, in case of diffuse eccentric lesions like astrocytoma, what is your comment on unilateral versus bilateral D wave if we insert, if the patient is having weakness more on right side? So do you prefer putting bilateral D wave to look for right and left?
I always use IONM, but I personally believe that your IONM actually gives you a good feeling that you're going in the right place. It doesn't really help you operate. It always has a, there's always a problem. When problem occurs, you have to either stop, that is there.
Yes, sir. Like regarding D waves, we use usually the distal one, but we use the single probe. But if there is differential weakness like right and left, sometimes we put two electrodes, right and one left.
We use, I think, single. I think I'll have you talk to Dr. Jaryal later.
Fine, thank you, sir. Regarding D waves, we use usually the
Anything
distal
else?
one, but we use the single probe.
Yeah, thank you.
If there is differential weakness like right and left, sometimes we put two
no.
electrodes, right and one left.
We use, I think, single. I'll have you talk to Dr. Jaryal later.
Thank you, sir.
Anything else? Yeah, thank you.
Now I would like to invite Dr. Chaitanya to discuss the next OT case.
OT3 case 1. Okay. Good morning, esteemed faculty and colleagues. I'll be presenting the cases of OT3, starting with the first case. Mr. X, who is an 84-year-old male, came with complaints of low backache radiating to the bilateral lower limbs since 8 months with a claudication distance of 20 steps. So he doesn't have any bowel or bladder involvement. His on motor examination, his power on the upper limbs is 5 by 5, lower limbs is 4 plus by 5 at hip joint, knee joint and ankle and EHL. Sensations are intact, tone is normal. Reflexes are 2 plus in the lower limbs and plantars are flexor. On imaging, he has multiple level lumbar PIVD with L23, L34, L45 and L5S1 with listhesis. This is the CT of the patient showing L5S1 listhesis. I'd like to invite Professor Park for the operative approach for this patient.
Actually, hello everyone, I am Park from South Korea. It's my great honor to stand here. Actually, all of cases are very severe and complex case, but my case is very simple. Just only spinal canal stenosis on L45. So today, I would like to have a live surgery. How can I decompress the spinal canal stenosis with the endoscope? There are two types of endoscope, unipolar and bipolar. Today, I want to show you how to decompress the spinal canal stenosis with usually I use the epidural anesthesia, and my operation time is around 30 or 40 minutes. And this case is a very severe case of spinal canal stenosis. So I would like to remove the ligament flavum with one piece or two piece. Usually, if you remove the your ligament flavum with a piece by piece, it is some cause of early dry tear. I mean, endoscope is a water-based surgery. Microscope is a air-based surgery. So laminectomy, usually laminectomy and the proximal ligament flavum, laminectomy, proximal ligament flavum make early exposure of epidural space. It means if you expose epidural space early stage, it can lead to the early tearing of dura. Early tearing of dura means you have to convert your surgery to the open because the pressure of your surgical field is transmitted to the intracranial because you are operating in the fluid. So, I mean, the late exposure of epidural space, it means after completing your drillings, laminar drillings, whole drillings, and the exposure of your ligament flavum, especially for the inner layer of ligament flavum, and to separate your ligament flavum, and then remove it with an angular or two-piece. With this vest, you can expose your epidural space lately. Later tearing of dura, you can control without conversion of open surgery. That is my plan today.
OT-3 second case.
Good afternoon, sir. Sir, would like to know that during endoscopy when water is flowing, how would we detect the subtle dural tear? Because would it be difficult to know whether it's water or getting mixed with CSF?
Actually, the big advantage of endoscope is you can see it very clearly with the magnification field. So we can find the tearing of dura or root red, and sometimes aracoid membrane. So we can recognize the tearing of dura. If there is severe dura tear, we know very well some eruption of root red, also finding of dura tear. But you can see very easily the finding of dura tear with my endoscope.
Thank you, sir. Thank you.
Dr. Park, is there chances of increased instability because she's a very elderly female, 80 plus years?
I believe one of the advantages of endoscope surgery is we can preserve passage joint more effectively. He is 81 and have a severe degeneration, and his segment is already stabilized. So with the preservation of passage joint, we can decompress effectively.
Thank you.
Welcome, Dr. Park, to Delhi. I want to know whether you will remove the disc here if it is contained. Whether you will remove the disc in addition to the flavor. Yeah.
In this case.
I cannot find, on the MRI, I cannot find the existence of a disc, but I can make sure of the decompression, ligament flavum, and I will track the root and find is there any compression by the disc. I will make sure of decompression.
Thank you.
Case 2. Case 2. This is a case, second case in OT-3. This is Mr. Y who's a 25-year-old male who has presented with complaints of low backache since 3 months relating to bilateral lower limbs, left lower limb more than the right limb. And he has also complaints of numbness and tingling and weakness of the bilateral lower limbs since 3 months, and complaints of stiffness of bilateral lower limbs since 3 months. The patient doesn't have any bowel or bladder involvement, but he has a history of trauma due to ground level fall 3 months ago. The patient doesn't have any known comorbidities. On examination, on motor examination, the bulk is normal in upper limb and lower limb. The tone is increased in bilateral lower limbs. He has grade 2 spasticity in the right lower limb and grade 3 spasticity in the left lower limb. Power is 5/5 in the bilateral upper limbs and 4/5 in bilateral lower limbs. And the deep tendon reflexes are 3+ in bilateral ankle joint, knee jerk, and ankle jerk are 3+, and bilateral plantars are extensor. On MRI imaging, there's D9, D10 PIVD with ligamentum flavum hypertrophy with cord signal changes. So I'd like.
Yeah, this patient is thoracic compression T910. Okay, show me sagittal MRI. Okay, this is very good. So yesterday I watched my patient. His left side is spastic, and it increased the DTR. So and on CT, on the ventral compression, slightly ventral compression, and the posterior compression due to ossification or ligament problem. Today my plan is only posterior decompression with a bipolar endoscope surgery. I believe compared to microscope surgery, we are doing the endoscope surgery in the water base. During the drills, everybody have some experience. During drills, there is a lot of heat generation during bone drills. But I'm doing drills in the water, so there is no heat generation during drills. The heat which is generated during drill is transmitted to core, so it makes harmful effect, post-operative weakness of legs. But we can prevent the heat injury from the drill because I'm doing in the water mediate with the endoscope.
Any questions?
So what?
I'm sorry, sir. CT isn't uploaded.
CT is.
No, it isn't uploaded in the video.
So it's ossified, sir. It's a calcified disc. CT is not there, but it's calcified.
Professor Park?
Yes.
What is your take on ossified dura? How do you deal with it?
Ossified dura?
Yes.
Actually, several signs of ossification dura, but I think on MRI and CT there is no severe lesions, and I cannot make sure the CT. I cannot see the CT, so I don't know the existence of ossification of dura. But I believe it does not matter because I have my surgery is having drilling stage and the separation of ligament flavum stage, and I can remove the ossified ligament. Even there is a severe lesion, I believe I can treat it.
So you had mentioned that specifically for this case, you would need a diamond burr. That is a specific requirement.
Diamond burr. Usually my surgery drill out the laminar bone, especially inner cortical bone and the medullary bone with the remaining outer cortical bone. So left side laminotomy, nearly hemilaminotomy, and the contralateral sublaminoplasty, removing inner cortical bone and the inner medullary bone, and the remaining ligament flavum, and separate the ligament flavum from the bone, and take it out, the calcified ligament flavum.
Thank you.
Professor Park, any comments on localization? How you planning to localize the level?
Level.
Level, yes.
Yeah, you have double needle techniques. Usually I have L1 needle in one, and the other needle, another needle 9, 10 before operation. And double needles and make the levels, correct levels, and try to skin incisions.
Are you planning to use methylene blue for?
Oh yeah, if you have match blue, it's very helpful. Yeah, before skin incision, I would like to inject methylene blue on near the lateral recess, And during operation, with endoscope, I can make sure the methylene blue. We can believe there is a correct levels without additional X-ray check.
Anytime do you do pre-operative localization? Not intraop, in pre-operative.
Pre-operative when you make a SIAM, under the SIAM, L1 needles and T10 needles. Under T10 needles, inject the methylene blue there. Okay.
Hello, sir. Good morning. Good morning, sir. Sir, just want to know, as this is OLF, it will be more like stony hard than the other things. So do you think that a normal drill or diamond drill will work, or you will use the other sharp drill for this, or any experience of using a bone CUSA? Because it will be very stony hard as compared to the OLF. OLF would be very hard.
You mean
the OLF?
OLF. I don't know what.
Ossified ligaments and flavor. It will be very hard.
Ossified ligament for what? No. Ossified ligament flavum drilling is make a thinning. If the ossified ligament flavum, I like to make island. It means second ossified ligament flavum make island. It means I make a zone, compression zone, and normal zone, and safe zone. So at the compression zone, I cannot insert any kind of instrument, such as a punch or other things. A compression zone with drill, I make it island and lift up. Yeah.
Any use of bone CUSA in this type of cases, sir? Bone CUSA? Any
Just
bone
repeat the
CUSA, does it be helpful for this type of cases?
Bone CUSA.
Actually, I don't have, and I don't need for that, for the OLF removal. Actually, my clinical experience for bipolar OLF removal was 120 cases in our hospital. So I don't need for bone CUSA.
Thank you.
Thank you, Dr. Park. So rest of the case discussion will be done after the inauguration ceremony. Dr. Pauna.
So good morning, everyone. We would now proceed with the inauguration ceremony. I would first like to welcome the dignitaries over the dais. So may I now call upon the stage Professor M. Srinivas, sir. Professor Shashank S. Kale, sir. Professor Girijarat, sir. Professor Sharat Chandra, sir. Professor Shashank S. Kale, sir. Professor Girijarat, sir. Professor Sharat Chandra, sir. Professor Ashish Suri, sir. Professor Deepak Agarwal, sir. Professor Ashish Suri, sir. Professor Deepak Agarwal, sir. I would now like to invite the dignitaries for the lamp lighting and Saraswati Vandana. I would now like to invite the dignitaries for the lamp lighting and Saraswati Vandana. Thank you, sir. I would now like to invite Professor Deepak Agarwal, sir, Organizing Secretary of the workshop, for the welcome address.
Good morning to all of you and dignitaries on the dais, Professor Srinivas, Director AIIMS, Professor Gaikwad, Chief Neurosciences Center, Professor Kale, Head of Department of our Neurosurgery Department, Professor Sharat, Unit Head, and our esteemed foreign dignitaries, including Professor Kolosov and Professor Park, who are here with us to teach us. I thank each one of you for coming over for this event. I think Dr. Datta and Dr. Meena have worked very hard, along with Dr. Ramesh, Dr. Pankaj, to make this event a very educative one. Spine surgery is one of the happening specialities today, and we can see from the interest all across this nation that people are very interested specifically for minimally invasive and endoscopic spine surgery, and we plan to showcase the cutting edge of this speciality in the next few days. So I again welcome you. Thank you so much.
Thank you, sir. I would now call upon Professor Chandra, sir, co-chairman of the workshop, to address the gathering.
We plan to showcase the cutting edge of this speciality.
Honorable dignitaries on the dais, Director, sir, esteemed faculty both from national and international, and delegates. This has been our 10th year of this workshop, which started in a very small way in the seminar room, and then we shifted to the conference room, and today we are proud to say that we have more than 200 registrations. And this is, I think, the one of its only kind of spine workshop across the country, which shows the entire spectrum of spine surgeries. You go to some orthopedic oriented conference, you will see a lot of fixations, a lot of screws, there's no neurosurgical perspective. And if you go to any neurosurgical, there's less of scoliosis shown there. But over here, we are covering the entire spectrum of spine. We are going to operate 15 to 20 cases just in a matter of 3 days. And it's going to be definitely an academic feast. From that perspective, I congratulate Professor Deepak Agarwal, Dr. Rajesh Meena, Dr. Dattaraj for all their untiring efforts, and of course Dr. Pankaj Singh here. All the faculty have worked very hard to make this spine conference a very good success. And thank you once again for coming, and thank you Professor Srinivas once again for coming for the inaugural address. Dr. Rajesh Meena, Dr. Dattaraj for all their untiring efforts, and of course Dr. Pankaj
Thank you,
Singh
sir. May I now invite Professor Suri, sir, to address the audience.
Make this spine conference a very good success. And thank you once again for coming, and thank you Professor Srinivas once again for coming for the inaugural address.
Director, sir, Dr. Gaikwad, Dr. Kale, Dr. Sharad, Dr. Deepak, all my friends, dignitaries. It's a very proud moment for the department to have been organize this cadaver workshop plus live surgery workshop. Spine surgery, spine admissions constitute nearly 40% of our in-house admissions, both in the main department. We do around about 5,000 cases, surgeries overall in the neurosurgery department, in the main as well as the trauma combined. 40% is always spine as admissions. And it's very important for the resident training program, which is to build the skills, to learn the spectrum. And I would, though controversial, I'd make, since I've been given this chance to speak, I think 2 radical statements. Maybe there are a lot of difference of opinion, but I think it's important at this time. I think one, especially for the juniors and residents who are, if you're specializing in spine, think of the whole spectrum. Don't be only motivated by titanium addiction or some other addictions possible. Think of the whole spectrum. The congenital is there. There is pediatric spine. There's craniovertebral junction as well. There's degenerative spine, and there is scoliotic spine. So a lot of spectrum is there. So if you are specializing in spine, I think the whole spectrum needs attention. You'll be giving a lot of goodness to the specialty and a lot of goodness in the patient care. Second, more controversial. I personally feel that spine is a cage. It's like the skull and the brain. The relationship of the spine is ultimately, God has given us a spine to take care of the spinal cord and the nerve roots. Otherwise, the spine wouldn't have been just a biomechanic feeling for us to move around. There is a proper segmental distribution. So the main issue is, what is the main aim of spine, the whole of spine surgery? One is to give you the proper balance and the movement and the mobility, and that's fixed. The bony concept is there. Second is protect the nerves, the spinal cord and nerves, so that you restore or improve the neurological function. I personally feel that neurosurgeons should be in command of all spine surgery units. That is another statement. But I thank the organizers, Dr. Deepak Agarwal, Dr. Pankaj, and Dr. Dattaraj. He's been very enthusiastic and Rajesh Meena for a wonderful show. Thank you very much. I personally feel that neurosurgeons should be in command of all spine surgery units.
Thank you, sir. I would now request Professor Kale, sir, Head of Department Neurosurgery and Chairman of the workshop, to address the gathering.
Dr. Dattaraj, he's been very enthusiastic and Rajesh Meena for a wonderful show. Thank you very much.
Professor Srinivas, Director AIIMS, Professor Gaikwad, Head of the Department of Neuroradiology and Chief of Neurosciences Center, Professor Sharad Chandra, Professor Suri, Professor Deepak Agarwal, all my friends from all over the world who are here. Is Professor Visochi here? He's just come, okay. And Professor Kolasov, Professor Park, Dr. Raja Kumar, my friend from Pune. All of you are here. Welcome you all. Dr. Srinivas was asking me that why do you need to do this inauguration? You have already started, you keep on discussing. Apna kaam karo, if that's what he said. But there is something called tradition. And there is a very fine statement which says that well begun is half done. So this is the beginning. So you have to begin well. You have to begin well with all your seniors around you. And then only it is it's done well. Well, I'm sure we will do well in this workshop. It offers you cadaver experience, live surgery, case discussions. Tried to cover almost every aspect. That's Dr. Deepak Agarwal and his team. I'm not going to name individual. The whole department has been involved. All the faculty, all the residents, all the staff, they've worked very hard to put all this together. And I welcome you all to enjoy this feast for the next 3 days. The academic feast in the daytime and the other feast in the evening, like yesterday. So welcome you all once again and let us begin. Thank you. I welcome you all to enjoy this feast.
Thank you, sir. I would now invite our guest of honor, Professor Sailesh Gaikwad, sir, Head of Neuroradiology and Chief CN Center.
So welcome you all once again and let us begin. Thank you.
Respected Director, sir, Dr. Kale, Dr. Shara, Dr. Ashish, Dr. Deepak Agarwal, and I should specially mention names of Dr. Deepak Agarwal, Dattaraj, Pankaj, and the entire team, the entire department from neurosurgery, who have been working tirelessly over the last few weeks, and I've seen the enthusiasm amongst the youngsters to make this happen and take it to a next level. I'm very proud to say that this is the 12th annual spine workshop, and I like the format. Like first there is a cadaveric workshop followed by a live demonstration of the very complex cases. And to make this happen, I think they have gathered very doyens in the spine surgery who are coming from abroad, but also from within India. And I'm sure the scientific program will teach you a lot. So enjoy this gathering, enjoy the academic feast, the socio-cultural evenings in the night. And yes, I won't say that enjoy the weather in Delhi because this is monsoons now, but still I think you are in the comfort of the indoors. So thank you very much. Also from within India. And I'm sure the scientific program will teach you.
Thank you, sir. I would now request our chief guest, Professor Srinivas, sir, Director AIIMS New Delhi, to address the gathering.
And yes, I won't say that enjoy the weather in Delhi because this is monsoons now, but still I think you are in the comfort.
Thank you. Good morning, everybody.
Thank you very much.
Respected Professor Gaikwad, Professor Kale, all the dignitaries and the faculty from India and abroad, and special welcome to the people, Professor Kalsho and Professor Park, and all the delegates who have been here. I was just discussing with Professor Kale that, when we do newborns and the pediatric cases, whole abdomen is a very big one, and he was saying that you put 2 ports to the spine. Very exciting, I think. I'm sure we must give a big hand to the organizers who have done this. I think this is something which is a very important thing. Bringing the best of the people from all the parts and bringing them here and having an in sequence, the way it is being planned, from the cadaver to the 2-day extra clinical workshops. This will definitely inspire our youngsters. They definitely take up these techniques so that it becomes more minimally invasive, and then we carry forward. There should not be gap in what the entire world knows as the best practice or the new innovations, the surgical innovations, to our own students and the colleagues and the youngsters. That's something which I must commend the entire team, which has brought the best of the people here and taking into the things. And again, welcome you all to the AIIMS New Delhi and to the India, and then look forward that all the people who have come here will definitely carry forward this message and then practice and get connected with the people. You have the best of the people in the neurosurgery and the spine surgery here today in the audience. So get connected with them, continue to do that, and then propagate that, whatever you learn and see today, so that the benefits go on to the patients, so that it becomes more minimally invasive and complex cases are taken care. Otherwise, as people say that, that who should be operating, the best of the people should be operating. I think the best of the people are the neurosurgeons because they know not only the brain but the spine, but also the consequences of everything, Otherwise, we don't end up in giving the functionality to the things which are there. So once again, welcome to All India Institute of Medical Sciences, New Delhi, and then looking forward that the best of the demonstrations and your interactions, the clinical interactions will go a long way for all our patients in the country. Thank you very much. Otherwise, we don't end up in giving the functionality.
Thank you, sir. We would now like to felicitate the dignitaries on the dais with a bouquet.
Looking forward that the rest of the
Srinivas,
demonstrations
sir.
and your interactions, the clinical interactions will go a long way for all our patients in the country. Thank you very much.
Thank you, sir. We would now like to felicitate Professor Gaikwad, sir, with the bouquet. Srinivas, sir. Professor Kale, sir. Professor Chandra, sir. Professor Gaikwad, sir. Professor Suri, sir. Professor Kale, sir. Professor Deepak Agarwal, sir. Professor Chandra, sir. Thank you. Professor Suri, sir. So now we would like to felicitate our international as well as national invited faculties. So may I now request the dignitaries to felicitate our invited faculties with a plaque. Professor Park from Korea. So now we would like to felicitate our international as well as national invited faculties. So may I now request the dignitaries to felicitate our invited faculties with a plaque. Professor Park from Korea. Professor Massimiliano Visocci from Italy. Professor Massimiliano Visocci from Italy. Professor Kolasov from Russia. Professor Kolasov from Russia. Professor Raja Kumar Deshpande from Bangalore. Professor Raja Kumar Deshpande from Bangalore. Professor Sushil Patkar from Pune. Professor Sushil Patkar from Pune. Professor B.S. Sharma, sir. Professor B.S. Sharma, sir. Thank you, sir. Vote of thanks. I would now like to invite Dr. Dattaraj, sir, co-organizing secretary of the workshop, to present the vote of thanks.
Dear Director, sir, dear senior faculty members, and my dear friends, it's my privilege to give a vote of thanks to this August gathering. On behalf of all my colleagues, I express my hearty thanks to all my honorable guests and senior faculty members for joining this occasion and officially inaugurate this workshop. I express my special thanks to all my international guests, Dr. Park from South Korea, Dr. Massimiliano from Rome, Professor Sergei Kolezov from Russia, for taking time out from their busy schedule and joining us and making this as an academic feast. I'm also very much thankful to all my national faculty, Dr. Deshpande, Dr. Patkar, and our beloved Professor B.S. Sharma, sir, for gracing this occasion and making it very much interactive. I also extend my gratitude to all the delegates without whom this workshop is not possible. And your active participation since yesterday made this workshop phenomenal success. And thank you very much for joining in large numbers and being active all the day. This workshop of this magnitude cannot happen overnight. It requires month and month of the planning, and to make it of this magnitude, you require a good support. So I'm very much thankful to the spine of our department, Professor Kale sir, our senior faculty members, my dear colleagues, and our dynamic organizing secretary, Dr. Deepak Agrawal sir, to make all the efforts so that we make it a very good academic event and make it a successful one. So thank you very much, all my colleagues, to make it happen. Also, I extend my special thanks to all my senior faculty members and colleagues from Department of Neuroanesthesia, Neuroradiology, from Neurophysiology, whose support is paramount for conducting workshop like this, which requires some meticulous planning and teamwork to conduct a workshop of this operative cases. I also extend my special thanks to my support staff, my OT staff, my staff from the organizing team, which worked very hard to make this workshop a successful one. And I thanks to all the sponsors for their generous academic sponsorship for making this event possible. With this, I conclude this ceremony, and we can join for the breakfast in the foyer. Very hard to make this workshop a successful one. Yeah. On the first floor. I thanks to all the sponsors for their generous academic sponsorship for making this event possible. With this, I conclude this.
Breakfast is on first floor.
For the breakfast in the foyer. Yeah. On the first floor.
Breakfast is on first floor.
Welcome back, everyone. Now we would like to continue with our case discussions about how I do it. May I invite Dr. Prakash to discuss OT-4 case, which is to be operated by Professor P.S. Chandra, sir.
Good morning. I'm going to be presenting the OT-4 case. So patient is presented with complaints of headache for 25 days, which was holocranial with photophobia and transient visual obscuration for 15 to 20 days. He had left-sided weakness of upper limb and lower limb and dysarthria for 15 days. The presentation was that of a posterior circulation stroke. On examination, he was E4, E5, M6 with pupils reactive. He had intact extraocular movements and higher mental functions. He had intact power, but there were cerebellar signs and ataxia present. So this is the NCCT head on presentation. So it's showing bilateral posterior circulation territory hypodensities, and this is the NCCT head. Once the symptoms are improved, and the CT is also showing improvement in the hyperdensities. So on further evaluation, dynamic X-ray was done, which is showing a dynamic AAD with basilar invagination. This is the plain CT CVJ, which is showing AAD with basilar invagination. And this is the coronal view of the same, which is showing a vertical joint with a pseudojoint formation. And this is the MRI, which is showing compression at the CVJ with a component of tonsillar herniation with crowding of the foramen magnum. This is the CT angio of the case.
What does the CT angio show? Please tell.
So the CT angio is showing codominant vertebral arteries with almost normal course. Now request Chandra sir to come for discussing the plan.
So it's not very unusual for CV junctions to present with posterior circulation stroke. We published several papers on it. So as you can see here, the C1 arch is fused, and there is a fusion of C2 and 3. So, and one finding which you missed is that the vertebral artery is straight on the right C1, C2 joint. And there is also evidence of dissection, narrowing of one side vertebral artery because of the dissection. So these are challenging cases. Now, what we do normally here is we do a posterior approach, and in this case we will mobilize the vertebral artery on the right side, which shouldn't be too difficult because it's on the medial side of the joint. I will rotate it and show you. So you can see the vertebral artery. This is on the right side of the joint, and it's on the right joint. So we need to carefully dissect it and then mobilize it, and we put a spacer. And then we do the technique of DCR. We reduce both the BI and AD. We actually had another case. It was much more severe, but unfortunately the patient did not give consent. And you can see this side vertebral artery is narrow. Definitely there is evidence of dissection on this side. And then once we do it, I prefer to do an occipital C2, C3 fusion for a couple of reasons. A, to put a C1 screw in this location will be itself a challenge. It's not that we cannot do it, we can do it. Secondly, if we do it, there is going to be crowding of the vertebral artery, and again, it could lead to compression and presentation of a stroke again, which we want to avoid. And thirdly, it doesn't make a difference because the C1 is already fused. So in which case, it doesn't make a difference whether you put the screw on C1 or on the occiput. And I know some people are against occipital screws, but initially even we were cautious. But we have now done over 500 cases. We have not seen a single case of occipital screw pull-out. We have seen other complications, but definitely not occipital screw pull-outs. So bottom line is occipital screws are actually very stable. So it's not a very severe BI in AD. It of course can be done the way Dr. Patkar would do. You can do it anteriorly. But I don't have the experience of doing anteriorly. But we're also very comfortable doing it from the posterior part, which leads to very solid rigid fusion. So we'll prefer to do a occipital C2 and C3 fusion. So whenever we do a posterior fusion, we do a 3-point fixation. Now movements, neck movements, one would argue that you're going to limit your neck movements by doing a 3-point fixation. So that's not true, because whenever there is a CV junction anomaly, the patient comes like this. So there is always a severe degree of spasm. So it doesn't mean that if you fix 3 levels, his neck movements are going to be totally restricted. It's not like that. In fact, the spasm is going to be relieved and the neck movements will improve. And then I always say that CV junction is like a complex spine. It's like a very complex deformity. So one should always do at least a slightly longer segmental fusion in order to have a very good rigid fusion. So that's one point in favor of the doing DCR technique. So once we put a spacer, we will reduce it. We will reduce both the AD as well as the BI by using the universal reducer, or I can even demonstrate it with a straightforward wire and show you how the reduction happens. This is not such a complex case. What happens in severe basilar invagination and AD is there is a retrolisthesis. So the C2 not only goes backward and causes compression of the spinal cord, but it also moves backward. So just by a straightforward reduction doesn't correct the deformity completely. So you need to push the C2 forward. So that can only be done using the universal reducer that we have devised. But this is a straightforward. You can even reduce it with using a simple wire. That shouldn't be an issue. So rest of the techniques, we will show it to you when we are demonstrating it. So if there are any questions or any comments, we can take it up. Yes, Dr. Patkar.
Thank you, Professor Sarath. I agree with you that it's very important just not getting the C2 down. The tilt also has to be corrected, and otherwise just putting the distractor just brings the odontoid down and gets the compression from cervicomedullary to higher cervical. One interesting thing, can you go back to the angiogram in the posterior aspect, in the CT angio, where you showed that the artery is on the medial side. Yeah. Whenever there is a big loop, it is not frightening. Only when it's on the other side, it is straight. That is the time I get worried, because there is lesser place to manipulate it. If there is a nice loop, this kind of artery can be manipulated well. It is not going to create a lot of trouble while operating. But if the situation is tight and it is straight, on the other side, it is just straight. So those that is the time I'm worried when the artery is straight, that while trying to manipulate, there is very little play left for me. What are your comments about that?
That is very true. We do CT angios for every case. Fortunately, in most of the cases, you have a very good redundant artery.
Yeah.
Because the artery has to be redundant, otherwise your neck movements won't be possible. So it passes through a plexus of veins, which provides a very nice cushion for it, and there is a nice redundant loop, which allows you 90 degrees rotation without any evidence, without causing any dissection. So that's the purpose of it. So most of the cases, we find a nice redundant loop, and we also found that we can increase the spacer. Even severe BI, we have gone up to 22 millimeters of spacer height. We have reduced very severe BIs, and that has not led to any problems. But we do it gradually. We don't do it at one stage. We start with 4 mm, take it out, put 6 mm, 8 mm, slowly we jack it up.
I think nobody in the world must have done 22 mm apart from you.
No,
See, on this side, the artery is so straight that if anything more than 6 or 7 mm, the artery is going to get stretched.
That is right. So this side we have to be very careful. It's already dissection is there.
Yeah.
But it's not on the joint, so when we mobilize the joint, it should be fine. Plus the BI is not much. So with just 5 or 6 millimeters, we should be able to reduce it. So when we give a spacer, when we produce a spacer and produce compression forces between the C2 and OC1, what happens, not only the BI gets corrected, but the AAD also gets corrected to a great extent. And when it gets corrected, the residual BI also gets corrected. Because a part of BI is also because of the tilt.
This is a very important point which is saying if you take the spine in your hand and you tilt the spinous process of C2 towards cranially, towards the atlas, any atlantoaxial dislocation is going to get corrected. And if you see the more severe atlantoaxial dislocations, you will always find that you just go to the x-rays, the C2 spinous process is very much angulated as compared to the atlas. So the concept which is proposing is to push it upwards, automatically the AAD is going to get corrected and the BI is also going to get corrected. Thank you, Professor.
Sharat, Professor, I just wanted to ask a question. I think, I'm not sure where the dissection is, on the right side or on the left side?
It's on the left side. Yeah. You can
Are
see
you
some
sure?
irregularity here.
No, but you see
Here
in the
also there is an
angio,
arrowing.
if you see on the angio, it is the right artery which is narrowed and dissected. Is it right? That's the right one? or
This I
left
think
one?
is the left or right, I don't know. I think this is the left.
I would like to say.
So there is narrowing here, and this should be right and this should be left. So it corresponds to the 3D angio. But yes, I will check it. So I was under impression that this is left, but I will check
the
it on the angio
I think
fields.
the projection, for example, if you see the middle image, and in front there is an A and then there is a L. That's on the left side. So that means I was thinking you are on the right side. So I'm not sure where the projection is. So depending on that, you should decide which of the arteries is causing the dissection.
So like when it's rotated, this now looks to be the left. But yes, I will check it. But I'm more or less certain it's on the left side.
That's my confusion in the picture.
But I'm more or less certain it's on the left side, this one. On the right side and left is on the left side. This from the back. So left is on the left and right is on the
And
right.
so the curvature of the artery, which is only there on the right side, on the CT angio, that corresponds to the right on that side. The curvature is also seen.
Which one, Deepak?
So the same curvature of the vertebral artery.
On the left or right?
On the right on the CT angio,
Mhm.
here.
Yeah. So this curvature, let me see again. Yeah, you're right. So this redundant loop is seen on the CT angio on the right side. So we would expect this redundant loop to be on the right side. On the left side. So all the more reason we have to be very careful with the right side.
So regarding the orientation of the joints, go to the coronal things. In some of your papers, you have mentioned about the existence of the pseudo joints
Yeah,
and how
so in
you
this there is no pseudo
change
joint.
and
Let
change
us
it
go to the
and change the orientation of the joints.
Let us see the sagittal section. So the coronal tilt is good. So if I go to the sagittal, so you see the joints are straight. It's only that the C2 joint there is a backward retrolisthesis, which is expected. I mean this amount of, but otherwise it's more or less flat. If you look at sagittal inclination, it's more or less equivalent to 90 degrees.
So the question
So in
is,
pseudo joint, what happens is you will find the true joint almost vertical. So when it becomes vertical, the spinal column kind of slides backwards and then rests on the posterior superior surface of the pars of the C1. That is where it forms the pseudo joint. Can go to the other side also now. That's the dense. So again here, that side also you find, yeah, I'll just run it again. So one side is okay. You go on the other side. So other side also very straightforward. So surgery itself should be straightforward. I don't expect any issues. Only thing is, we should decompress the foramen magnum very well. We should mobilize the joints very well. We should be very careful of the vertebral, very careful handling of the vertebral artery. And as soon as surgery is over, patients should be started on blood thinners from day 1 post-op.
So, sir, in case you have a vertical joint with a pseudo joint, do you reshape the joints or what is your strategy?
Yes. So reshaping is done in almost all the joints. So in this case also we will be doing some degree of reshaping. But that becomes quite a lot, quite significant when you have a pseudo joint. So in the pseudo joint, what now we do is we drill with a diamond drill, we make a lot of space, and then we go right up to the true joint and drill the vertical part. And then the trick is to disarticulate. So when you disarticulate, the whole thing becomes totally loose. So only then you need to put the space. You should put the spacers. So before you disarticulate, if you put in the spacers, then you're, if it's very tight, then you may end up having problems. So it's very important to work on the joints, release it, drill it nicely with a diamond drill, and then disarticulate. It has to become totally loose. And then when you put spacer and when you reduce it, then it's going to reduce completely.
Yeah, I agree with you. To treat any deformity and to correct deformity, you have to create additional instability. Only if you create additional instability, then you can treat. Now, another thing very interesting in this case is just show the sagittal and parasagittal cuts of the joint. See, this joint, there is no dislocation. The facet, just go back to that joint in the sagittal image.
Yeah, but the other joint, there is some dislocation.
Yeah, see, the other joint, there is dislocation. Now, when I still do posterior surgery. I feel that this kind of case, you can also push and do posterior transarticular screw. And that can also be an option because you see the facet and the pars on one side is adequately thick to pass a transarticular screw. But especially when you're going to do distraction, then it becomes difficult to pass a transarticular screw. So there are various options. Now I want to know your comments on compression is not the issue. Stabilization is the issue. Stabilize it in situ. Dr. Goyal has stopped doing any decompression, any distraction. He says stabilize them as they are and you will see the magic after the operation. What is your opinion?
Fortunately, Dr. Goyal is not here. So let's not talk behind his back.
No, not behind his back. I want to know your, what do you feel? I'm not talking behind his back.
So my viewpoint stays constant. It has not changed over the past 10 years. We need to disarticulate the joint, we need to prepare the joints, we need to put spacers there, and we have to correct the deformity. So unless we correct the deformity, the compression is not going to be released. And similarly, posterior, also when we drill the posterior lip, we find a lot of dural bands. So those dural bands have to be released. So once we release, the dura starts pulsating. So this kind of release is important. And we see really complex cases. This is one of the simpler cases.
Yeah, I know.
We had a very complex case posted. I was really excited to do that. The patient refused just today morning. Today morning, I think, because it was a workshop, there has been too much of counseling. So suddenly the patient's attendant realized something is wrong. So he said, no, I don't. So that's why it got cancelled. But that was a very severe case. But the philosophy remains the same. Prepare the joints, disarticulate the joints, put adequate level of spacers, provide, decompress the foramen magnum, remove the dural bands, do a DCR technique, which will lead to perfect reduction. But in this case, yes, in this case, I know you have an expertise to do it from anterior part. We'll be very happy to learn that.
No, I was only thinking Dr. Goyal's transition and his belief now that I've been his great fan. That whether because he says that this deformity is long-standing. And what is causing the worsening is the repeated instability. Stop the instability and that is enough. What you are doing is surgical overkill. When he himself did all these things and now he's proposing that, he's going all over the world saying that, and there are many people who believe it. What is your
now there is, he is right to some extent, but from the degree of instability we have moved to an irreversible stage. where compression is also becoming an issue. So perhaps it started with instability with not so much of compression. So maybe in this case, if you do an in situ, maybe you'll still get away. But in most of the cases, it has gone already over the cliff. It's already gone into a stage of irreversible compression. So you need to relieve the compression, otherwise it's not going to improve.
So my opinion on this is that you can't have one rule for all, for any listhesis for that matter. If we extrapolate it to lumbar listhesis, there are so many cases of lumbar listhesis where you may not require decompression, you fix it, it automatically gets decompressed and the patient is neurologically also good. But then there are cases where there is significant compression, there is canal stenosis, and there is lumbar listhesis. Similarly in CVJ also, sir. At times you may not have compression. There you may not require decompression, but then there are so many cases, complex, long-standing cases where we see that there is an element of compression which requires decompression.
But I think that many ways to skin a cat, says in United States, and I think that this location is the reason of many dysfunctions, but sometimes this location doesn't affect neurological function at all. For instance, the concept of Atul Goel that 100% of Chiari malformation should be fixed by posterior approach can be faced with by some personal experience. In my personal experience, I have a case I will show this evening of children harboring basilar invagination and Chiari malformation. The patient was decompressed totally by transoral approach with total removal of the clivus and the odontoid. In 9 months, clivus and odontoid growed up again, and the patient harboring craniovertebral junction instrumentation and fusion produced again Chiari malformation. So fixation is not the cure of Chiari, and the subject is still matter of debate. Also, according to the age of the patient, fractures like that can be treated conservatively without any treatment, any fixation, since normal, natural, elderly arthrodesis produce a natural instrumentation without instrumentation. And so I think that it is still matter of debate. Anyway, I agree with your personal observation. You already showed us in Mumbai, if I don't remember bad, and I appreciated so much even 4 weeks ago. Thank you.
Thank you.
One,
Thank
one
you.
question. Sir, one question. Yeah, sir,
Yeah.
here. Dr. Sharad.
Yeah, please. I cannot see you.
I'm
Where
here.
are you?
I'm here waving,
Yeah.
waving my hand.
Yeah, please.
So there is a C0, C1 assimilation and C2, C3 fusion. So we are planning to do a subocciput C2, C3 fusion because C2, C3 are fused. Okay. So this is why we are doing a C2, C3 fusion. Had the C2, C3 were not fused, we would have done the same thing, or
No. We always do a 3-point fixation.
Okay, good.
So in this case, I may go one step below. If the C2-3 is fused, I may even put it on C4. But let me see. The reason is a 2-point fixation, I have done several of them. But somehow they don't have that much of stability as a 3-point fixation. And sometimes the shear forces are very, very strong here. And particularly when I put an occipital screw and then I put a C2 par screw, you know, the shearing forces could be very high. But I will decide it. On table, I will decide and see.
So where we are going to, like where we are planning to put the screws on C2, C3, like parts, pedicle, or?
So yeah, definitely in the occiput, then C2 pars, and then.
Sir, can we see the diameter of the parts available to us?
I'll show you. Introp, I'll show
in
you.
In the CT scan?
Here on the CT scan.
space available in the pars on one side.
Sagittal.
Yes, sir. This one only.
This one.
Yeah. Please come. Yeah. There is
Yeah, this
hardly any
one.
space available.
You can put a screw directly into the subfacetal region. No? I don't
Yeah,
put it in
can put it in a subfacetal region, or you can put it in C3 also.
And
So we'll
my second question is, there is a good space available in the lamina. So are we like, we don't feel comfortable, or is there any problem with putting laminar screws?
laminar screws I used to put. That's absolutely another option. One of the issues I found with laminar screws is, it pokes out of the skin. So if the patient is quite emaciated and all that, there's always a chance of skin adhesions because it's quite on the surface. And the other thing is, it holds well, but sometimes it's very difficult to contour the rod. And then after that, we have started doing a 3-point fixation. Since then, we have stopped doing laminar screws, but we have done a lot of laminar screws. It's
So
a good option.
To make it a 3-point fixation, we need to put subocciput, C2, C3 is 1 now, and then C4.
Most probably, I will do occiput, C3, maybe C4. Let me see. If there is good mobility between C3 and C4, I'm worried that you could end up getting an end plate disease between C3 and C4. Then we may have to fuse C4. So intra-op, I will decide that. Yes.
We are distracting the joints, packing them with the bone graft. And why we don't just go with along with that occipito C2 wiring, so that to avoid further going distal, because it is a child. Even ultimately the bony union will take place. So why it is not a first option to consider?
So you are suggesting that we can put a spacer with an occipito C2 wiring, isn't it?
Yeah.
So spacer in C2 and done.
With the decompression and everything.
Yeah.
And
See, I have put hundreds.
Atlas cables they are also very tensile strength is also high.
So I have put hundreds of Steinman pin wiring and all. I've done hundreds of these cases initially. The problem with wiring is that after some time the wiring becomes loose. So you need to.
But by that time the bone union will
I'm coming to that. So you need some kind of a solid option for bone fusion. So as a result, you have to also immobilize the patient for a longer time on a collar. That's one of the major disadvantages. So maybe for 6 months, 7 months, still the bony fusion starts happening, which you don't require. If you put a screw, you don't require that degree of immobilization on a collar. That's one point. Then second point is the wiring provides you only a compression force. It doesn't provide you a fixation in all the directions. That is another disadvantage while the wiring may fail much more earlier. So let us say if the wiring goes through the occiput or eats through the bone because of some reason, then it's going to become loose. And this thing, it has to be solidly immobilized. So that thing doesn't work with wiring. So saying that, I have never put wiring wherever I put a spacer. I've never done that. Maybe it will work, I don't know. Maybe we could study on cadavers and see if it's working. I'm quite open to that, but I have not done it. I've not done it because of, this was my thinking why I said, because I've seen a lot of wires failing. So I put lots of galleys, galleys used to, unless you provide them collar for 1 year, a galleys fusion is going to fail. That's what we have seen.
But if we are packing with the bones, and by your logic,
Yeah, compressing.
it
We have
will
done that.
compress
We have
and,
done that.
yeah.
I've
So
done
it
that.
will even pull the retroverted odontoid anteriorly also. Because
Yeah, I agree. We have done that. Maybe your success has been much better, I don't know. I've done hundreds of cases. I've seen galleys failing in a significant number of cases. So that's where I stopped doing galleys. I switched over to C1, C2. I initially did transarticular. Transarticular, the problem is you have to really go down very, very inferior. You have to make an opening here. And then when you're pushing the screw, you have to ensure that you purchase a very significant portion of C1. So often what happens if you're not, if it doesn't have a right degree of angle, it will just push the C1. Or it could purchase a small portion of C1. And again, that's liable to fail. So C1, C2 is an excellent. You do it 15 minutes, it's over. So we have done all this. We have gone through it, seen that, been there, not just few cases, hundreds of cases.
Bone grafting and fusion always has to be along the line of weight transmission. If it is somewhere behind, that bone graft, even if it fuses, it's not going to stop rotation. Whatever you do, you have to try to get a fusion across the joint, and if you're not getting that, anything short of that is, I think, asking for
That's one big issue with wiring. Wiring is the rotational is very, very poor. That's the reason you need to put them on collar even for 1 year, till the entire bone fuses. That's the main issue. So, any more questions? So before I conclude, Professor Kale was here. So we see a lot of our alumni here. So I'd like to make a general announcement. We are having a Golden Jubilee get-together on 1st and 2nd of March, along with the February Micro-Neurosurgery Workshop. It's an open invitation to all of you, all the alumni, to come back to home. This is your home. So we will send you invitations definitely. But when you come to home, you don't require invitations. So looking forward for all of you to participate wholeheartedly in this upcoming event. So thank you very much.
Can we have OTs? Any OT? What is going on? So, I mean, for today's, we have 4 OT running on 4 corner of this hall. They will be relayed continuously there. I mean, if you are sitting there, you will be watching that OR. So, we'll label the ORs and let you know. So, OR 1, 2, 3, 4. And in the center, there will be the main OR, which you want to discuss, you want to see, or something action is happening there. So, this is one thing. In morning sessions and in afternoon session, we have designed some faculty in charges, moderators. You are all here, sitting here, you know your role, right? So take a discussion forward. If you want to discuss something, take those roles and bring it to the center point. So OR 1, 2, 3, 4, there are 3 faculty each for morning session and 3 faculty each for afternoon session for each OR. So just, this is for your information again. So can we have a OR, main OR? Okay. Yeah, OT1. Dr. Pankaj.
Are you ready? Hello?
Yeah, Dr. College, we are with you.
Yeah. Can you hear me? I am Park, Dr. Park.
Yeah, we can hear you.
Yes, yes. We are preparing very well. Today. Hello?
Yes, Dr.
Can I talk about my surgery?
Yes, please.
Yes. Hello, everyone. It is my great honor to have live surgery in front of you and this wonderful hospital. So today I want to show you how to have radiation-free ULVD means unilateral laminotomy with a bilateral decompression. So, and how to complete the bipolar endoscopic surgery. Actually, the endoscope is 4K. The resolution of the endoscope is really 4K. And nowadays, we also have experience for 3D endoscope, also possible. And we are trying for the interval from decompression with the endoscope, from decompression to the interbody fusion, including decompression, including cervical and thoracic, and the interbody fusion, and intradural from regular tumor removal. We can do it with a bipolar endoscopic surgery. The big difference between unipolar and bipolar is bipolar is bipolar has two-fold. Two-fold means two skin incision. So left side skin incision we can insert endoscope, and right side skin incision we can insert instrument such as drills, punches, other things. So there are freedom between endoscope and instrument. It is a very big advantage compared to unipolar. As you know, unipolar has only one house, one channel. With the same channel, endoscope and instrument have to move with the same channel. It is very inconvenient. But bipolar, there are independency between endoscope and instrument. So that is why it is so handy and so easy and so safe. So and the most important thing for this surgery is maintenance of fluid movement. It means if you maintain the movement of fluid is make clean your surgical field with washout of bloody water and bone debris. Other development is self washout because there is a movement of fluid. So most biggest difference compared to microscope surgery. Microscope surgery is air-based surgery, but this is a automated surgery. So the pressure on the surgical field is transmitted to the intraventricular brain. So if your pressure of surgical field, the press on your surgical field is too high, it can be transmitted. It can be transmitted intracranial. So you have to be careful. The problem of intracranial problem. The best way to prevent the increasing the press is maintaining the outflow. If you have any question to me, please let me know. Hello?
Yes, Dr. Park.
Can you hear me?
Yes, we can hear you.
Yeah, and can you understand my talk?
Yes, somewhat. The question is, what is the pressure you will be using? Yesterday, I think you showed us.
Yes.
So,
because we are also neurosurgeon, so we know very well which is a normal intraventricular pressure, intracranial pressure. Actually, normal intracranial pressure is 5 to 15 millimeter Hg. So your press for the operating period, the press for operation period also not exceed than 15 millimeter Hg. So how the maintaining good press is maintaining good outflow. So if your outflow is good, your surgical field must be clean. If your outflow is not good, the whole body you cannot see your anatomy. So you can see your anatomy clearly. It means your outflow is good, and don't worry about intracranial ICP problems.
can we have the imaging in the PIP?
Okay. Yes. Okay. Yeah, you can see the website, the cytal MRI. That's the MRI. You can see the severe compression of the sarcophagus on L4-5 levels. Okay. Here is the L4-5 levels. And also we can see here, actual view, very severe.
Yes.
Severe spinal canal stenosis, serious grade D, okay? And okay, very good. Maybe it's impossible. Is it okay? Okay. Let me explain this one. Yeah, we know very well, here is the L4-5 interlaminar space.
Yes.
We know very well, here is the iliac crest, okay? You can palpate the interspinous area. you have to palpate the midline and the interspinous area. I mean, here is the interspinous, 4-5 interspinous area, 3-4, no, sorry, even 4-5 interspinous area, 3-4 interspinous area. And I can draw here, so here. So I'm marking here, and you have to know. Here is the most important. Here is the most important things. Please focus on me. Everyone be quiet. Sorry. I'm explaining about
Yes, we are listening.
the most important thing is the location for the working port, skin incision. You have to learn. And the best skin incision is lateral recess. Because the lateral recess is the most deepest area and the most dangerous area. So your skin incision always include lateral recess. So there are two types of skin incision. One is vertical, the other one is vertical, and the other is transverse. I like to have transverse skin incision on the lateral recess. Lateral recess means upper one-third of pedicle. On lateral view. Your needle, T1 needle is located upper one-third of pedicle, distal pedicle, low pedicle. And nearly, middle part of here, pedicle, that is the best location for the needle markings. And then you can make a skin incision from the midline to the lateral like this. From the midline to the lateral over the lateral recess, about 1.5 cm. That is the best location for a working port. Working port means the skin incision for the instrument. And the other one is for the skin incision for the endoscope. Usually from here about 2 cm cranial, because I am a right-hand surgeon, so standing left side is best, very good, more good. Also, so from here is a skin incision for the working port, and cranially 2 cm above, you can make another skin incision for the endoscope. So for the bipolar surgeons, standing left side, if you are right-hand surgeon, you have to try to stand the left side because of the endless of drillings. So left side standing is much more easier compared to right side standing. So I'm talking about the location for the skin incision. I will summarize it again, and I'll show you. Welcome. Okay, everybody, move, be careful, don't talk away, I'm going. Okay, hello everyone. I want to explain my surgery. Now I am palpating iliac cluster. You can palpate iliac cluster roughly like this. And I can palpate the interspinous area here. Pen, marking pen. No, too thick. No, it's okay. Yeah, after palpating iliac cluster, and I am just before I palpate the interspinous area, and I can palpate another interspinous area.
Camera view de den.
Yeah, here is the midline. Can you see? And you can, roughly I can here. So
OT-3 camera view.
Come close. So I believe here is a profile interspinous interlaminar area maybe. So we can from here I can. Okay, come here. Okay, and then we can make a needles. Yeah, here is the interspinous area, just laterally here. Okay, and then gentle touch, just like acupuncture. Careful and touching the like this, and try to palpate the bony prominence like this, and then try to eat, yeah, like this, okay. I can feel some bony from it here, and then we can inject small. Okay, it's bleeding. Okay. No problem. Okay. Siam also not. Okay. No. I don't like Siam. It is. I need another one. Okay. Another needle, please. Don't worry. No, give me. 왜 피가 니들이 너무 큰 모양인데 작은 니들 없나? Okay, it's okay. No. Okay. Let's check. Siam, please. Okay, Siam. X-ray, please. Okay, move.
सियाम को पीआईपी में कर लेना.
Oh, AP, I need it, yeah.
कैमरा को पीआईपी में रखो. OT-3.
सर OT-3 में सियाम में आउटपुट नहीं है सर, वो डायरेक्ट कैमरे से.
हाँ तो एक चीज पीआईपी में तो रखो, कैमरा को और सियाम को एक ही चीज आएगी.
ये सर.
Lateral and AP. Lateral and AP, okay. Okay. Check lateral, okay. Only lateral, please. Yeah. We are checking lateral view.
Okay sir, okay.
Yeah, with X-ray, we are checking lateral view, and I want to make sure the location of the needles. Oh, no. Check again. Show me my needle correctly. Yeah, I think I wanna. No, sorry, move back. Sorry, 1 second. Move. Sorry. Very needles. Show me a pedicle. My needle is upper 1/3 of pedicle. Show, yeah. Camera. Please focus on lateral view.
We are seeing, sir.
Can you
Yes,
see?
we can see.
Yeah, it's right. Can you see? Yeah.
Yes.
So on the lateral view, the best, be quiet. Sorry, I have to focus. Everybody be quiet. Look at me. On the needle is toward one side of the pedicle, L5 pedicle.
Yes.
That is the best location for our skin incisions. Everybody be quiet, okay? And move back. Actually, it is enough. It is enough for skin incisions. Do you understand? So I don't need X-ray. No more. Okay?
पेशेंट पे फोकस कर लो OT3.
Okay. Please remember, on the lateral view, distal pedicle. Remember, upper one third of distal pedicle. That is the best location. Usually there is a lateral recess. So and after bone touch, we can insert the maxillary below here, but there are some bleedings. So I don't like to put this one, and only I try to. They're very bloody. I don't know. I don't know. This patient has a very easily bleeding. I don't know. So I want to recommend to anesthesia systolic press. Maintain systolic press 90, sorry. Nearly. Because easily bleeding. I don't know why. Okay? Just before, sorry, take it down, please. Very easily bleeding. I don't know. Take it down.
Dr. Park, what did you just inject?
Yeah, just before I injected the methylene blue. During my operation, I can find the methylene blue. It means our array is correct. So from the midline to the laterally, about 1.5 cm, I want to make skin incision for a transverse skin incision. Everybody be careful, everybody be quiet, if possible, be quiet. And from the midline to the laterally, I'm making skin incision. This skin incision must include fascia, because you have to cut the fascia. Fascia prevent the outflow, movement of fluid. So cutting the fascia is very important. And now I have a balloon tear. This is a balloon tear. I can palpate. This is a spinous process. I can dissect like this and move to the more deeply. Here is the intracranial space. So just like this, touching the spinous process firstly, and just a G line, make a G line like this, and move to the more deeply, and then you can palpate the intracranial space. I can palpate the intracranial space here. So with this angle, we can palpate the distal margin of the L4 lamina and intracranial space
Dr.
here.
Park, can you just orient us cranial and caudal?
Yes, sir. Left side, because I am a right-hand surgeon, so left side is the brain.
Yes.
Right side is the leg. And I'm standing only left side. You can try. This one. I'm palpating. Yeah, you try. You can palpate the intracranial space. Okay. Lower lamina between upper lamina, lower lamina. We call here intracranial space. Okay. Can you feel it? Click. Okay. That is intracranial space. Do you understand? Intracranial space. So because this is a live surgery, to make sure the levels, usually I cannot check the CM again, X-ray again, but this is a live surgery. So I want to make sure the levels again. So be careful. X-ray again. Do you understand? Because this is a live surgery, so I will check the level epilateral again. back, back, back. No, more back, more back. No, more back. Yeah, just before I put the handle, next handle into the interlinear space. I'm making sure the location of the tips, it must be located midline and interlinear space. Check.
Dr. Park,
Yes.
I have one question. If there's a disc herniation on the right side, still would you stand on the left side of the patient and operate?
Yeah, usually.
Or you prefer to stand on the
Yes,
right side?
I call it contralateral approach.
Okay.
Yes.
What is the size of the incision that you have put now?
1.5 cm for the water.
Away from the midline.
Shoot again. AP again. Yeah, AP. You can see there is interlaminar, profile interlaminar space, AP dojo. So 100%, here is your profile interlaminar space. Can you check the AP X-ray?
The incision is put 1.5 centimeters away from the midline.
No, from the midline to the laterally, transverse skin incision. The length of the skin incision is 1.5 cm.
Okay.
I can understand. Okay. Please, AP like this. Why is it so difficult? I cannot understand. Is it radiologist? No? I'm checking. It's only for make sure the levels. Okay.
Can we just rotate through the wards?
Okay. Please focus it. Okay. It's 4-5. Okay. Move back. I don't need more. Okay. I don't need X-ray more. So. Okay. Yeah. You can go out. X-ray. Okay. Okay. Okay, hello everyone. I want to continue my talk. So everyone be quiet. So please be quiet for me. So this needle, you can see this needle is located interlaminar space. The lamina between L4 and L4 lamina. Okay. So I call this is a working port. So with the balloon to T, we can dissect muscles from the lamina. You have to know there is no attachment between muscles and lamina. There is only muscle and lamina. There is only pen nail, no attachment. So only separation of muscles from the lamina. I am palpating interlaminar space and palpating medial wall facet joint here. Also, I can palpate the distal lamina, L5 lamina, L4 lamina, interlaminar space. The most important thing is this angle. You have to remember this angle. When you start your drillings, you have to start these angles. If you are starting, when you start your like this angle, you have a mislevel, okay? And if you have this angle, it also mislevel. So you are drilling should start this angle because here is a spinolaminar junctions. And 드라이까지 오나, 드라이까지 뭐, 드라이까지 올라, 오늘 터치요. Okay, and we need another skin incision for the endoscope. So usually, cranially, 2 cm above. I can palpate above interspinous area here. Here is usually best place for another skin incision for the endoscope. So I'm making another skin incisions. Usually this is for the endoscope. So you need 0.7 cm, 7 millimeter. 7 millimeter is enough for us. So make it, including fascia, like this. And then put it toward the lamina, toward the midline, toward the spinous process, and toward the lamina. You can palpate the lamina bone here, try it. You can palpate the lamina bone, so you have to make a triangulation on the lamina bone. This is a muscles. Why so many talks? Please tell me, talk, okay? So, if you make your triangulation in the muscles, it is very difficult to make a triangulation. So my talk is always try to make a triangulation on the lamina, not muscles. I mean, we call this is a triangulation. This triangulation is always on the lamina bone. Do you see? It is a very important point for our surgeries. So you can make triangulation on the lamina bones. So you can feel that like this. You can feel the metal. Yeah. Can you see? Yeah. Okay. For education. Okay. No. I told you, touch the lamina, not muscle. Okay, this angles. Okay, and you can feel the bone like this. Okay, for education, I want to show you the X-ray. Okay, come in. Yeah, show X-ray again. Be careful, everybody.
Can we shift to OT-4?
Yes. This is only for the audience.
OT-1 you are connected, sir. OT-1 main screen.
OT-1, what is going on? Scoliosis surgery. Who's assisting in OT-1?
We have just started the incision, sir.
Okay. Your voice is coming very low. Okay, now.
So incision is grafting something. Yeah. And started surgery.
Okay, Dr. Kalas. Shift to OT-4. OT-4.
Yes, sir. OT-4 you are connected. पवन जी माइक लगा दीजिए.
OT-4, anybody?
Dr. P.S. Chandra, sir.
So we have just given the incision there, OT-4. Come back to OT.
OT-3, sir?
So yeah. What is we must have given the traction to this patient. Acha. Okay.
Shift back to OT-3.
Yes, sir. OT-3 you are connected, sir.
Like it. And then you can change it this one. Like this. Okay. It is all.
Volume बढ़ा दो.
Yeah. Let me explain again. This is a tube for the endoscope. This is a tube for the instrument. So we call here working port. And this is the endoscopy port. And it is a pre-endoscopy stage. And I want to put the endoscope. Conclude. You already
Dr. Park, I have a question. Before you put the ports inside, do you take a fluoroscopy? Do you take a C-arm shot with both the dissectors for both the incisions?
Sorry. Yeah, it's weak. So wait a minute. So you have to check the pressure water. This is too weak. So around 1.5 cm press, okay? So you have to elevate the height more. It is too weak. It's also very important. And you know this is the angle for the camera. So this fluid is too weak. So make it more elevate. Or you can use a PP curve. It also weak because this line is too small. Usually we use a bigger line and a longer line. Yeah, it is not good. Because the line is too small, so fluid is too weak. So put the BP curve. Yeah. Checking the pressure is also very important for your surgery, successful surgeries. So, hello? Yes.
Hi, I have two questions. One is, what are those plastic sheets that you're using? Any specifications, any particular brand or make that you're using?
Well, I don't understand what you mean.
The ports that you're using.
Two port what? Working port. Yeah, this is actually I designed this telecast because when I started my bipolar surgery, this maintaining fluid is so difficult. So usually there are semicircular metallic tube.
Yeah.
But I don't like. Sometimes it is a pull out and very difficult to control. So I find it and design it. So I use it. So I like to use this one. So it is a primary idea.
Is that available commercially for use in India?
Maybe impossible. But in Korea is made and you can buy it.
Okay. And how deep are those cannula going?
What?
How deep do they go? Do they go to the lamina?
Always the T is on the lamina bone, okay? You always touch the lamina bone. I can feel the lamina bone here, okay?
Okay.
I need more press here. So you can do the BP curve pressure. And try to change the fluid line.
Yeah. What is the brand of those sheets? What is the company name?
If you don't have a water pressure, you cannot continue the surgery because you have to maintain the outflow. Please take it down, please. Yeah, take it down, please. More take it down. Okay, stop. It's good, wonderful. Thank you so much. And you have to find the T-level instrument here. And I'm looking for the pressure. Make a press, water press, please. Making optimal press is the most important. You can see the here. You have to find the instrument here with the endoscope. Okay.
We have some questions from the audience.
Yes.
The endoscope you have put cranially. Sorry, the camera you have put cranially, right?
Yeah, left side endoscope port.
Endoscope port is inferior.
Cranial part. And
so the camera is cranial and the working channel is
right side. So right side is the working port, okay? Working port, and the left side, can you see here? Can you focus the, maybe endoscope? Here.
And the endoscope is
Camera.
0 degrees, right?
Yes, yes, sir. No, you have to video. Video is here. Video is here. Commercial, okay. Cutting. Yeah, hello everybody, just before, this is RF, cutting. And you can see, stop. You can see this is a laminar bone. Can you see here? This is a laminar bone.
Can you point the midline?
Midline is 12 o'clock.
12 o'clock.
Yeah, 12 o'clock, midline, stop. I will explain the anatomy of endoscope. 12 o'clock is the midline, and 9 o'clock is the cranial. 3 o'clock is the caudal. So this is L4 lamina. And I'm moving to the interlaminar space, cutting. I'm moving to the interlaminar space. It is here, 11 o'clock. At 11 o'clock, we can find. We need more water pressure, okay?
Yes.
Yeah, here, you can see here. Everybody, please be quiet, okay? I have to focus my survey. If you want to talk, please go out and have a talk. So start, coordination. Here is the interlaminar, yes.
What is the power that you're using for the RF?
RF is usually early stage, and stop. If you are under the bone, we can use the maximum side. Maximum is there on RF. Let me explain about the RF. RF is two types of mode. One is ablation mode. The other is coagulation mode. So if you are under the bone and away from the nerve, you can use ablation mode with a high maximum power. So this is the interlaminar space, as you can see here. This is the interlaminar space, and this is the laminar bone. Cutting. So we are. Sorry. Give me here. Give me. So this is the bleeding from the bases. If you want to bleeding control from bases, you can control. You can use the coagulation mode. This is a coagulation mode, like this. You can pause elevate power for the maximum power. Coagulation. Maximum power, I need it. Maximum increase. Coagulation.
What is the power shown on the machine? And which machine are you using right now for the RF? Because different machines have different power settings. Can you please guide us through that?
Yeah, every company has they have their own RF machines. So usually there are power number 7 to 1. So if you are away from the nerve, you can use a strong power. Okay. If you are close to the nerve, you have to decrease the, and you have to use a minimum power. So this is if you want to remove this soft tissue, you can use ablation mode. I want to show you how to use it. I want to remove this one. You can use like this. Clean out the soft tissue like this. Okay. This is lamina over L4. This is margin of L4 lamina, and here is the interlaminar space. And if you want to control the bleeding here, this is a coagulation mode. You can see here low ligament here. This is a low ligament. I told you here is a 12 o'clock. Here is a 12 o'clock, and here is a spinal-laminar junctions. Here is a spinal-laminar junctions. I told you. This is a spinal-laminar junction and starting point for our drilling. Look at this angle. If your angle is just same angle. If your angle is just like this, you will have this level. So you understand? That's why palpating interlaminar space is so important. So I will start my drill here, because here is a spinal lamina junction. Do you understand? So just before I explore the interlaminar space, and now I will start my drills. If you have any question, please let me know. Yeah, you can see here, this one, this is a drill. This is a drill. Okay, you can see here, I want to show you drill. Can you see here? This is a drill ball. This is a cutting, shave drill. This is actually arthroscopic drill. So I want to start my drills. Here is the spinal laminar junction. You can start the drill like this, okay? Like this. You have to learn. You have to know superficial bone first. Here is the spinal laminar junction. 11 o'clock. Look at 11 o'clock. You can like this. Like this. This is the outer cortical laminar bone. This is the outer cortical laminar bone. You can believe superficial bone first. You can believe superficial bone first like this. Because you are endoscope. Usually you are endoscoping here. So the right from your endoscope, you have to reach here. So you cannot see here, but when you do out here, the right from here reach here. So that's why outside view, outer cortical bone first is so important. I need another drill. This is orange color drill is more better for me. Yeah, I am drilling. This is L4 lamina. Can you see? And you can continue this like this. This is outer cortical bone. So please drill outer cortical bone first like this. And then outer cortical bone drill first. And then please move to the inner area. Okay? And you can see some natural blue here. It means that here is the correct letters. And try to explore the ligand flower. This is a ligand flower. This is a ligand flower. And expose the ligand flower with your jaw. You can see the natural blue here. That's why our array is correct. And try to, this is IAP of L4 lamina. You can go more cranial like this. And continue your breathing, superficial bone first. And move to the deeper area like this. And try to explore the ligand flavum. This is the lower ligament. And here is left side L4 lamina. You can do it here like this. Please drill superficial bone first. And then move to the deep area like this. And try to explore the ligand flavum. Now you have some important situation. You have to find the midline. So you have to know the anatomy, surgical anatomy of a ligand flavum. So the anatomy shapes of ligand flavum is just like a butterfly. That's why I like to have a butterfly techniques. So have a butterfly. When you meet the first epidural pad here is a midline. You have to remember, this is a very important surgical anatomy. When you meet the first epidural pad, here is a midline position. So you can control the epidural bleeding like this and stop. And you can meet both cutting when I call cutting, okay? There is no you don't have people cutting. You don't have a line for line. You don't have a full line. Stop. Cutting. Don't have. Stop. Cutting. cutting. So with the ablation mode, we can control bleeding from the bone bleeding. Please turn off to the right, off to the right, over right. Turn over right, off to the right. Okay. So, okay, so you can see here is the epidural pad, okay? So here is the midline. When you meet post epidural pad, here is the midline. From midline, you can go laterally. Left side lateral and right side lateral. So usually the diameter of spinal canal is 16 to 20. It means we can, from here, we can go laterally 8 milli, okay? Usually one diameter is 4 milli. So one diameter, two diameter, we can go laterally, congregation. So we can go more laterally, roughly one millimeter, 2 millimeter, okay? So, cutting. After clean up, you are soft tissue like this. This is the outer layer organ problem. This is outer layer organ problem. After you clean up the outer organ problem, you can expose this lamina. This is L5 lamina. Can you see here? This is L5 lamina. Cutting. Continue cutting. And this is the inferior pole of IAP. Inferior pole of L4 IAP here. So stop. I told you from midline we can go laterally about 8 milli coalition. It depends on patient's size, okay? So most important thing is you have to expose SAP. Stop. This is IAP. When you remove IAP, you can expose SAP. Cutting.
Dr. Park,
Yes,
what
yes.
is the extent of bone removal laterally? How much of the IAP would you like to drill?
Yes, I already talked up. I told you, this is a midline, okay? From the midline, we can go laterally about 8 milli. One delivery is about 4 milli. Do you understand? So roughly we can, this is one delivery, okay? And the other delivery, we can go laterally. So the most important thing is exposure coefficient. Until you expose
Superior to
SAP. Do you understand? So, yes. I want to show you. This is IAP, okay?
Yes.
So, with the use, you can go laterally until you expose SAP. Do you understand? Please, everybody, please be quiet. I have to focus here. You can do it like this. Go and move to the lateral like this. You can go more laterally. And we have to go until you can expose SAP. You know very well, this is midline. Here is the midline, and I'm separating the attachment of ligament problem. We will do it like this.
What is the size of the drill bit that you're using?
4 milli.
4 milli.
Yeah. Usually 4 milli. I like to use it.
And is it necessary to use a guarded drill, or can the drilling, since the ligamentum flavum is there as a protection, can the drilling be done without the guard?
Cutting. Yes, this drill has a hood, so you can protect the nerve or ligament problem. Fluid. I cannot understand. Yeah, I need for a 1 hour surgery, we need a 5,000 cc of fluid. So we need keep two continuously. And wide line we have, wide connection.
Meanwhile, can we shift to OT-4 and can come back soon? Yes, sir. OT-4 you are connected, sir.
For all the audience, I must say, we are streaming at spinecon.in, so you can watch your respective OTs on your devices also, rest of the OTs. But we'll just rotate quickly.
Dr. Sharad, are you there? Dr. Sharad Chandra sir, are you there? No sir. Sharad is about to scrub. We have just started exposure. This is occiput and this is the C2, C3 spinal. How much traction we have given to the patient? We have just put the Gardner belt on. As of now, we have not put traction.
Okay. So can you orient, please?
Yeah, this is cranial,
Okay.
this is caudal, and this is the...
Your hands are obstructing the vision. So now please, if you can...
This is the cranial end, this is the
Okay.
caudal end, and this is the left side, this is the right side. This is occiput, and this is the C2, C3 spinous process.
Okay.
We are just trying to expose now. Dr. Chandra will scrub in maybe half an hour.
Okay. So we can shift to Dr. Parks or OT3.
This is outward development. You can find here middle layer of SAP. You have to drill laterally until you explore the middle layer of SAP. 알아보죠. Coagulation model. You are near the layer coagulation. Pituitary 주시고 pituitary. Pituitary 보세요. So it is very important, most important thing is how much you have to go laterally. How much you have to go to laterally. The answer is until you expose medial layer of SAP. So this is lamina. So we are near the Okay, I'm trying to explore the middle layer of SAP here, like this. And I'm separating the proximal attachment of real problem. You can see here, this is the proximal attachment of real problem. I'm doing here, okay? And, okay. Just before I nearly complete. 입시다트라도 켜준 거 알았어? So, coagulation. The bleeding from the bone, better we can control the coagulation. Stop. Yeah, the bleeding from the bone, cutting mode. Cutting. Okay, cutting, normal, cutting, okay. So you can see coagulation. You can see here is this lamina. So just before I complete the left side drillings, correct? And here is correct. Here is a contralateral sublamina. You can see here. You have to drill here. Here is a contralateral. We mean the right side sublamina area here. Here is the right side sublamina area here. Okay, and you have to drill out. You have to drill contralateral sublamina. You can see here, this is the outlayer organ problem. You have to know there is a two layer. This is the capsular ligament, the outlayer ligament problem. So if you have to remove the outlayer ligament problem. Cutting. To explore the contralateral. Cutting. Yes, cutting. Yeah, and stop. 들어주시고. Yeah, I will start the contralateral sublaminar drillings. You can see here.
Dr. Park, do you try to identify midline cleft in the ligamentum?
Oh, midline. Very good question. Thank you. Yeah, can you show it to the pair here? This is the midline, okay?
Okay.
Yeah, when you need the epidural, post-epidural pair, there is a midline. It is very important. I call here
head butterfly, okay? Head butterfly and wing butterfly. So,
yeah, there is an anatomical cleft over there.
Yeah, there also head, yeah, is a pad, and some cleft here. You can find some cleft, midline cleft here. Can you see it?
Yeah.
This is a midline cleft. But finding face is much more important. And I'm doing care, yeah. I need more water press. I need more water press, please. Yeah. And yeah. I'm waiting for it. Well, why is this?
Do you put any antibiotic in the irrigation fluid, or it is just saline?
Actually, no need for that, because for the 1 hour, we have a 5,000 cc irrigation. Open, first open. I want to camera please. Open here. Okay, this is the optimal pressure. Can you need a water pressure, okay? Your pressure is just like this. You cannot perform your operation. Please make your pressure like this. This is the optimal press. So our vision becomes much more clear. Can you see here? Yeah, become very clear because the fluid movement is become good. Do you understand? That's why maintaining the outflow is so much important. You can see our vision is much more improved because of water press. Do you understand? So now I'm drilling contralateral sublamina. This is the right side lamina, sublamina area. So I am drilling inner cortical bone first. And then you can drill inner cortical bone and the medial bone. I am drilling like this. Can you see this one? Yeah, you can drill like this. Yes, I'm drilling sublamina here. Okay? You have to know this is one problem. This is one to really protect your nerve damage for this. I mean, this is one problem. We protect the nerve damage from the drill. So you have to only remove one problem become only turning dura, okay? So, I mean, preserving your little problem until you complete your drillings. So, I am drilling contralateral sublamina area here like this, okay? And you have to know until you meet the contralateral sublamina area, contralateral facet, okay? This is the IAP, because 100% IAP, because this is the one body of the upper lamina. Do you understand? So you can find here, you can go more lateral, you can see the SAP. So this is 100% IAP, 100% IAP. So with the drills, you have to try to explode contralateral SAP. So, yeah, I'm drilling until you explode the contralateral SAP. You can do it like this. And you are in problem. You protect the nerve damage from the drills. So that's why your drills are so safe, so much safe. You can do it like this. And do more deeply like this. And bleeding, if you are bleeding, you can see here, and you can do like this. My secret thought is when you write with the contralateral, the direction of the rotation is counterclockwise. I mean, here is the contralateral sublaminar area. Right knee is a counterclockwise rotation. Counterclockwise rotation. And if I have it here, ipsilateral, but the rotation is a clockwise rotation. Here is a clockwise rotation to this. Okay? And here is a counterclockwise rotation. This. Like this. So I strongly recommend you, please make a stage for your surgery. Let me know when I call. Please. Coalition. Please reduce the power of coagulation. Number 3. Reduce 3. Coagulation. Continuous coagulation. Make 3. Coagulation. Okay. Cutting. 3. Cutting. Okay. Yeah, let me explain. Fluid. What's the fluid? No fluid. When you are speaking become deaf, you have to check the press here, always. The press is good. Okay, and we are here. I don't know why our crew is not good. Okay, so correct. And we can remove this one. We don't need it because outflow is well made. Okay, so you can remove the trocar. Can you see this here? This is 100% IAP. When you dig out here, you can find the SAP. Here is the contralateral facet joint. This is the IAP, and here is the interfacetary plane. So, and this is the outlayer ligament problem. So you have to remove this outlayer ligament problem. Okay? When you remove this outlayer ligament problem, you can find the SAP. Let me explain how to find the SAP. You have to find your SAP from the distal lamina. Here is your coagulation. Here is the proximal margin of the distal lamina. Okay, cutting shortly. Stop coagulation.
Can we go to OT1 quickly?
Cutting. Okay.
Yes, sir. OT1 you are connected, sir.
Dr. Kolosov,
Yeah.
can you explain what you're doing?
I'm doing approach and try to remove pedicle screws before our surgery. It's a mono pulexor.
Dr. Kolosov.
Mono, yeah.
Hi, so I see that you're removing those pedicle screws.
Yeah.
This surgery was done priorly also, right? About a few years back. What was it that went wrong and why are we revising it? Can you please explain the audience?
Repeat question, please.
So, the surgery was done previously, right? You already have pedicle screws over there. So, what went wrong and what are you trying to correct now?
Let's give me a chance to finish the approach and introducing screws according to plan. And after that, we decided what kind of osteotomy we will do. And
Yes. All right. So till that time we can go to OT3.
cutting. Can we move on to OT CV junction for a while?
Yeah.
Yes, sir. OT4, you are connected, sir.
Thank you.
Dr. Sir, you are connected, sir.
Can you hear me?
Yes, sir. Yes.
Sir. We're just exposing, we exposed occiput. Now we'll start exposing the vertebral artery and the joints. One small tip I can give you, I use this Vesalius, which is a variable impedance bipolar. So I don't use monopolar for dissection. I don't use monopolar for any spine dissection because that leads to a lot of swelling and pain. So using bipolar for dissection gives you a very nice vascular field. So we keep the cutting very high on Vesalius and then it produces a very nice and clean dissection. So now this is the space we'll start dissecting.
And still we haven't used weights for the traction?
No. So the traction, most probably we won't use any weights. Usually I don't bother about traction. So you can see now we have started dissecting the joints. So for dissecting the joints, we follow along the lamina. It's a 1-minute process. It's not at all difficult. Too much has been told about bleeding in the joints. It's a completely avascular technique. There's absolutely no bleeding provided you know how to do it. On. So you can see I've kept the cutting high in bipolar. No monopolar, nothing. I'm just using the bipolar. And that provides us a very beautiful plane. On.
And the irrigation is also not required?
No, not required. On. Clean system. थोड़ा सा लाएंगे.
So we are first going to the left joint. It is the left side joint, if I am not wrong. Dr. Sharad Chandra?
Yeah?
It is the left side joint we are reaching up to?
There is no specific side. Anyway,
no. Right now you are going to the left side?
Yeah. So I don't have any particular preference which side I like to go first.
First, like what is your preference, like when the joints are asymmetrical, when there is one side there is a problematic joint, when there is one side a anomalous artery, so any preference going first?
At this stage I don't have any preference, honestly, because anyway both have to be exposed. So I'll go on this other side. Girlfriend, so that's the vein there. Salam. Salam. On. Salam. On. Wait a minute. Not on. Cotton. Give me a. So you could have venous bleeding from 3 sources. So best way to control is just put gel foam for a few minutes. It gets controlled. On. So the idea is to follow the lamina, which is a highway to the joint. On.
Looks like C2, C3 pars it is.
Yeah, this is the beginning of the C2 pars. Just to dissect the muscle here. On. Clean the bipolar system. Hmm? I think it's a vertebral. Yeah, could be there. That's a, yeah, that's a C2 now. So this is the vertebral here. Not on. This is the vertebral.
Okay.
Okay, and this is the C2 ganglia.
Okay.
On. So remember, vertebral artery is always anterior to the C2 ganglia. So if your dissection is meticulous, it is meticulous, you don't have to worry what is going to come there. The anatomy is going to reveal it by itself. Clean. Can you dissect it?
So there is a question as what is the bipolar setting?
Bipolar, the cutting is very, very high. You put the cutting at, I think, 70. How much is the cutting?
70.
Yeah, so you put it at 70 so that it cuts the tissues. Well,
But I must tell the audience, this is the molecular resonance bipolar machine. This is different from the regular bipolar. It costs around 40 lakhs or so. It's beautiful for neurosurgery.
So I don't have to worry about cutting it, cauterizing it. So it cuts and cauterizes. Saline. On. So that's the C2 ganglia. Can you see that?
Yes, sir.
That's the C2 ganglia. So we cut it at least 1 centimeter. It should be a distance from the thecal sac. Otherwise, you can have a CSF leak. So cutting the C2 ganglia.
Sir, we'll just join you in a minute.
Sure.
People want to see OT3, Dr. Park.
Yes, OT3.
So, Dr. Park, we are back with you. Could you just explain what you do?
Yeah. Yeah. Now I'm moving left side veno vertebral. This is left side veno vertebral. Just before. Yeah. This is left side veno vertebral. And I'm just before I remove it. This here, and we remain. This is the right side, okay? Right side we will vertebral here. Can you see here? So we can separate it from the bone. This way we can see. Okay, cable. Alif. Yeah. Coagulation. We can control bleeding, coagulation more like this. And we are going to here, stop. When I call, coagulation. Yeah, this is a contralateral problem here. accurate. We have to do more lateral here. You can see here, okay? You can see dissection of ligament flavum, dissection of ligament flavum from the dura like this. Here is the medial pedicle. You can see here. This is a traversing root. Can you see traversing root here?
Yes, very nice.
And we can two minute punch please. We can palpate the medial pedicle here, punching. And we can put our punch like this. We can put our punch like this, and remove it like this.
So Dr. Park, these are standard punches or they are specialized?
Yeah, these are normal punch. Normal punch which is used in microscope surgery, okay?
Okay.
Pichita. Yeah, the strong point, the advantage of this surgery is that you can use the same instrument which is used in the microscope surgery, okay? So you can use like this.
That is a major advantage.
Please. Up, please. Coagulation here, coagulation. Over the pituitary. Coagulation. Okay, over the pituitary, please. With the punch. I mean, pituitary process. Okay. Now I will show you surgical anatomy again. Here is the left side, okay? Left side, and here is medial wall of the pedicle. If you not have medial wall of the pedicle, you can remove it. Here, clean up. Okay, here, you can remove it here.
So then we should be able to see the traversing route.
Yeah. If you not I am exposing, if you not traversing route, okay? Here, we are weird, okay? You can palpate here. Here is the medial wall pedicle, and you can see here. Okay, double M. Extrude. If you want to extrude, we have to go more here. If you want to extrude, you have to design your surgery differently. You can see here, this is the traversing route. Can you see here?
Yes.
This is the traversing route here. And you can check the disc. There is no disc here, okay?
Right.
Yeah, here, this is the traversing route, and here is the medial wall pedicle here. So this is the lateral marginal dura, okay? And here you can see here is the contralateral traversing route here. Can you see this one?
Yes.
Here?
Yes.
And here is the contralateral lateral recess, okay? And if you want to make sure extrude, you have to go here. You have to drill a lot. You can explore the extrude. So if you have a primary control, RF please. So just before we complete coagulation, we can shrink the inner flywheel with the coagulation over like this. Okay? Like this. Stop. So this is the lateral wall of dura. Okay? Can you see here?
Yes.
Lateral wall of dura, traversing route, coagulation. And here is the lateral recess, coagulation, here. So, every route, both the traversing route is completely decompressed, okay, coagulation. Here, this is well decompressed, you can see here, sir.
Yes, very nicely seen.
Coagulation. Yeah, fully decompressed. And here is left side, coagulation. Left side traversing route, here, coagulation. Okay, So, and here is the central area.
So surgery is over, Dr. Park?
I'm completed my surgery. Here is the contralateral medial oral pedicle, okay? And here is the ipsilateral medial oral pedicle. Our decompression is from medial oral pedicle to the medial oral pedicle. So the it is fully decompressed spinal canal. So we can complete this surgery. So I will finish my surgery here, okay? And here. Angioplasty we can do. I will show you how can we have angioplasty. So actually now I'm working with more.
Question,
so
because decompressions, we do the decompression from?
If you want angioplasty,
one question is concept of decompression, we do it from pedicle to pedicle. So are you going to do some work on the exiting route, or only the traversing route you need to decompress?
This question, the two-route decompression? Yeah, I will explain. This is the contralateral SAP, okay? This is here is the T-level SAP. Over the T-level SAP here, we can find the exiting route. If you want to decompress the exiting route, you have to drill more lateral here. This part of bone you have to drill out. And you have to explore the contralateral T-level SAP. And then you can find the exiting route here, okay? So if you want to decompress the exiting route, you have to drill more cranially, and try to explore the exiting route.
Are you going to exercise the tip of the SAP here?
Usually we don't need to explore the SAP because traversing route is compressed. So our surgery is which route is compressed. We have to, the goal of our surgery is decompressing the route, affecting route. This patient, both L5 route is affecting route. So we have to decompress only both L5 route here, okay? We don't yes, sir.
One more question, please. As far as I understood, there was also a bulging disc.
Bulging disc, yeah.
Yeah. What do you do with bulging disc?
Thank you for a good question. Just like this, question. I'm doing. So now you flat like this.
Yeah.
Well, you can see the shrinkage of the, stop. You can see the shrinkage of the, sometimes shrinkage of the areas you can see. Correlation. So now I like to have, you have to call you have to follow my call, okay? So we are here. This is the areas you can see here, correlation. So area first like this, correlation.
Yeah.
Correlation. Doing tightening correlation. Semi modulation of the area, stop. Semi modulation of the areas is very helpful for the, you can see correlation. You can see the shrinkage of areas like this. Can you see here? Stop. Again, shoot.
So you just coagulate and shrink the disc, but not remove it.
Like this, yes, coagulation. It is the best for it. So just before, I performed the other things, coagulation. And the next stage is prevention of hematoma collection, okay? So when you start the input over here, like this, there is no bleedings. Can you see here? Then this is this one. So usually I apply the fluosil over the dura, and put it there. There is my surgery. So I want to complete my surgery. So let me summarize my surgery, okay? You have to stay on the left side, okay? And start with the spinal junctions, and explore the renal problem. And find the head of butterfly, midline, okay? And laminate region, both sides of laminate regions. And explore the inner layer problem. and find the medial wall of pelica, medial wall of SAP. You have to separate the medial wall of SAP, from optimize it like this. And then you can take it out, 2 piece or 1 piece of the problem. And then you can complete this survey. So,
one more question, please.
Yes, yes.
Just in case of CSF fistula, leakage.
Yes, yes.
You cannot repair it by switching, like microscopic approach, just to put a patch with glue, right?
Yes, yes. Yeah. Thank you for wonderful questions. To the tear, okay? You have to check the arachnoid membrane because here is the water-based surgery. Even though there are two tear, your arachnoid membrane is intact. At that time, you don't worry about the leakage of the CSF. Only tacocele patching the something. Okay? If there is some inside the tear, also you can control some patchy or other things. You don't need to convert your surgery to the close. You can apply another things. So I told you if you remove the renal problem lately, your epithelial space also expose lately. Lately telling we can control it. But when you expose early exposure to the PCNL renal problem, only telling make a problem. Only telling make a problem. So if you have only telling you have to convert. You have to convert your surgery to the microscopic surgery. That is my talk.
Hello, back with you, Dr. Saradoti.
Yes.
Yes,
Thank you,
Dr.
Dr. Park. Thank you.
Dr. Stress, sir, you are complete, sir. Can you hear me?
Yes, sir, we are with you.
I just want to show you the anatomy. This is very, very critical.
Right, sir.
Okay, so give me a dissector. So this is the lamina of the C2.
Right. Can you focus there, sir? For us, camera, it is slightly out of focus. Much better, sir.
Much better?
Yes, sir.
So this is the lamina of the C2.
Right.
Spinous process of C2.
Right.
So we just follow it, and that becomes the pars.
Right, sir.
We follow the pars, and that's the joint. You can see the joint?
Yes, sir.
That's the joint. Okay? And now this is the vertebral artery. You can see that here? The vertebral artery has been completely dissected, and as you can see, there is not much of redundancy here.
Right, sir.
As you say on the angiogram. You see that?
Yes, sir. Yes.
So when I'm kind of doing it, I can see a little bit of stretch on the vertebral artery.
Yes.
And that is the portion of the C2 ganglia which has been cut. Can you see it?
Yes, very clearly, sir.
So you can see there is no blood loss.
Right, sir.
Yeah, we have dissected lateral to vertebral artery, medial to vertebral artery, exposed it completely, cut the C2 ganglia. Okay. So we are dissecting the other side.
Right, sir.
Manipula.
Right side is the more dangerous side, is it?
Yeah. Manipula.
We'll be there with you.
Okay.
So I will just join you back.
Sure. Take your time.
OT3, put the X-ray, MRI films. MRI film पे focus करो. MRI film पे focus करें. OT3, Rajesh, Dr. Rajesh. हाँ. इसमें लाइट पीछे का वो कुछ ऑन होगा? तो कुछ नहीं दिख रहा. नहीं दिखेगा सर वो. सर उसके पीछे वो है नहीं. दैट्स अ सेपरेट थिंग. Yes, sir. point is well taken. I think that there are limits to endoscopy. Dr. Rajesh Meena, are you there? Dr. Rajesh? नहीं जा तो रही है सर. Can we have the MRI put on a view box? क्या कर रहे हैं? चलो सीरीज में तो भी डिसेक्शन स्टार्ट की. ठीक है, we'll shift to OT-4. And Dr. Sharad, we are there with you. Yeah, so I'm dissecting the other side. So you can see again the same technique, follow the lamina, go to pass on. And you can just see how beautiful this bipolar is. You know, otherwise, I don't know what is that. Let us see. Could be. Deepak, you are appreciating the bipolar? Yes, the whole audience is appreciating. It is as if we are doing it on a cadaver, okay? On. Retract here. On. So that's, so come there, this must be the vertebral. You can see some pulsations here. On. Venous bleeding is a marker of that vertebral is nearby. See, venous bleeding, you have to understand only three things. There are only three directions from which it can bleed. One is from the epidural space. Yes. Other is lateral to vertebral artery. Okay? Right. Other is from the pars of C1. There is no fourth area from where the veins bleed. It's as simple as that. Once we understand that, then, so that's a joint. We reach the joint. You see, as it took us almost less than a minute to reach. Retract. Sir, the vertebra was supposed to be on the medial aspect. Yeah, it is still on the medial side, but we are not bothered. That's the vertebral. Right. So it's basically because of the dissection, it's got. Yeah, absolutely. In the dissection, it's gone laterally, so we don't even bother about it. So we are mobilizing it, but it's. So we are dissecting on the medial side of the vertebral artery. So that's a joint. You can see the joint? Yes, sir, yes. On. So this is the vertebral artery. Okay? We have kept it covered with its sheaths, so we're not retracting it too much. On. So this is the pass of the C2, exposed completely. On. On. See, that's what. Now if you have to do a C1, C2 screw, I'll have to put a C2 here. And then C1 has to go here, okay? Which is kind of a messy thing. You know, why should I do that? Just put an occiput and retract. We can do it, one can do it, there's no issue of not doing it. But the question is, you know, at some point of time, you feel it's not required. Give me Paris preservator. So that's a vertebral. Can you see that? Yes, sir. So I'm now distracting the joint. By Bilal, I'll Try to save the C2 ganglia on. That's the C2 ganglia on. So that's the joint on. So now we drill the joints with the diamond drill system, and then we have to disarticulate the joints completely. It has to be totally loose. Only then we can push in the spacers. Drill. Diamond drill. आजा इसको हाँ इसको रिट्रैक्ट करो
मुझे पेंसिल 1 दे दीजिए पेंसिल 1 दीजिए मुझे
Also, I will request the audience, we have this question system online, menti.com, and you have it on the left screen top. So you can ask any question by joining it, putting in the code. So it will appear on the screen and we can ask the question to the speaker or the surgeon. Just a little better. Give me 2 पेरे हाँ इस तरह भी थोड़ा कम है आ जाओ कमल जी
So once you have opened the joint, the traction will help in better visualization in
in this I didn't put a traction. The reason is the table is not optimal. It is a carbon fiber table. So we put a GW traction but not put any weight on it. Not required. In fact, I don't bother whether the patient is on traction or not. It's not required. Give me Paresh level. We have kind of put too much of importance on traction. But traction doesn't help. The what? How you retract at the joint, that is what is the key. The maximum force what you apply is at the joint. Traction is not so important. Hammer.
Can we go to OT1 for a moment? Dr. Kolsa.
Yeah.
Hi, how is it going? Can you please tell us what are you up to over there?
I try to find post-laminectomy defect.
Okay.
Let's start, let's change place and start introducing screws.
Okay. Are you using neuromonitoring for this patient?
Yeah.
Okay.
Of course.
Yeah. You've done a very good exposure. Looks bloodless. I think that's one of the key factors for these surgeries, right?
Filler. Oh. Yeah.
Lunch is also ready for those who would like to have lunch.
Section, please.
Doctor, can you orient us which level you are doing right now? Which level of pedicle screw are you putting in right now?
Sorry.
This is L4.
L4.
Okay. And whenever you get a chance, can you please show what landmarks you're taking for putting in that freehand pedicle screw?
It's for preparing screw, top.
Yeah.
Yeah. 5.5. Okay. Maybe you have a little less. 4.5. Yeah. Landmarks, it's transversus, process, and connection with facet joints.
Can we have the camera reoriented to see the landmarks, if at all that is possible?
Angle in my head. I see deformity and in my head there is algorithm.
So you have navigation already into your head?
Screws maybe 5.5. For maybe 45. Only puller. In deformity, I don't use non-axial screws.
Shift to OT-4. Dr. Sharad?
Yeah, are you with me?
Yes, sir, we are with you.
So you can see now this is what I do. I put two periostral elevators in both the joints and then turn it. Now I've drilled it with the diamond drills. Okay.
So one of the questions was, can you use curettes instead of the drill?
Curette again, yeah, you can use it. I use drill because it's very simple. You can use curettes, no problem. So I put periostral elevators on both the sides. Now you can see I turn it so that it's completely decided. Can you see that?
Yes, sir, very clearly.
Now there's a very free and nice movement, so it's completely disarticulated. So one has to completely disarticulate it. And now when I do that simultaneously, you have to keep a visual on the vertebral arteries. You have to see that it's not getting too much stretched and all that. It doesn't happen, it's very, very rare, but still, that's the reason, you have to expose the vertebral arteries and keep a visual on that. So it's nicely disarticulated.
So sometimes there is a lot of bleeding from the joints when we do this step.
Yeah, there may be some ooze and something, but moment you stop it, it stops.
Yes.
It's not an issue. So right now it has disarticulated. So we will now drill the rim of foramen magnum, place the screws, and then place the spacers and then reduce it. Cutting drill.
OT-2, what is the status?
Yeah, hi.
Sir,
here.
Yes, sir, we can hear you.
Yeah, the patient is in prone position. We've done, the tumor was Day-2, 3 intramedullary tumor. And we've done...
can we focus on the patient?
Yeah, we'll just do that.
Yeah, hi.
And what, दिखा दो spine में निकाला था. Ultrasound on है. So, we took out this laminoplasty, 3 level, we'll fix it back.
Can we focus there? We are not able to see.
Are you better?
A microscope view दे दें, we are not having.
Microscope view दे दो. We took out this
OT-2 microscope view.
3 level, we'll fix it back. Microscope view दे दो.
Can we focus there? We are not able to see.
Are you better? Microscope view आ रहा है?
Microscope view.
आ गया?
We are not having. Yes, sir. Yes, sir.
So this is a 3 level laminoplasty we've done. So this is this will replace it, fix it back with mini plates later. इसको रख लो पानी में. And this is the field.
Yes, sir. Yes, sir.
This seems that this is the tumor bulge and
Cranial and caudal, can you just
this is
give it?
cranial. D1.
Right.
This is D2. This is D3. And we have an ultrasound here. So ultrasound on kar do abhi. Chalo, they'll put it on. So we just see whether we have to extend our laminoplasty. I don't think so, because I can feel the tumor, see the tumor bulge like this. It seems to be softer here and here. And है कोई अल्ट्रासाउंड है? नहीं तो हम खोल खोलें. देखो please. So we just see whether we have to extend our laminoplasty. I don't think so, because I can feel the tumor, see the tumor bulge like this. It seems to be softer here and here. And है कोई अल्ट्रासाउंड है? बाइपोलर. खोलें. देखो please.
थोड़ा कम
कितने पे बाइपोलर? 8 पे कर लो. सक्शन कम करेंगे. मैं पहले अल्ट्रासाउंड देख लेता अगर है तो. आगे चलो पानी. इस पे फोकस कर दो स्क्रीन के ऊपर. We are lucky to have an ultrasound here and थोड़ा पानी डाल दो अंदर फील्ड में. So we can see the ultrasound image. Abhishek here. We can see the lower end of the tumor. Can you see the other screen?
No, we cannot see.
The ultrasound image. Just switch to the.
Yeah, now we can see.
That is the upper end of the tumor.
Okay.
Big tumors I don't usually use, because then you are actually slightly good with your laminoplasty. You can, but here I'm using a limited exposure. Pani. It helps actually. It's not mandatory, but it helps. This is the lower end. You can see it going down, and then that's the normal cord. That is, yeah, that is it. So can you see the lower end?
Yes.
Yeah. So it is, the lower end is there. So we'll open the theatre now. We confirm that our lamina exposure is directly above the tumor level. So we don't have to extend our lamina exposure. Can I have cottons, please? Bipolar.
No, what should be the extent of lateral extent of laminectomy? Like, so.
Laminectomy, the lateral extent is just if you put your Bible or flat dissector,
Yeah.
you still have a couple of millimeters left. We don't, actually this is not, enough dura is visible, that's enough. Because we need some part of lamina to fix it back also. Do you have a diamond knife or any knife, 11 number blade or something? Fine section? Full size cartons please, 2 full size. Oh, ठीक है, ये भी ठीक है. एक और दे दो, half rod दे दो. Give me half rod. चल गया बेटा, चल गया. Thank you. एक और दे दो, half rod. Any knife, 11 number blade or something. Fine section. Full size cartons. It should not be a very narrow exposure. But you don't need a real, not like a gill laminectomy or something. Fine section. Have you taken the waves, baseline waves? So you are monitoring the D wave and SGP and MEP. अभी सब ठीक है. Good.
So can we have a look on the monitor, sir?
एक monitor का भी look वहाँ दे दोगे of that. Have you taken the waves, baseline waves? So you are monitoring the D wave and SGP and
Monitor.
Knife.
Can we have a look on the monitor, sir?
एक monitor का भी look वहाँ दे दोगे.
Professor Suri, there is a question from the audience.
Yeah.
Your patty does not have a thread.
This patty?
Your patty which you are putting, they don't have any threads attached to them. Any reason?
Because I know 1, 2, 3, 4. This is the standard I keep. 2 long and 3 small. And removing the end. You'll see. I'll count it when I'm removing. None of our patties in our OT actually have a thread. It's a pity. But I do a mental count.
So, the reason why they stopped using the thread, because that was the standard everywhere, no?
I don't know. I'm not in charge of the procurement. Bipolar.
I want to ask, after you open the dura, halfway through the tumor, can you again use the ultrasound to see if there's any residue?
Can be, but I think visual impression is very good, but still we can. the good thing. But what I want to stress to the junior people also, that there is no point putting a lot of surgery constant. So you can do these epidural veins can be easily coagulated if you are right on like this. You don't need too much of technique there, and the rest of the bone can be just drilled with a diamond bar. And so you don't have a bloodless field without any unnecessary flow seal on surgical constant. Because the problem is anything you put, the moment you decompress the tumor, it starts oozing badly again the moment it's closing. So it's better not to put anything. And so you don't have a bloodless field without any unnecessary flow seal on surgical constant. Because the problem is anything you put, the moment you decompress the tumor, it starts oozing badly again the moment it's closing. Section come karo. It's better not to put anything. Give me 50 number plates. Section come karo. Give me 50 number. 50 number. Number. Okay. 5 fine forceps, side angle blue scissors.
How much importance you give to the mean arterial pressure while operating these cases?
How much is the mean arterial pressure? 85.
But do you ask for a particular pressure?
No. Standard.
How much importance you give to the mean arterial pressure while operating these cases?
How much is the mean arterial pressure? 85.
Whenever you are dealing with spinal tumors or in spinal surgery in general, I think it is always better to see that the anesthetist doesn't bring the BP too low, because spinal cord perfusion is a very important issue. And you can have disasters because of hypoperfusion. In their attempt to help and trying to make the field vascular, I think it is they can actually cause damage to. The anesthetic doesn't bring the BP too low, because spinal cord perfusion is a very important issue.
What is your opinion?
And, you can have disasters because of hypoperfusion. In their attempt to help and trying to make the field vascular.
This is where the bulge is maximum, so I am very careful that I don't cut the pia along with my and the arachnoid along with my dura.
Can I ask a question, please?
Yeah, please, sir.
What do you think about the dural opening with the hook without using scissors?
So this is a beautiful scissors gifted to me by my Japanese friend Dr. Ohata. He calls it the Ohata scissors. But you can put the tip of, you open a dura with a diamond knife or a simple knife, and then you just put, you can use a hook as well, no problem. But this is nice. It's only a couple of millimeters of tip is going inside, and it's safe. And I'm not opening the arachnoid at all. Hook is good, but sometimes with the hook, I've used the hook, but sometimes you don't get a linear cut. You tend to go a bit lateral with the hook. Another thing with the hook is you can actually give the initial cut a thin line with the knife and then use the hook. That's good enough. I've used both, but this is faster, I think.
Do you staple for dural bleeding?
Closure? Final closure? Or
just to staple during the opening procedure?
Yeah.
Just to staple on the vessels?
No.
The block without...
Hello, Dr. Suraj sir, back with you. Yeah, are you with us? Dr. Suraj sir, your message. So we have drilled the lumbar foramen magnum. So I wanted to show you this band. Can you see this band? Sir, just a minute. Shift to OT-4, Dr. Sharad Jyoti. Yes, sir, we are with you. So I have drilled the lumbar foramen magnum. Sir, back with you. Yeah, are you with us? Dr. Suraj sir, your message. So we have drilled the lumbar foramen magnum. So I wanted to show you this band. Can you see this band? Sir, just a minute. Shift to OT-4, Dr. Sharad Jyoti. Yes, sir, we are with you. So I have drilled the lumbar foramen magnum, maybe about 1 or 2 centimeters. Right. And then you can see these bands. Little bit of focusing, sir, on this. Opposite side.
Yes, yes, it's fine. Yes.
You can see these bands, no?
Yes.
So these bands have to be released. You can hold on biopsy forceps and then pull it up. That's the safest way to do it. If you try to cut it with scissors, they can be difficult. But pulling is always okay. Can you see that?
Yeah, Professor Sarat, this was not, there was not much visual invagination or incurving of the occipital bone. In the difficult ones, I don't know whether you agree, I like to drill first on the occipital side, expose the dura and then start drilling downwards rather than starting from down and coming up.
Yes, I mean, anyway, it has to be tailored according. Sometimes, the CV junctions are very, with forceps, mixing them. Sometimes the CV junction occipital is very deep.
Yeah.
It goes like a dense.
Correct.
It kind of almost cuts the cord across. So in that case, you drill from the top and kind of go down first. Because you can't come from bottom to top. But I just wanted to show you that band. Once you release the band, you can see the dura pulsating. So not just drilling the bone, this of course not for experts like you, but for other beginners sitting there. But when you expose the dura, it's very important to release the bands.
How much of occipital bone you will drill?
I would have drilled maybe about maximum about 8 to 9 centimeter, that's it.
Okay.
The whole idea is to remove the compression at the back. So now we'll put in the spacers. Sister spacers 6 millimeter. इसमें hydroxyapatite भर के दे दीजिए. So we'll put a standard 6 millimeter size spacer. Or even 5 is okay. It is reaching up to.
Do you decide by looking at where the tip of the odontoid is?
Yeah, the actual measurement is that we measure the degree of basilar invagination in severe cases, and then we reduce a couple of millimeters for the drilling we have done. So we add that up also. But in this case, just इसमें hydroxyapatite भर के दो. So in this a standard 6 mm is quite okay.
Sir, can we take the bone graft from the spinous process of C2?
Yeah, we can do that. We can do that, but I prefer to put hydroxyapatite. We can, but the reason I'm preferring spinous process now is we use that for reduction. So I'll show you. I'll put the reducer, and then I'll use the spinous process. I will put a reducer here, and then reduce the space after putting the spacer. So this compression between OC1 and C2 after putting the spacer. Yes, so if I reduce it without the spacer, the dense also goes up now. Basilar invagination will increase. But if I put a spacer and then compress it, it converts it into a type 1 pivot joint. So it reduces the dense and reduces the basilar invagination. Lining? Why?
Can we move to OT1 for a while?
Yeah, good. Yeah.
Dr. Kosa, we're getting a very good view of your operative field right now. So while you put the next thoracic pedicle screw, please guide us what landmarks you use and how you direct your pedicle.
Landmark.
Yeah.
Okay. No, next.
Right. What is your UIV in this case? The upper vertebra?
This is transfer this process. This is up part of facet joint. Pedicles here. Remove cortical end part, yeah?
Okay.
And after this, pedicles. And after this.
And how do you decide your supero-inferior direction?
Ambulation. You just know.
It's link technique in OT. Link in OT. Yeah. Now it's pretty good. Yeah, yeah. I feel that media are part of soft and I need to change position. 35. Yeah. I introduce like this. A little concave. Yeah, round in the and a little lateral.
Dr. Kolosov, one of the questions is which side screw should we put first, concave or convex? As we can see, you're putting the concave side first.
Yeah, yeah. Yeah. Yeah, yeah, yeah.
Yeah. Can I ask a question more? Dr. Kolosov? Do you use neuromonitoring to check that you are purchasing the bone without engaging the neuroforamen, impedantiometry, electromyography, something like that?
We will do neuromonitoring of the screws in the end. Usually I do that.
X-rays only at the end of the operation, right?
Exactly. Yeah. Yeah. Oh. Yeah. Come on. Yeah. Feel it. Yeah. I think 35.
We are in OT-2. Professor Suri sir, can you guide us regarding the myelotomy?
Yeah. Now open the dura, tag the dura laterally. Bipolar. Hello. Yeah, I've opened the dura and tagged the dura laterally.
We are in OT-2. Professor Suri sir, can you guide us regarding the myelotomy?
Yeah. Now open the dura, tag the dura laterally. Bipolar. Hello. Yeah, I've opened the dura and tagged the dura laterally. Needle. Tag the sector. Yeah, first see the midline, see the lateral roots on the side. This is the root exit. These are root exits. You can see these are this is of the right side, and here it's on the left side. So the cord is not deviated eccentrically. So the midline should be somewhere here. Now we actually look at the midline by the vessels disappearing into the posterior septum.
And here is on
Needle.
the left side. So the cord is not deviated eccentrically. So the midline should be somewhere here. Now we actually look at the midline by the vessels disappearing into the posterior septum.
Can I have a finer section of this? Bipolar. Fine bipolar.
Can I have a finer section of this?
कितने में bipolar? Okay.
Bipolar. Fine bipolar.
Are you connected? Yes, sir, you are connected OT4. Yeah, I'm just driving. This is 6 millimeter spacer.
कितना देगा आपको? Okay.
Are you connected? Yes, sir, you are connected OT4. Yeah, I'm just driving. This is 6 millimeter spacer. I get it free of cost because I've designed them. So it's a biconvex. I can show you some bigger size spacers. बड़ा size दीजिए. So we have all sizes. So this you can see. It's called as 16 millimeters. So it's called as a DCR 16. So you can see this is how it looks. So we use that for severe. And there's a hole here, you can connect it to the rod also. So I'll just show you. Here it should be very straightforward. So Dr. Kamaljeet is retracting the vertebral artery. And we have already loosened the space, hammer. So you have to ensure that it's not on the way of vertebral artery. Progress slowly, better.
That side you do the opposite side, it will become simpler. Maybe if you put the opposite side one, because that joint is bigger.
I want to put this side one because here the vertebral artery seems a bit tight. So that side I'm okay with vertebral artery. And normally when we put a spacer, the other side collapses. So
Are you using any neuromonitoring, Professor Sarat?
I used to use neuromonitoring. I didn't find any difference. So one of my residents did a thesis. So in fact, we found that when the procedure was done, it's published also, the DVA improves. So after that, we don't use it. So right now, Dr. Suri is using this. So I'm okay. I'm not too much concerned about neuromonitoring. One more. So that's the thing, when you put a spacer on one side, the other side collapses. So you have to again release it properly. Hammer. Base system, diamond drill.
Sir, how much is the length of the eventide line above the Chamberlain line? I am asking because it has to be like made up millimeter by millimeter or?
No. Only for severe. In this case, it's a very moderate. So, a 6 millimeters is quite good.
So both sides 6 millimeters?
Yeah, both sides 6 millimeters. So you can see now it's the joint is released nicely. Spacer. So again, Dr. Kamalchit is retracting the vertebral artery. This side is the easier side. So that side, the vertebral artery dissection was where I was a bit worried. This side should go in okay. That's okay, Pramod. Look at this.
Sir, there is a question from the audience that had the patient been on traction, this step would have been easier.
Not actually, believe me. You can put the traction on. Gelfand, big size. Gelfand big size. अरे दीजिए नहीं पूरा है. Gauze.
There?
Yeah, I'm there.
Yeah, can you please say what you are doing? Like you have done a myelotomy?
I don't call it a myelotomy. Actually, the arachnoid vessels better to separate. I'll just show you. Some arachnoid vessels are separated. The pile vessels, see them going down, and they are going into the septum. And these are two fasciculi, the posterior column, the fascicula gracilis. And this is where, how do you identify the septum? The vessels coming into and then coming down into the septum. And that's important. So you actually don't do a real myelotomy. Myelotomy is cutting the spinal cord. So you're better widening the posterior septum. That is the right word here. I don't know the name for that.
Dr. Suri, can I ask you a question?
Yes, please.
Regarding the identification of a posterior longitudinal fissure, due to the tumor pressure, many times it disappears, so it is quite impossible to recognize it morphologically.
No, I'll tell you the technique for that. I actually learned it from one of a very senior Italian neurosurgeons, professor. And his name was the late Professor Albino Becolo. He was visiting us 25 years ago when I was a junior faculty. Asked me a flat dissector. I just deal with it. You actually go across and see the roots. The roots which are coming from here, and then you see the roots are coming from here. So when you identify the roots, then you start seeing the posterior, then that is the real midline of the posterior fissure. There you see start seeing the vessels which are going, if you see these vessels are nicely going into the septum. But you are absolutely right, a tumor which is eccentric will have a deviated posterior fissure. So there, this identification of both the roots actually helps. Here, the roots are, if you see this, they are here and they are here. Had it been a very eccentric, this would have been shifted here and this roots would have been coming here.
Absolutely correct. We can also find neurophysiologically by stimulating and identifying a neurophysiological midline fissure. This is another option.
Very good.
Second observation regarding coagulation of the vessels. Is it mandatory to coagulate the vessel and hold them, or is it possible also to jump over in some cases, or to put gel form or Flosil, or something like that in order to spare local circulation?
Yeah, you're absolutely right. These vessels, this was crossing the midline,
These are arachnoidal vessels, they must be preserved, because otherwise you'll have posterior column problem, yeah. You can shift, like you see, I'm not keeping my, this arachnoid cut is not in the midline, it's lateral, because I want to shift this, I want to dissect and I want to shift this vessel to the opposite side, and then I want to identify these posterior midline vessels, but these are the vessels, the posterior ones, which you can partly coagulate, partly you can jump if it's a big one.
Yeah. This technique was conceived, the jumping technique, by another Italian neurosurgeon, Professor Cantore.
Yeah, you're absolutely right. On.
Which you can partly coagulate, partly you can jump if it's a big one. Yeah. This technique was conceived, the jumping
Flat
technique,
dissector.
by another Italian neurosurgeon, Professor Cantore.
Yeah, you're absolutely right. On. Flat dissector. Scissors. Can I find scissors? Scissors. Can I find scissors? Pass me the ultrasound once, please. Let me see if the tumor is going above that. Just put some saline. Pass me the bowl of saline. This is Gina. Hi, Gina. How are you? Dekho. Pass me the ultrasound once, please. Let me see if the tumor is going above that. Just put some saline. Pass me the bowl of saline. This is Gina. Hi, Gina. How are you? When you're using ultrasound, do not touch. Just put a film of water between you. Just पानी डालो. देखो. देखो. Are you there? Sure. नहीं तुमसे पूछो मैं ठीक है ना? अभिषेक. लोअर एंड आ गया. ठीक गुड. अपर एंड सॉरी. सेक्शन बना दो. देखो. Are you there? Sure. नहीं तुमसे पूछो मैं ठीक है ना? अभिषेक. लोअर एंड आ गया. ठीक गुड. अपर एंड सॉरी. सेक्शन बना दो. Diamond knife.
Can we connect you OT-4, please?
Diamond knife.
Can we connect you OT-4, please?
So I'm just, can you hear me?
Yes, sir.
So I'm just fixing the reducer. Okay. I'll show you the parts of the reducer. Where?
So till now, we think that the odontod must have gone down.
Yeah, but I would like to reduce the gap between C2 and, there's a gap is a bit too much. I don't see, I like to reduce it a little bit.
Now we want to like anti-word the odontod. This is the aim now.
Yeah, the aim is normally if the gap is too much, normally the dents is still pointed backwards.
Yes, sir.
So in order to reduce that backward
Yes, sir.
curvature, you need to reduce this gap.
Yes.
So when you when it's slightly anteverted, then the correction becomes very optimal.
like you have put a, what is this called as, you have put on the occiput?
Yeah, I'll show you. Give me a couple of minutes.
Okay.
That's a part of the reducer system which we have designed. After once it reduces, yeah, we need to put the screws first, so that.
Sir, if at all it is possible, can we have the radiological picture now?
Yeah.
Now and after the maneuver is done, the DCR maneuver is
Is
done.
the AM working? Working. Okay, let us do an AM then once.
That would be very great.
Let's have a CT scan once. Yeah, CT.
Yeah. Thank you.
Laminate and partial.
Laminate.
So you did a ultrasound, sir? You got the tumor up there?
Now upper end, I'm going to work lower end.
Okay.
Dr. Sui said you are connected, sir.
I may have to leave a jump away in the vessel. I'll just show you. That's my exposure till now.
So now this is a skip thing you have done.
At the moment, I'll try to mobilize that. If it's not possible, then I'll do a skip.
So saving these arachnoid vessels is paramount.
Yeah.
So now this is a skip.
Otherwise, the patient will have posterior column deficit. If it's not possible, then I'll do a skip. Needle.
So saving these arachnoid vessels is paramount.
Yeah. Otherwise, the patient will have posterior column deficit.
Just for the sake of audience, which gauze needle it is? 24 or?
Do you know which needle is it? 26.
26. It comes with the 2 and 5 ml syringe.
Which syringe is it? 1 mm.
1 ml
This is insulin syringe.
Okay, so that's why it is 26.
Do you know which needle is it? I find this very nice for dissection.
Yes. So it comes with the 2 and 5 ml syringe.
Which
You
syringe?
have taken?
1 mm.
1 ml. The one thing has been done in OT-4. Done. Okay.
This is very nice for dissection.
You have taken? The one thing has been done in OT-4. Done. Okay. No, but
Can we have the lateral fins?
Microcartil.
Yes, OT4 you are connected, sir. Dr. Saras sir? Yes, sir? You are connected, sir.
No, but sir, we are not able to see the full images.
अच्छा अभी तो हुआ ना इसके वजह से
हो गया लेकिन sir, not able to see the subocciput and C1. It is subaxial fins which are seen. Yeah. So it is.
पता
Some people they use a fresh 11 number knife instead of a needle.
I also use that.
Yeah.
But the problem with the tip of the knife is you don't know how deep it can go actually. Okay. I'll be using it now for my dissection, but for the vessels, I feel needle is better. But the problem with the tip of the knife is...
Sir, at this level, can we go in for a frozen section, histopathology or a crush cytology, just to make sure that whether it is ependymoma or astrocytoma?
I can do it, but I think it's an ependymoma, but still I can do it.
Because that will guide for a radical excision or decompression. Or
Yeah, I'll do that. If you want, I'll do that. But looking at it, my first impression is ependymoma.
So looks like ependymoma. There is a plane so far.
Yeah, maybe a possibility of a pilocytic. I cannot rule out at the moment, but still I can pass my fine forceps. But looking at it, my first impression is ependymoma.
So looks like ependymoma. There is a plane. Can you go to Dr. Bharat Chandra's theatre?
I cannot rule out at the moment, but
Yeah.
still I can pass my fine forceps.
Can you go to Dr. Bharat Chandra's theatre? Yeah.
ये दिखाइए ना सर्जरी सेक्शन दिखा दो नीचे और नीचे कर दो हमको Be careful, don't touch. सर्जरी दिखाइए यहाँ कौन है कैमरा वाला कौन है हाँ कहाँ दिख रहा है ये कैसे दिख रहा है ये कैसे दिख रहा है अच्छा आउटपुट ले लिया आपने ठीक है
हाँ इस पे मिड से जाकर
यस सर डायरेक्ट कनेक्टेड है
मिड से हाँ मूव करिए प्लीज yes
okay so now you can see
it has gone down substantially.
Now you can see there is still gap
is still there.
And you can see the universal reducer in position.
Yes, sir.
Okay, you can see the wire looping around the C2.
We can see, sir.
Now you have to, there are spaces in between. Okay, spaces are in perfect position.
Yes, sir.
So now when we compress the OC1 and C2, this gap will completely reduce.
Yes, sir.
Now we can show the cornel also. Spaces दिखाइए cornel में. Can you see the cornel image at the top?
Yes, sir, we can see.
I show the spaces in perfect position. Can see that? Okay.
Yes, sir.
Go up. So can you see the spaces are absolutely in perfect position.
we can see.
Okay. So now they will act like type 1 pivot joint. It's a very simple thing. Now most of the people, they understand this. So once we compress it, we'll do another CT scan, then you can see. So normally we never do. We just do one CT scan again to reduce the radiation.
Yes, sir.
But now because it's a demonstration case, we have done it.
Thank you so much.
Okay. Suction. Bipolar. इसको लूज करो. So am I still connected?
Yeah, you are connected.
So you can see the bleeding stops. You just put a gel film with a gauze. नीचे को expose करो. So I decided to put a C3 and C4 lateral mass screw. I thought that would be best.
So we are avoiding the C2 thing?
C2, you know, it looks a bit thin, and anyway C2, C3 is fused. So I don't want to. Give me drill, C1 drill. Drill. थोड़ा छोड़ दीजिए.
And the CT scan, they look pretty like spacious. The lateral masses of C4, C3 and C4.
Yeah, it looks quite okay.
It is a 2020 rule, sir, you are following?
Pardon?
2020 rule for the insertion of lateral mass, 20 superior and 20 medial angle.
So, yeah, this is not 20 degrees, not so much. If you go, you can fracture. I don't go so much, just slightly. If you go too much, you have a danger of fracturing the lateral mass or purchasing too less of lateral mass.
Less than 20.
Why it is less than 20? I don't go 20. Don't worry about vertebral. Unless you are really determined, you will not hit the vertebral and lateral mass screws.
Patient bucking, patient light.
Which OT, sir?
So far there is no changes in the this thing.
Patient light.
Patient bucking.
Scissors.
Patient light.
Flange sector.
So far there is no changes in the this thing.
Patient light.
Scissors.
Dr. Suri, sir?
Yeah.
So far the monitors is not showing any significant changes.
कोई change तो नहीं है IMN में. Okay. I think they are increased anesthesia dose. Patient was light.
So far the monitors is
All
not
good?
showing any significant changes.
All good.
Okay, sir.
Patient light, so we'll have to find forceps.
Anesthesia dose. Patient was.
Put some. Keep on putting a few drops of saline at some time.
All good? All good.
Okay, sir.
Patient light, so we'll have to find forceps. Keep on putting a few drops of saline at some time.
Dr. Suri,
yeah,
in this part of this operation, absolutely well performed so far, What about the possibility to reduce the tumor volume by debulking with CUSA?
Yeah, I'll do that. I'll do that after this part of the tumor. I've taken the plane till at least another few millimeters on either sides. I am not of the opinion that you're absolutely right, Professor, that we should not be aiming at removing the tumor in toto at the cost of handling the corticospinal tracts. So I will be decompressing in another few minutes after I make some more plane. If, like this, then I'll be decompressing. I believe that decompression makes the tumor dissection much more simpler, especially the most important part is the anterior part, the anterolateral. Like this, then I'll be decompressing. I believe that decompression makes the tumor dissection much more simpler, especially the most important part is the anterior part, the anterolateral. Bipolar. On. On. Figures.
Professor Suri,
yeah,
what prevents you from taking the H stitches?
Taking what?
H stitches of the paya.
I don't want to even do any traction on it because the thing is that when you take stitches in the paya, it's bilateral. At the moment, my one side is absolutely relaxed. I'm just moving on the other side. And I'm actually, if you see my cotton movement, I'm hardly retracting any bit of the paya or the cord. I'm actually just pressing my tumor down, so shifting my tumor to the opposite side and try to create the space. And after a while, I'll do a central decompression. Curious. I actually want to see these vessels. That is the plane. Keep on putting some in, please. And after a while, I'll do a central decompression. Curious.
How frequently you keep on checking the neuro monitor?
Every half an hour, or maybe
How frequently you keep on checking the neuro monitor? How would you know whether the damage is occurred or not occurred? You'd come to know after half an hour?
I know when I'm doing it. If I don't get the plane, that means I'm not in the right place. If I'm on the plane, I can see these blood vessels. But even if I know, I can tell them, why would you get out, right? Or shift to another place, that's all. I don't do it.
Don't give too much importance to the monitor.
Yeah, actually, if you summarize that, yes, you're right. Unless you're polycystic. Now I have a gut feeling it's in the tendon. Now, after a couple of more millimeters, I'll know. Fine forceps? Actually, if you summarize that, yes, you're right. Unless you're polycystic. Now I have a gut feeling it's in the this artery is coming in the middle, so I've just this is hanging in the middle. That makes my tumor a bit more difficult.
We will get back to you soon. Can we have the other theatre, Dr. Sharat Chandras?
Yes, sir. What is for your benefit, sir? Dr. Suresh, sir? Yeah. I have put the AIIMS screws.
Yes, sir.
Can you see that?
Yeah, we can see that.
So now we will reduce it.
Get back to you soon. Can we have the other theatre, Dr. Sharat Chandras?
Yes, sir. What is for your benefit, sir? Dr. Suresh, sir? Yeah. So I have put the AIIMS screws.
Yes, sir.
Can you see that?
Yeah, we can
Yes,
see
sir.
that.
So now we will reduce it. Okay. Give me a needle holder. Let us pass the wire
missed the like insertion of this reducing device. So if
Yeah.
you can like.
We'll just show you.
Okay.
Actually, we should have passed this wire first and then put that. Hmm? So this device has two components. One is a C2 push, one is a compressor, wire compressor, and other is a C2 pusher. So I'll show you both of them. So in this case we don't have to push the C2 forward. So this is the wire. So I will just take a crimp. ये जाने रहा हाँ
Sir, you have fixed this to the occipital bone.
Yeah, so we fixed this to the occipital bone. We tied a wire which is gone. There is a pulley here which comes out of the hole, the wire. Now I'll show you the C2 pusher. एक और है ना इसके साथ एक लगा हुआ clamps. So in severe cases of BI and AD, हाँ ये नहीं यार एक और भी है पुशर एक और भी है इक्विपमेंट नहीं और है देखो नहीं यार एक है मेरा तुम लोग कहाँ खो देते हो और कुछ उसमें देखो दिखाओ मेरे को हाँ इसे यहाँ रखिए यहाँ रखिए हाँ ये है ना इसको खोलिए ओपन दिस हाँ
You have already done the C3-4 screws and put rods in it and fixed the rods, huh?
No. We just put the lateral mass screws.
But there are no rods in the lateral mass screws.
No. So these are the C2 pushers. I'll show you how they work.
Okay.
So there are about 5 sizes. So you have to choose the appropriate size. So this looks like a good size. So now give me the long screw. नहीं इससे भी लॉन्ग स्क्रू है क्या लंबा वाला किससे लंबा स्क्रू है यार एक लंबा स्क्रू दो तुम यार मतलब तुम नहीं मैंने अभी देखा बिल्कुल नहीं मैंने अभी देखा सिस्टर ग्लव दीजिए वहाँ पे दिखाइए एक हाँ खोलिए इसको हाँ ये है ना you can see this is a very long rod. So this, I pass through this. In this case, of course, it's not required because there is no backward listhesis. So now, when I turn this pushes the C2 forwards. Can you understand?
Yes,
It's a simple mechanism.
Yeah, but how are you tilting it? By tightening, crimping the wire?
So it has got two flanges. They sit on the lamina of C2. So when I tighten this, there is a pulley here. So by this it goes forward and pushes the C2 forwards.
Okay, and you'll crimp the wire simultaneously?
Yeah, you have to do it simultaneously. So now I will tighten the wire. So I don't need to. So you can stabilize the C2 lamina. And then there is a special wire tensioner which we have designed. It's not the usual one which is provided. It can sustain force up to 10 times more than the usual wire tensioner. So I put the wire tensioner here. Okay. So I'll just try to withdraw the microscope and show you. Can you see that wire tensioner?
Yes, we can see.
Okay, now. So now we can do both of them simultaneously. We have something to turn this. What turner दीजिए? Screwdriver हाँ दीजिए. So we have this special screwdriver. So we put it on this. और एक साइज होगा. So now we can start tightening the wire. So as you tighten the wire, you will see the run over. इसको कैसे भी ये कुछ हाँ Can you press this? Why is it not moving? Try again. So little by little. ऐसा करो. ये टाइटन क्यों नहीं हो रहा है? No, this is okay. This is only a cramp. अब करो. हाँ. Why is this not working? रैचेट चल रहा, कहाँ चल रहा दिखाइए.
थोड़ा सा उसको नीचे से पुश दे दीजिए स्पाइनल प्रोसेस को.
हाँ बस.
Yeah, it is coming.
अभी. हाँ, so you can see the CT moving up.
Yes, yes, we can.
एक और बार. I think it has already hit the
anterior arch of the
anterior arch of atlas. One more time, so it's not moving anymore. So I will remove this. We can do a CT scan for the benefit of the viewers. इसको निकाल दो. नीचे लॉक हो जाएगा ना इसको. हाँ हाँ इसको यहीं पर रखते हैं. एक वन कर दो. So this is actually a very straightforward case. So we use it for reducing it very, very severe BI and AD. There are some of the extreme BI and ADs.
Sometimes I found that if you take a trajectory for the C2 screw which is more angulated and then compress it on the rod, it will correct the angulation of the odontoid.
That is also another trick.
But the screw should be a monoaxial screw preferably.
That is right. So I have done that in couple of times. But this is a kind of a very standard technique. So anybody can do it. It's a very simple technique. Open.
So let's finish. Yeah, by the time he does the O-arm, we can shift here.
Dr. Suri, can you tell us? Yeah, I'm separating the tumor from the spinal cord. What? Did you send a frozen, sir? Yeah, I've sent frozen, no, Vishuk? Frozen.
Dr. Suri, can you tell us?
Yeah, I'm separating.
So you're using CUSA also in this?
हाँ, decompress किया क्योंकि it was bulging very badly. I wanted to create a spleen, तो मैंने कर दिया CUSA for decompress किया, central decompression. It's making the plane better.
And any changes on neuromonitoring?
Not yet.
Can we see the screen of the neuromonitoring?
Very badly. I wanted to create a spleen, तो मैंने कर दिया CUSA for decompression. You know, biopsy.
And any changes on neuromonitoring?
Not yet.
Can we see the screen of the neuromonitoring?
You know, biopsy.
Grossly, it looks like an ependymoma.
Yeah.
But the plane is somehow not that good.
That will.
Grossly, it looks like an ependymoma.
Biopsy.
But the plane is somehow not that good.
That will. Fine forceps.
We can shift to OT1.
Biopsy.
OT1, you are connected, sir. Dr. Kolosov?
Fine forceps.
Yeah.
Depot. Yeah, no.
We can shift to OT1. Repeat question, please. Dr. Kolosov, we are with you.
Make release soft tissue around.
Repeat question, please. Dr. Kolosov, we are with you.
Make release soft tissue around spinal cord near previous surgery and big scars here.
So there seems to be a 3-level or 2-level laminectomy already done.
Give me footsteps. Yeah. Here is defect after laminectomy.
Dr. Ramesh?
Yeah. And there are a lot of scars. Before osteotomy, I tried to make release this level because when we will do correction, scars maybe give spinal cord compression.
Right.
So the post-laminectomy scarring that you're trying to remove.
This was already a defect from the previous surgery.
Yes. Ramesh, can you also put in a mic on yourself so that you can transcribe for Dr. Kolosov?
Hello.
We are not able to hear you properly. Have that mic put and we'll come back to it. We shift to OT-4.
Yes, sir. OT-4 you are connected, sir. Dr. Saraf, we are midline picture. So we are seeing the okay. So that looks satisfactory. So sometimes, I don't get complete bony opposition because there are ligaments in between. So in this case, we were, that was the maximum we could go. We could feel the bony thing, but it's okay.
So can you compare the image before you tightened the wire with the image after tightening the wire?
पहले वाला इमेज दिखा सकते हैं?
जब वायर टाइटन नहीं किया था
नहीं आएगा.
नहीं आएगा. ठीक है, कोई बात नहीं. कितना डिस्टेंस था?
तो ऐसे ही दिखा दीजिए.
Between the atlas.
पहले वाला दिखाइए.
This was the one before tightening the wire. Sagittal image.
Yeah, I think the tilt has improved a bit.
Tilt has improved a bit.
It's okay, I'm satisfied.
Yeah, that's I just wanted to know what the wire is.
Can you see the pre-op नहीं हुआ ना इसमें? Pre-op, हाँ, ठीक है.
Pre-op तो CT scan था ना, उसमें दिखा था.
हाँ, but not on the arm.
No, not on the arm.
So we'll go ahead and fix it.
Yes. So now what you will do, you will...
we'll put the rod and fix it. Now the occipital clamp what we have put, we put it away from the midline. So that on one side we put the screws to the midline and then we remove the occipital clamp.
So the question is, the bone is thickest in the center, median. So this is the right ideal position for the screw to go, like for the occipital plate.
That's right.
So putting a lateral plate, is it going to like stay there?
No, what I'm saying is this
because this is obstructing the ideal.
No. I'll just show you what I mean. So you see this occipital plate?
Yeah.
This occipital plate is not in the midline. It is away from the midline.
Okay.
So when I put the screws, it goes exactly in the midline. And once I put it on one side, then I remove the occipital plate.
Okay.
So then I put it from the opposite side, then that also goes in the midline. So these are screws which go in a skew. So they transit each other's in space and they provide a very good stability. A template.
So at one point of time, the whole construct would be like dependent on just one side of the screws.
Yes. It doesn't make a difference. That's quite stable. So that is the best way I found, because if you put it in the midline, then you will lose the advantage of the midline. So I put it slightly away from the midline.
Dr. Chandra.
Yes, sir.
Just a couple of observations. First of all, a question. Which the name of the head holder you're using? Mayfield head holder or what?
For the head?
Head holder.
Oh, the head is on a, it's on a horseshoe. We're not kept it on a Mayfield.
With pins, without pins?
Without pins.
Without pins, okay. Second question. In your opinion, which is the amount of reduction for jamming procedures and for cable procedures?
I'm sorry, I didn't understand your question. Could you repeat it?
with the jamming procedures with the graft in between C1, C2 lateral masses, we have a reduction as well. But you improve this reduction with cable procedures.
That's right.
And in your opinion, which is the best, cable procedure or jamming or grafting procedures in reduction?
Oh, jamming.
Jamming is the best.
See, no. Jamming is not the best.
Not the best.
Because if you just
this is against the Atul Goel theory.
Yeah. It's not. You have to loosen the spacer. You have to put a spacer because spacer only leads to distraction.
Yeah.
It doesn't correct the deformity. It doesn't correct the angulation. So for correcting the angulation, you need to provide compressive forces between the OC1 and C2. That's what I've shown in here. And some severe cases, you will have to push the C2 forward. So that's what we have in our reducer here.
Okay.
So reducer, we also have a technique to push the C2 forward. So you have to do additional manipulation. Just a distraction is not enough.
And as far as I understand, this is an occipital cervical instrumentation infusion procedure, isn't it? Do you confirm it?
Yes, this is an occipital cervical fusion
perfect.
procedure.
And in my experience, even with Mayfield with pins, head holder, by performing some kind of forces in during the instrumentation procedures, is it possible to reduce? I published a paper 2009, if I'm not wrong, with Mayfield.
That's right. I read your paper.
Yeah.
So I read your paper, yes, with Mayfield as...
I called it the always posterior strategy, since I proved that it is possible to reduce, even it doesn't seem during the operation. As soon as you release the head holder after the operation, you face with immediate reduction operated by the hardware. And how this observation can fit with your observation?
So yes, you can reduce it. See, you could do it in different ways. Reducing it with Mayfield is a good enough technique. But the advantage of this technique is that you are applying forces where it matters. So you are right at the C1, C2, and that is where you are maneuvering. So that's the reason we believe that provides the best opportunity to reduce it optimally. But yes, various people have described, Dr. Patkar doesn't believe in this technique. He says, I will do everything anterior. But yes, we have been doing this. So I would have done maybe 500 of these cases.
I am not saying I don't believe it, my dear. I am never said anything like that. But what I want to know is that if you are using the Mayfield, you need somebody after you expose the muscles, open the joints to manipulate the Mayfield and realign it. Is my understanding correct?
Yeah, that is what he's asking. We think it's not necessary.
Yeah, because that Mayfield will be fixed before surgery.
Yes.
And as you open the joints and you manipulate the joints, you require somebody to loosen the Mayfield, no?
No, he speaks of, tilting the Mayfield with the pins in position.
Correct, but somebody has to do that intra-op, halfway, after you open the joints.
Yeah.
Because that Mayfield was put when you started the surgery.
C1. So that goes right up to the midline. It's a very low profile clamp system. C100.
Dr. Chandra,
Dr. Chandra.
Yes, please.
I have a devil's question over here.
Yeah, please.
Do you get CSF, if at all you get a CSF leak while you do this drilling?
Yeah. Very quite commonly. Don't worry. Just put the screw.
Okay.
But don't compromise on bicortical perches.
Uh-huh.
Don't be afraid of CSF leak and compromise on bicortical perches.
Okay.
See, bicortical perches and the screws, going from lateral to medial is a must for your occipital implant to hold on.
Excellent. And then the lower screws that you have put into the C2, C3 area, are you going to do a fusion across it?
4.5 to aluminum. I'm sorry. Yeah. We are going to put bone.
Okay.
We're going to fusion has to be done. You cannot compromise on fusion.
Got it.
Dr. Sharad? Yes, please.
No, I'm just taking the
Tap. Yes, Deepak. Tap.
So we'll shift. One question.
We have done the fusion between C1 and C2, sir. Is that not enough?
For what? For not putting the bone?
No. We have done a spacer filled with hydroxyapatite crystals.
That's right.
So is that fusion not enough?
No, we need to put some bone and do a good fusion laterally. No, we will. So after, if you do a CT scan after 7-8 months, there is a solid fusion. Which happens. I won't depend just on the spacer fusion. The hydroxyapatite is very less there. I like to have very good fusion laterally. These are very severe deformities. The forces on these deformities are very, very severe.
On that note, I would like to ask Dr. Patkar. You say, and which is of course the orthopedic principle, that the bone graft has to be under compression along the vectors of the forces. Now when we put a posterolateral graft over here, what do we expect? Do we expect a solid fusion? Do you expect...
According to me, even if you put tibia fibula on a big piece between the occiput and the spinous processes or onlay graft on the joint, they are of no use. Because that's not a line of weight transmission. If you want to do, you should put them inside the joints.
That's right.
There's no point in putting onlay, because onlay grafts, whatever you do, the weight is not getting transmitted through that.
C1
If you want the bone graft should be at the site where the weight is getting transmitted. In the cervical spine, C1, C2 is going through the joint, and the subaxial spine, apart from the ventral disc, it is also going through the facet joints. So I would rather drill in the facet joint and push pieces inside the facet joint.
You can see there is some CSF leak there.
Yes. Professor Sarachandra, do you evaluate the CT scan before and decide where you are going to put these occipital screws?
Initially I was, but now it's okay.
Now you don't bother?
No.
Because you would like to put them where the bone is thickest, no?
That's right. I mean, this is where it is thickest. Invariably.
On the scan?
Yeah.
Okay.
But never compromise on the bicortical. That's very important.
Yeah.
Don't worry about the CSF leak.
That I accept. Even that there is Dr. Deepak Singh who has got this technique where he makes a small burrow and he's got that screw with a plate which goes inside, and the screw comes. Have you seen that?
Yes, I have seen that.
Deepak Singh, and that looks quite scientific,
Yes. 4.5?
He makes a hole on the side and he's got a kind of gadget where it goes inside and the screw comes up from inside. Correct.
Final type, no?
So we'll join back in a moment.
Okay, Deepak.
We can shift to OT1.
That side, rod also when it is placed, I'll just show you once.
Right, sir. Please, sir. OT1.
Final type, no?
Yes, sir. OT1 you are connected, sir. Ramesh, can you hear us? Doctor.
Yeah.
Please tell us what are you doing?
We check screws. Good. An X-ray control.
Your screw looks very good. Can you please orient us into the surgical field, up to what stage you have reached and what would be the further plan? I think you're about to start your osteotomy now, right?
All screws is good position. Yeah.
Yeah. You've got nice convergent screws at all levels. I think when we put all these convergent screws, it increases the pull-out spin. Right, Dr. Kosa?
Yeah, yeah. We have checked on X-ray position of the screws. I'm not, I can't see all screws clear, but I feel that all position is good.
Yeah. If I may ask this, usually when we put in the screws, the dictum is that they should not be crossing the midline. Otherwise, we are medializing it too far away. What is your thought process, or do you take a even further lateral entry to have this kind of a medialization?
Mini camera zooming? Don't understand.
Okay. How far medial do you want to go with those screws? Are you okay crossing the midline in the X-ray?
Can you please table? All screws in the bone, no contact with spinal canal. I feel with this filler it's good. Yeah, it's no problem. It's very good for prophylaxis of migration.
Dr. Kolesov,
Yeah.
is the entry point of the screw intrapedicular or extrapedicular?
I think mix. Maybe a little extrapedicular, maybe, but the most intrapedicular.
Yeah, that's why they are so much converging medially, because probably they engage the bone laterally to the pedicle.
Can we shift to OT-3 and see the status? OT-3 camera on further.
Oh, yeah, stimulation.
Yeah.
Okay. Did you find the electrode? Okay. We will start from L4 to the right side. Middle.
OT-3 shift करना. Shift to OT-3.
Okay.
Dr. Rajesh. Sir, not ready. OT-3.
L4 to the right.
We want to see the position of the patient. Okay, sir. Okay. राजेश जी माइक लगा दीजिए डॉक्टर राजीव सर को. Dr. Rajesh, can you just tell us the position of the patient? Is it Wilson frame?
Rajesh, can you hear us? Because yesterday Dr. Park was saying that he wants his hands on the sides, not up.
No, I think we will get it. We will get it. इधर पे इधर पे इधर पे इधर तक हो जाएगा. Let's see. If not, we still have can.
You can do more और कर लो ना थोड़ा सा और सर
हो जाएगा सर.
हाँ राजेश.
7 तक हो जाएगा.
We can hear you now. राजेश मीना.
करते हैं अभी. उठाओ पेशेंट उठाओ. ये वाला पोस्टर भी ठीक होगा.
I think there's something important going on in OT-1. Can we go on? Shift, yeah?
Shift to OT-1.
Yeah, OT-1. Also, can you please tell us what you're doing with those screws? I think you're using a stimulator to check the position of your screws.
Yeah. We're making stimulation of the screws and check is there contact with spinal canal or nerve roots or not. Okay.
And
L4, 3, 2, and 1. Okay.
so if the screw is not right, how would the EMG tell you what kind of signals you would get on neuromonitoring?
Everything okay? Okay. Let's continue. The dissectors.
Dr. Kolsa.
Dr. Koloso, I had a question for you. In scoliosis, the vertebral body is rotated, so the pedicles are straighter on one side and more convergent on other side. So how do you decide intraoperatively how much mediolateral angulation you require for the screws so that you can place them correctly without breaching?
I just feel pedicle because when we have very severe deformity like this, it's very difficult to feel right way for the vertebral body. But I use transverse process, just try to estimate the degree of rotation of the vertebral body. Up part, thoracic, it's straight, it's no problem introducing screws. Low part, more or less too. Here it's just, I try in, out, in method and try to feel the pedicle screws way.
And I think over a period with so much of experience, you get that two-dimensional orientation about how the pedicles would be, what kind of angulation you would need. So usually when you look at it from behind, the spinous processes they tilt away from the convexity.
Yeah.
So you have to kind of eyeball it well and just make sure that you're not probably not crossing into the canal when you put in that screw.
Bleeding. Maybe try ultrasonic. No.
So we'll get back to you. Can we shift to Dr. Saran Chandra's theatre?
Yes, sir. Dr. Saraj sir, you are connected, sir.
Yeah, I'm just finishing. Okay, I've just fixed on the opposite side.
Okay.
So you can see we are bang on the midline.
We are on the midline, yes, sir.
C1.
Screwdriver. My apprehension was just at one point of time only one rod was bearing all the reduction.
Oh, it doesn't matter.
See, this thing is not like a rubber band. You know, once you have distracted, once you reduce the deformity, it stays there. Initially, that was also my apprehension. So I used to think that that doesn't move. It's quite good enough. These are all valid apprehensions, and one should have all these apprehensions. 12. One tip is don't, when you do the drilling, please don't suck out the bone dust.
So we'll just come back to you. Shift to OT1. Dr. Kolosov wants to show something.
Yes, sir. OT1, you are connected, sir.
Dr. Kolosov? Yeah. Main screen पे नहीं आया. Dr. Kolosov, can you show us what you're doing with the bone juicer?
Now using ultrasonic bone scalpel for posterior osteotomy.
So are you trying to
Just between screws.
vertebral level?
Yeah, just between screws. Maybe small.
ये देखो ना पीछे पैटी जो डाला पूरा. Dr. Kolsa, can you reorient your camera so that we can see that end on? We are probably missing out on the most important step of this surgery.
Yeah.
Let the camera be overhead, coming from midline, I guess.
Camera zoom out.
Maybe.
No, they want it like this. Try karo. Udhar se. Is it okay?
Better.
Better?
Yeah, no, more, you have to reorient it more. Focus on that apex of the deformity where doctor is working. Yeah. Yeah, too bright.
Exactly.
Brightness ज़्यादा है.
Yeah, perfect. Can you take the camera overhead, Dr. Kolsa, so that we can get a better view over his shoulder?
Smaller.
It will be a bit difficult. Huh?
In this case, it's impossible because the microscope let us possibility work on the very narrow space. I should make control of deformity because I use just binocular glasses. Yeah, it's spinal cord. Yeah, I try. Yeah. It's posterior part of the facet joints fusion.
Dr. Kolosov, one question. So, are you doing asymmetric point osteotomies or symmetric?
I try do a little asymmetrical.
Okay.
Okay.
And just at the level of the cube.
Ultrasonic scalpel. Yeah. Let's do here. Yeah. Fusion part. Yeah. Awesome. restricted, please. Yeah. Yeah. Wait 1 moment. Try do this, yeah. Yeah. Rib maybe try to cut here. Give me just some. Monopolo? Oh, just this one. Yeah. Correct. Yeah. Yep. Small, yeah.
So while Dr. Kolsa is doing this and focusing on that surgery, I can just take you through those steps, what he is trying to do. So there's a hemivertebra over there, which is being the driver of the deformity on the right side. So Dr. Kolsa has identified that hemivertebra and he has put in screws one level above and below it. And now he's trying to remove that hemivertebra completely. And before going there, he has to do a laminectomy and remove the facet joints above and below that vertebra.
Hello. Switch on the audio OT4. OT4 you are connected, sir. Dr. Saras sir, you are connected, sir.
Yeah, Dr. Deepak?
Yes, sir.
Hello?
Yes, sir, we are with you.
So I finished, I just want to show you. Okay. So this is a 3-point fixation. You can see it's a very good and rigid fixation.
Right, sir.
So that's it. Surgery is over. We'll now put, Dr. Kamaljit will now put the bone graft.
Thank you, sir.
That's it. Thank you very much.
Very nice demonstration.
Thank you.
Go back OT number 1. OT1 you are connected, sir.
So he's trying to remove the facets, then identify the nerve root. And most of the times when you have to do this hemivertebrectomy, you have to ligate the nerve root at that level. So I think this might be around the thoracolumbar junction D12. It's okay to ligate that nerve root. Up to L1 probably you can ligate it, but below that it gets riskier.
Maybe, yeah. I think it can be.
It's difficult in this case because it was operated before. You tend to lose all those landmarks. There are more adhesions. You have to be much more careful than doing it in a primary case. So he's trying to gradually get in there, do a complete facetectomy, and we have to remember that it's not a not a normal spine. This spine is rotated completely, almost 90 degrees. So the moment that he does the facetectomy, does a lateral dissection, the vertebra is going to be looking at him.
Do you have smaller?
Dr. Kolsa,
Yeah.
what is that surface that you are working out on right now?
I'm making resection posterior elements on the right side where they were fused after previous surgery.
Were you able to identify the disc space above and below the hemivertebra?
I think it's a little maybe more close to, I think close to hemivertebra.
Okay.
Yeah.
So he has identified the neural elements, the dura, and then working lateral from there.
Dr. Suri, we are there with you.
Yeah, this difficult tumor, as we expected, it will have a good plane. After the first 5 millimeters on the lateral side, there is actually no plane. I'm trying to create a plane. Frozen section is a pendulum.
Okay.
The pre-op IOM, the MEP only had pre-op on the right side, AHL. The rest was not there at all. But the patient that they said initially improved. There's a very small dip now, but the thing is that the rest of the waves are not. The rest of the left side में तो पहले भी नहीं था. I'm trying to create a plane, but that's not there. On. I thought now it looks like more of a pyrocytic. But the frozen people now say it's an ependymoma.
Dr. Suri, pardon my question, I'm an orthopedic spine surgeon. What is the goal in this surgery? Is it a complete removal of the tumor along with clear margins? So what exactly do you intend to do in this?
Yeah, neurosurgery is not a cytoreduction, it's not a clear margin surgery. It is basically, we gain a preoperative impression of a ependymoma. The goal of ependymoma surgery is complete excision.
Okay.
Even if the other differential is a pilocytic astrocytoma, again it's a benign tumor. Again, the goal is complete excision or maybe a near total excision. If you remove, it recurs.
Okay.
And second surgery is always worse than the first one.
Right.
So you have to do the best in your first. Wow.
Interesting.
Time passes.
We shift to OT3. Yes, sir. OT3, Dr. Rajesh se connected or? We shift to OT3. Yes, sir. OT3, Dr. Rajesh se connected audio. He was not able to listen to us last time. आवाज आ रही है क्या?
ये सर एक मिनट माइक लगा रहे सर.
हेलो. हाँ राजेश.
गुड आफ्टरनून सर.
गुड आफ्टरनून. कैन यू एक्सप्लेन एक बार MRI दिखा दो.
So this case, cameraman. So this is the second case of our OT, sir. So basically, it is a case of spastic paraparesis. Patient has D10, D11 ligamentum flavum hypertrophy.
Okay.
So there is a calcified ligamentum flavum seen in this CT film, sag cuts and axial cuts of the CT films. This is calcification which is seen here.
Right. And plan is?
Plan is to do UV and remove that calcified ligamentum flavum.
So biportal again?
Yeah, biportal again.
And this is at level of D?
It is at the level of D10, D11, sir.
D10, D11 is the most dangerous level.
Sir.
So what is the power right now of the patient?
Patient is power 4/5 bilateral lower limbs with spasticity, sir.
Spasticity. ठीक है. And the position you are prone on bolster or Wilson frame or what?
Sir, we have positioned the patient on bolsters, sir, 2 bolster, one at the level of the chest and other at the level of the hip.
And is the patient shifted towards the side of the surgeon or is in the midline on the table?
It's on the midline of the table and the arms are hanging towards the head so that it doesn't come in our X-ray view. It doesn't obliterate our X-ray imaging.
Okay.
So we have marked the levels. Now we are just doing painting and draping.
So on the CT there was ossification seen at both D10 and D9 or it's only at one level?
It's only at one level, sir.
That is D10.
D10 and D11 there was a calcified disc also and also the ligamentum flavum hypertrophy at that level.
So your approach will be between D10 11, yeah.
So we are planning for that docking that lamina exposure will be at the D11 level. Then we go cranially and remove that ligamentum flavum.
Then we go, okay. How long will it be before you start?
Sir, I think within half an hour we should be able to start.
We shift to OT1.
Yes, sir. OT1 you are connected, sir.
Yeah. So Dr. Kolsa.
Yeah.
I see that you've done a bilateral facetectomy over there, right?
Yeah, I tried because it's he is very bad anatomy, and I try to recognize who is who.
I know. It gets very difficult in these revision cases to identify all those landmarks.
I try don't do resection of the body because if we do resection of the body, it's increased time of surgery, bleeding, and other problem. Anterior part of the vertebral column, not fusion. I try to make mobilization posterior part of this spine and do this part more mobility. And by the way, we have mobility here, and I try to increase as much as possible mobility of the spine.
Right. So you don't intend to remove the hemivertebra completely?
Because I try to do the surgery more simple as possible in this situation.
Yeah, got it. So there are various ways of correcting this deformity. One way would be being aggressive, removing the hemivertebra.
I'm not at home because I should be careful in 2 times.
And the other way is what Dr. Kolso is doing, a little bit safer, resecting the facets and trying to get whatever optimal correction he would get from there.
Okay.
You could even, rather than doing a complete vertebrectomy, one can even decancellate the hemivertebra and just try to crumple it, eggshell it and crumple it down to get a correction. That is one way that it can be done.
Yeah. Okay. I mean, usual, right?
Dr. Kolsa?
Yeah.
There's a question over here. How much has been the blood loss till now?
How many? 300 milliliters, not too big.
Oh, that's very low for this surgery.
Professor Kolosov?
Yeah.
So why have you opted for 100% screw density for this case? Why not less?
Repeat please.
Why have you opted for 100% screw density in this case? Why not lesser?
Do you understand?
Why not skip some levels?
Screw density?
Yes.
Yes, I feel bone quality each level, and according to my feeling, I feel that pedicle screws introduced it very hard, very solid. Bone quality quite good here.
So that is why he is asking
Yeah.
why not skip this.
So what doctor is trying to ask is why have you put pedicle screws at each level versus in AIS usually we skip a few levels. The density is 1.6 roughly in AIS.
Because he has big potential of the growth, and for prophylaxis any problem with growth of the spine, we should make fixation each level.
Right. And probably in this case, if you're fixing each level, you can possibly get a gradual correction, a few degrees from each level, and that can possibly give a better correction and better corrective forces, right?
Yeah. Yeah, yeah. Moving. Moving. Good. Okay. Give me rod. Maybe I go there. Yeah. Oh, sorry. Yep, please. Yeah, I think so. Do you have cutter?
Dr. Kosa?
Yeah.
Are you going to pre-contour these rods to a certain extent to correct your deformity? What are your thought processes while you do this?
Yes, I tried to pre-contouring rod, but I tried to do correction, and yes, I try pre-contouring rod. I'm doing which side is better for correction, convex or concave. I think maybe that. Начнем с этой. Yeah. Here. Open. No. Cut. No. French bending. Yeah. set screw. Hold this, please. Yeah. Yeah. Next. Cup. Okay. Give me.
Dr. Kolsa,
Yeah.
how do you decide between whether you're going to...
In situ bender, please.
How would you decide between concave rod first or a convex rod first?
I try with concave. With concave side because the cathotic on this side a little less.
Okay.
I try to make correction here, the first. And now you should check monitoring and say if will be any problem.
It seems to be correcting as you cantilever the rod.
No. Okay. Yeah. Give me. That's another one. And do you have rocker? Rocker. Just give me, please. Here. And you see quite good mobility. Because it's more safe for him. Maybe if I will be at home, I make resection with this part of the vertebral body. Maybe we'll do it. Yeah. What? Don't think. Set screw. Yeah. One and another one. And do you have cutter in situ? I think we should make resection this part.
Yeah, I think with the resection you're going to get a much better correction. Probably the kyphosis and the scoliosis, both those deformities would get corrected.
Yeah. You have in situ, yeah? And retractor, yeah. Yeah. Because not comfortable do this because very difficult detect real length of the rod. Yeah. I think we will do this part of resection in screen out and maybe do a little resection vertebral body. Yeah. Yeah, 12, right? 12. Oh, no problem. Yeah. I think it will be good. A little mobile, because I fixed it, this. Quite, it's not ideal, but not ideal mobility, but good.
So, as this action is going on, and we have OT and our team is always connected. So what we can do, we can start with a few of the talk, and when they have any problem, any important finding, those will be always relayed on 4 TVs. They will be not stopped. So you keep watching OT1, 2, 3, 4. At any point they have some important finding, they will ask us to stop the lecture. So that is, so that we can discuss it and come back to the lecture again. So I invite Professor Massimiliano to start with his talk on CV junction 360-degree fixation. Yeah, Professor Colezo?
Yeah.
Yeah, we'll be coming back to you. Yeah. Meanwhile, we'll be starting with one talk by Professor Massimiliano. And if any finding or thing, you can come back to us so that we can discuss. Ramesh?
Okay, good evening to everybody. It is a great honor for me to attend this beautiful, wonderful cadaveric and clinical course on complex spine surgery. I really thanks the organizer, Professor Kale, and also Professor Singh, and all of you that are providing this outstanding situation. I feel a little bit Indian because it's since many years I attend Indian congresses, especially in Mumbai by my friend Professor Atul Goel. recently my co-chair in the Neurorehabilitation Committee of the World Federation, Professor Virendra Singh, organized in March a beautiful meeting. I attended also, and at the beginning of this month also was invited by Professor Atul Goel and attended in Mumbai another beautiful congress. The topic that I have to fit with in this evening is the surgical approach strategies to the craniovertebral junction. As you all know, craniovertebral junction it is not an organ, but it is an ideal segmentation of the skull base and the upper cervical spine that takes the name craniovertebral junction, inferior third of the clivus C1 and the superior two-third of C2. This complex anatomic area is quite complicated by a very, very full vascular network we have to deal with by attempting to spare the most eloquent vessel feeding eloquent neurological area. Our group spent many years in trying to better understand both anatomical, anatomopathological, and clinical issue dealing with craniovertebral junction, and we published in different issue our experience and the experience of our friends. But everything starts from cadaver lab. Cadaver lab is the issue. Cadaver lab is the topic. By attending cadaver lab, we can try to understand at the best which are the surgical way to deal with craniovertebral junction. Transmucosal anterior, transnasal, transoral, extramucosal anterior, retropharyngeal, extramucosal approach, anterolateral or extreme lateral, posterolateral or far lateral, posterior midline approach, all dealing with vessel, with the bone, with meninges, with neurological structure and bundles. This is our last paper. We published to try to fit different surgical approach, 360-degree surgical approach to the craniovertebral junction according to the position, the volume, the size, the extension of chordomas. But the concept is valid as well for any other degenerative, vascular, oncologic, or inflammatory disease. Posterolateral approach and anterolateral approach. This is the issue, and these approach are quite similar but different for the position, posterolateral park bench, and true anterior approach to the bulbomedullary junction, although despite the name postero, it is an anterior approach to the bulbomedullary junction and is mainly indicated for intradural lesion and for controlling at the best vertebral artery. On the other hand, anterolateral approach, different from the first for supine position and for skin incision, is much more suitable for extradural approach, but it has the privilege to control at the same time both carotid artery and vertebral artery and jugular vein as well. These are some pictures of our cadaver lab, and this is one clinical case we approached for a schwannoma, high located at the cervical spine, that we try to identify intraoperatively with the echo-color Doppler and remove with these extra extramucosal approach. But when we speak about anterior approach to the craniovertebral junction, we have immediately to consider transmucosal and extramucosal approach, since transmucosal has some drawbacks linked with the possible contamination of CSF with intrapharyngeal matter, and extramucosal much more safe from an infectivological point of view, but uneasy, as demonstrated by this slide. This is a classic submandibular retropharyngeal approach, very well known by ENT surgeons. 2 fingers below the mandibula, we have to identify immediately the submandibular gland, the tendon of the gastric muscle. We detach the tendon from the hyoid bone. We identify the hypoglossal nerve, we shift it up, and we try also to identify the superior laryngeal nerve at the bottom of the surgical field. We shift it down, and we can spread laterally pharynx, mylohyoid muscle medially, and the tripod vertebral laterally. And we control the upper part, the lower part of craniovertebral junction. This is a cadaveric specimen, submandibular gland. We shift it up. We identify the tendon of the gastric nerve. We detach it from the hyoid bone. We identified also the hypoglossal artery, and we shift it down. But if you look at here, we have hypoglossal nerve that we have shifted up and down. We can see the superior laryngeal nerve. This nerve is the explanation why submandibular approach was conceived by the neurosurgeon to control craniovertebral junction. Since we cannot prolong the Clower approach for the upper subaxial cervical spine, because in this case we should injure the superior laryngeal nerve. So we need of a different approach, jumping over the superior laryngeal nerve and allowing a fair control of the odontoid. This is a beautiful paper of Professor Salle, who compared transnasal, transoral, submandibular, Volinsky approach, which is transcervical endoscopic, not submandibular. And according to Salle, submandibular approach should have a great control of craniovertebral junction. But we will see in the next slides that this is not so, although cadaveric specimens are very satisfying, and this video show us a fair surgical control of this area. Also, this other specimen, when we put the crocar distractor inside the mouth and also approach by submandibular, you can see here the tip of the crocar or the cocker forceps reaching the same target, but with a different angulation, with a very sharp, uneasy, uncomfortable angulation compared to transoral. This is submandibular approach with the classic rotation, 15-degree on the contralateral side. O-arm is important to orientate, is mandatory to orientate. Neuronavigation is the key to perform without ENT help this complex surgery. We try to simplify submandibular approach from 14 steps up to 3 steps. We will show better tomorrow when we will speak about chordomas of submandibular area of craniovertebral junction. But you see here that the key of this simplified submandibular approach is just to identify the lateral horn of the hyoid bone, just to shift it immediately, and with the finger according to the Cloward surgical technique that we are easy and used to perform, we immediately reach the odontoid without dissecting the tendon of the gastric muscle from the yoid bone. Another way to reach craniovertebral junction is a transnasal approach. It is a transmucosal approach with a limit. It controls only the tip of the odontoid and not fairly the anterior arc of C1. And it has some anatomic limitation to manage the skin and the bone. But it is mandatory for this type of basilar invagination. Type 2, according to Goa classification, the one associated with the platybasia, not reducible, and this kind of basilar invagination has this strange embryological origin that make mandatory transnasal. Transoral is not enough. Submandibular absolutely out. Only transnasal. When we deal with basilar invagination and Chiari, we deal with 1.5 Chiari according to the newest classification. And according to the Consensus Conference 2019, the therapy for Chiari malformation 1.5 associated with basilar invagination is decompression of basilar invagination and instrumentation infusion. Otherwise, if basilar invagination is reducible, the therapy is instrumentation infusion in extension. So the functional decompression of basilar invagination might be reached by fixation in extension according to Chandra beautiful experience. The limit of transnasal approach is that it has a good control of the clivus, I should say optimal control, but insufficient control of C2. This is a case I operated by transnasal approach. It was an irreducible basilar invagination associated with platybasia and assimilation of C1 to C0. And you can see here that the Eustachian tube are the reference point to identify C0, C1, and to move toward the odontoid, which might be removed post-op decompression. But this is another awful monster case of oral pharyngeal chordoma, which has wide diffusion at the skull base, and with DNT we identified here the carotid artery, and we performed the peeling of carotid artery, and by moving out the endoscope we get in the mouth with the cochlear distractor and complete removal in the retropharyngeal space. As soon as we finish with the endoscope, we take again the microscope. About transoral. Transoral is much suitable for low located craniovertebral junction lesion, since it controls in a fair way the inferior third of the clivus, all C1, all the odontoid. It has drawback, the anesthesiologist, because the anesthesiologist push you to perform tracheostomy because of simplifying anesthesiological management. We perform several endoscope-assisted approach as well as microsurgical assisted approach. We reviewed the literature. We try to publish also some more observation starting from our experience, and our conclusions are that neuronavigation also in approach is absolutely useful, but also exoscope and OARM neuronavigation are the new entries we have to face with in order to be updated in a transoral approach to the craniovertebral junction, as demonstrated by some cases we have performed in our department. What I'm doing, trying to show you now is a very instructive and explicating clinical case of synovial cyst, not chordoma, despite the title of the slide, but this is a huge synovial cyst compressing the bulbomedullary junction, engaging the craniovertebral junction, and we can see here the crocar distractor, the tongue spreader, lateral pharynx spreader, here the superior dental arcade, and this is the profile of the odontoid after removing the anterior arc of C1, and as soon as we use the CUSA, we get in the core of the odontoid, and removing it quite totally, we can expose fairly the transverse ligament, which is removed piecemeal by the Ronger. And you can see the endoscope is very useful in this step because it allows us to identify the reason of our surgical approach, which is the compression of the synovial cyst, which is engaged and taken out with pituitary. After the compression, we inject some contrast medium in order to have idea of what we removed. This happened before neuronavigation, of course, before OARM. This is a very old video, and with sponge inside and glue, we close in 3 layers the mucosa, and pay attention, 3 layers, not 2 layers, otherwise the mucosa can open, and the compression seems quite satisfying. Posterior instrumentation infusion is mandatory, as in this case, this is a patient with non-union of C2 fracture with a huge severe compression of bulbomedullary junction with myelopathy. After surgery, decompression, instrumentation, and good control. But what the literature says about transnasal and transoral, which is better? Is it possible to say this is better than the other? Are we looking for the winner, or are we looking for the best treatment for the right patient? This is the question we have to rise up. And this is the group of Benzel, which studied transnasal, transoral, and surprisingly, transnasal approach is the most accountable for velopalatin palsy, for CSF leak, for post-op infection, despite the original idea of Cassan that transnasal was safer and more sparing compared to transoral. On the other hand, transoral is much more accountable for tracheostomy, which is mainly requested by anesthesiologists. So look at this very strange situation. This is a child that was harboring a platybasia and a basilar invagination. So Chiari 1.5, look at the tonsillar herniation. This is a Chiari formation according to Goel classification. We removed very satisfying all the clivus, C1, and as demonstrated by CAT scan MRI. But some months later on, you can face with a regrowth of both the odontoid and the clivus. You see here, and as soon as the odontoid regrows and impinge the posterior cranial fossa, the chiari formation pop up again. And pay attention, this patient has an occipital instrumentation fusion. So this is an experimental, involuntary demonstration that the theory that to fix the craniovertebral junction is the therapy for chiari formation is the demonstration that this theory doesn't work 100% of the cases, but it depends on the presence of an impingement of the anterior part of posterior cranial fossa driven by the basilar invagination. This is another case of non-union. Despite the fair CAT scan post-op, due to the macroglossia of the patient, the real result, immediate real result, is unfair. You can see here the sensation that the compression is still here before and after. I don't find any improvement in this MRI, but 10 months later on, we have a clear improvement, demonstrating that craniovertebral junction surgery needs time to be checked, to be proved, and to state that the follow-up is reliable. This is another way that I don't like to reach extra-mucosally with craniovertebral junction, trans-cervical endoscopic approach, the same approach that was used for screwing the fracture of odontoid. This is the typical target for C2 odontoid fracture in a cadaver lab, you can see here, and then it is the same surgical way to deal with the odontoid by endoscope for removing the odontoid. The limit is that you cannot reach the anterior arc of C1, you can reach only, but not totally, the odontoid. So this technique was not successfully and properly followed all over the world since its introduction. But which is the best, transnasal, transoral? This is the question. In this paper published on spine, we tried to identify in cadaver lab which was the most featuring approach, transnasal on the left side or transoral in the right side, and the tools position in the X-rays and the CAT scan we performed in the cadaver was very clear in demonstrating that transnasal is less performing than transrosal, transnasal, transoral. Again, in AP position, transnasal, transoral, transnasal, transoral. Transoral has a huger surgical control. And also with neuronavigation, we have in the yellow line the demonstration that transoral is superior to transnasal both in sagittal and in coronal plane. Again, the volume is superior for transoral compared with transnasal. And again, transoral is larger than transnasal in the surgical domain. We identified also this line that is the dotted line, is the line that we can consider as the upper limitation of transoral approach, and it is the mirror of Cassan line which underline the caudal limitation of transnasal approach. This is our cadaver lab, and our conclusion is that there is not a winner or a loser. But both approach combine each other can be the solution for many problems. Thank you very much for your attention.
Wow. Thank you very much, Professor. Very nice lecture. It's the 360-degree approach that you have discussed. We can continue with the discussion. Anybody has any question? I mean, it was very nicely taken lecture, sir. Thank you very much. We will again come back. We'll be having so many cases, and we'll be having discussion, interactive discussion on those cases. So in that session, we will discuss lot of things. So now we can go to OT number 3, Dr. Park. Can you connect?
Yeah, I'm ready. Yeah, we.
Yeah, can you take us to, we are with you, Professor Park?
Yes, everything, prepared.
Yeah. So, okay, in few minutes we'll come back to you. Yeah.
2 minutes. I will, let's start here. Take.
Can you go to OT1? Yeah, Professor Koleza, we are with you. We are watching your beautiful rod reduction in situ.
Yeah, now I have finished correction, and osteotomy on the apex posterior elements was quite effective, and I suppose that correction near 70%, maybe more.
Yeah, it's looking good. We were watching you.
Yeah, and now we are doing posterior fusion, and I come to you soon. I hope.
Professor Kolosov, I have one question here. Are you going to put a stabilizing rod horizontally, like a bridge?
Yeah. I just put bone transfers. No. Connection, I think it don't need.
Okay.
Because when we use only pedicle screws, transverse connection is not effective.
Okay.
Yeah. Forceps.
Yeah, take us to OT3.
Yes, OT3 you are connected.
Are you ready? Yeah. Hello everyone. Let me explain the location for skin incisions. Because here is a thoracic area. So maintaining good outflow is very important. Under the same guidance, I made some T11 localization, and I want to make skin incisions from midline to the laterally, about 2 cm, because we have to maintain good outflow. So more wide skin incision, I recommend more wide skin incision. Skin incision including fascia, and then I start dissections of muscles and palpating interlaminar space. I believe this is a very good method. Now I can palpate the interlaminar space. So I believe here is a 10 and 11 interlaminar space. And also try to the middle part of posterior. So you can try it. Yeah, you can click. Click. No, sorry. Here. Yeah. Okay. So So, and separation of a pars spinal muscle from the lamina bone like this. This is all, and we need another skin incisions for the bigger cut. And about 2 cm above. Actually, merely hemilaminotomy is needed. So whenever above interspinous area, I like to have skin incision. Again, another skin incision. This is for the endoscope. This is for endoscope skin incisions. So, okay. And also put it here toward the lamina bone. Palpating lamina bone is very, very important. Now I can touch the lamina bone, okay. And make a triangulation. We try to make a triangulation on the lamina bone. I know interlaminar spaces at these angles, and like this, and then put here, also touching the lamina bone here, and another for dissection, dilation of fascia to make a good outflow. Okay. Always toward the midline. Here is the midline. Always your motion, hand is like this toward the midline. This is important. If you have like this, you can lose your anatomy. So strongly recommend always toward the midline. And I am keeping the this trochus. The right side of this two-way is for the walking foot, and the left side is for the endoscope. So just before I complete the, and I told you this is a fluid. This fluid is good. This is good. I think I told you this is too weak. This is good. And we can. Right off this. You can find the lamina bone here. Can you see blue here? And I inject methylene blue here. So yeah, you can find here. This way. Okay, cutting. This is a lamina. 10 lamina, the stuff. Cutting. Okay. This is a methylene blue, and I'm looking for stop. Coagulation. Sometimes methylene blue disturb the anatomy, but very easily would we wash out. Stop. Okay. Coagulation. Fluid cascading. Coagulation. Okay. Cutting. I'm looking for the interlaminar space, margin of interlaminar space here. You can see that. Stop. Cutting. Yeah, you can see the distal margin of T10 lamina stuff. You can see here is the interlaminar space. So make focus. Okay. I want to make focus clearly. Okay. We can see the interlaminar space here. Okay. Coagulation. Cut. Give me hand. Okay. Coagulation like to. Wait a minute. Okay, sorry. I want to do here. Okay. And expose. And expose the distal lamina. This is distal lamina. Now we can start our drawings. So, sorry. Good, please. Good. Okay. And, okay. We are here. This is interlaminar space. I don't know why camera is not camera has some problem, not clear. I don't know why. Move back. Deliver, please. Give me deliver, please. Pedal. Where is pedal? Pedal for drills. Okay. Thank you. Okay. We are here.
Hello, Dr. Suji sir,
Upper line,
sir, OT-2. OT-2, you are connected, sir.
Upper minus line, sir. Upper line. Pani. Upper minus line, sir. I think the complete tumor is out. It's a very difficult plane, but you can see all the vessels. There was a skip, so I just released this vessel in the middle. I think the complete tumor is out. It's a very difficult plane. Fine forceps, but you can see all the vessels. There was a skip, so I just released this vessel in the middle.
Dr. Suri,
Yeah,
what did the frozen come as?
ependymoma.
Okay.
But the plane was very much deficient. I got the plane in the posterior aspect, posterolateral, anterolateral, anterior there is no plane. I still think it is not ependymoma. I think it's a parasitic. I'll know after the final pathology. Because the last portions were very much merging with the card.
Is the IOM okay?
IOM preoperative only had one AHL on the right side. That is diminished a bit. The rest was not there pre-op also. We tried some new machine today. IOM preoperative only had one AHL.
So what's your next plan after hemostasis?
Hemostasis, I think it's done. Saline. I'm not. There was one or two. Hemostasis is done. You can see some anterior vessels which are preserved. The rest of the muscles or vessels are preserved. There was a small lesion from here. I put some flowseal, a drop of flowseal there. The rest, there is no bleeding. This artery I have preserved, traversing over the cord. There was a small lesion from here. I put some flowseal, a drop of flowseal. Half an hour for half. There is no bleeding. This artery I have preserved, traversing over the cord. You have sisters 7 of 8 of rolling 10 हो देगा 9 है 9 है 9 दे दो 9 polymorph दे दो put some 2 or 3.
So your plan is to put pulse sutures and then close?
Yeah, that's all.
Okay, can you shift to OT-2, OT-3?
Yes, sir.
So your plan
is to put pulse sutures and then close?
Yeah, that's all.
Okay, can you shift to OT-2, OT-3?
Yes, sir.
With the preservation of a middle structure, we can drill like this. Also, superficial bone drilling like this. Well, here is a one level of over. Here here is one level over intramural space. We can see, hold on. I mean, yeah, this one. This is a one level over intramural space. Yes, we have to go until nearly one level over intramural space. Diamond ribs, please. Okay. Yeah. Change it. Different pedal? Same pedal. I mean, same pedal. Push it. Are you ready? I can use it.
Dr. Park, can you please orient us once?
Yes.
Cranial, caudal, medial, lateral.
Okay, let me explain hello everyone, let me explain the surgical anatomy. 12 o'clock is midline, 9 o'clock is cranial, and 3 o'clock is the leg, and 6 o'clock is the left side. So this is a low ligament, and I'm doing to release. This is good. This is the good one. And this is good. Okay, good. Really heavy aminotomy we had here. This is a low ligament. This is a low ligament. We have to expose both sides of SAP, superior articular process. So I'm doing this. I think we need to change the endoscope, another one. If we have to try another endoscope. This endoscope has some problem. Okay. Change again. Close, always closed. Yes, and don't worry, it's very important. No, I can do it. Okay. And change it.
You are connected. Dr. Suri sir, I had a question. If this tumor was more eccentrically located, what would be your approach in tackling it?
Eccentrically means?
If it was not in the midline, posteriorly,
It's still better to find the midline plane, but then don't go on the side and then you, the ones which are eccentrically placed, actually the corticospinals of the non-eccentric side are normal. They're not pressed at all. So don't handle that. That's the only thing. There won't be any dissection on the other side. But the plane is normally the same. This usually happens in malignant gliomas. We've seen malignant gliomas, GBMs, eccentric, but it's not the thing. All the better is that tumor actually erodes through the pia. So sometimes it's directly on the surface. So you can just take it out and decompress and close. The prognosis is very poor in those cases. But whatever pilocytics I've done or appendix is usually central and slightly eccentric, but not that eccentric. The only thing is that even if eccentric, the midline shifts. If you find the midline, go on that side. That's all.
Thank you, sir. Can we go back to OT3?
The only thing is that even if eccentric, the midline shifts. If you find the midline, go on that side. That's all.
Thank you, sir. Can we go back to OT3?
open the fluid. Fluid open. I don't know why the fluid is like this. You have to this first. No. Yeah, we need this first, okay? Try again. I think previous one. Previous one. Show the previous one. Oh. Previous one. Malaki? Okay. Connector. Connect. It's okay? Okay, autofocus please. Water. No water. Why no water? Why no water? I think here is a different. Okay, here. To fix. It's okay. More higher, okay. And the RF please. We are here. Be careful for wire, okay? This, you know that this is just like a pencil. We can have a coagulation, and make focus, Dr. Roy. Stop. Make a focus here. No, more. Okay, it's good. Thank you. And we are here. Okay. We need a different area. Yeah, okay. RF. Okay, it should be okay. Cutting. Okay, it's fast. Wash out. You have to make a real anatomy. You have to make a real anatomy. All the way toward the midline, and looking for the previous drilling. At the bone, coagulation. So So, okay, we are here, coagulation. Coagulation. Stop. Why underscore is not clear? Coagulation. Deep problem. I don't know. Coagulation. Okay. Focus again. So please focus again. Yellow, make a yellow clear. Yellow round, make a yellow round clear. It's empty now. Okay. 2 meters. 3. Yes, yes. Baby, always take care without dying, okay? Because of 4 character of underscore, we are doing this. This is a superficial laminar bone over T10. And we know that here is a 10 whenever over interlaminar space. And I'm exposing ligament flavum, exposing this yellow ligament. So,
Dr. Park, any reason you're using the diamond burr this time and not the protected burr?
yeah.
Not the cutting?
Yeah, here is the thoracic area. If you use a surgery is more bulky, so can cause a compression. So I like to use this electric drill, which is used the microscopic surgery. I'm sorry for coagulation.
Which company's scope and drill system you're using?
Yeah, I like to strike a company 0 degree. Usually there are 30 degree and 0 degree. Because I am cutting, I am a neurosurgeon, so I like to have a 0 degree cutting. Stop. Yeah, this is a ligament, and this is a contralateral laminar area. I cannot understand why everything is okay, but the vision is very bad. I don't know why. Do you make a shuffling of the Correct.
Dr. Park, you don't use pressure pump for UBA?
Sorry, what? What is it?
Pressure pump.
Outflow is very good. I don't need it for irrigation systems, but we have a problem on the endoscope. The view of endoscope is very bad. But I can perform my surgery. So this is a ligament flavum, and this is a contralateral lamina. So I am drilling sublamina, contralateral sublamina drilling to expose ligament flavum. So this is a medullary bone. Always our drilling is superficial bone first. Hard. Irrigation. Very hard. Premier, always. Very mercifully. RF freezer. Coagulation. Please prepare 30 degree underscore. for you, if you have cutting, stop. Yeah, reduce the power to the fiber, make fiber. Cutting power, make fiber. Do. When you do hand the piece first, okay? Okay. As I say, I don't know why the quality of it is so much better, okay? It is really impossible to continue our survey. Anyway, can you see this is yellow ligament and this is outer ligament problem. So, with the same method, we have to explore the contralateral SAP. I am drilling contralateral IAP, contralateral sublamina drilling here. So, well, sorry, please conclude this screen conclusion. If possible, make it closer. Okay, you don't need for there. Okay, and okay, thank you so much. And this is ipsilateral AP here. What they say? Huh? Focus what? Make the focus again. Okay. And now I'm looking for the head of butterfly to identify midline. So, please section, irrigation, please, very hard. I'm looking for epidural pad because epidural pad, first epidural pad is midline. So, finding first epidural pad is very important in this step. We know very well there is a lot of heat generation, but here is a water. This surgery is performed in the water, so there is no heat injury. We can prevent heat injury from the drill. You can see here, we are near the midline. We are here. We can find some epidural pad here. And making several more like this. This is a contralateral lamina. Okay, yeah. Focus again. Okay, good. Drilling of the contralateral IAP to install the contralateral SAP. Okay. We need a superficial one first. You can see the retraction of soft tissue with the trocar, like plastic, we can retract the soft tissue like this, and then expose the bone. We can continue our drilling like this, and counterclockwise rotation like this, and clockwise rotation. Here, RF please. Cutting. Okay, stop. Okay. Cutting. Okay, stop. Conversion. progression, 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 okay, progression, cutting, cutting, okay, okay, stop. Yeah, focus again, three, round three, okay, we are here, we know very well, here is the first epidural pad, so we can, okay, I'm looking for first epidural pad. Always superficial wound drilling first, superficial wound drilling first, like this, and move to the deep area like this, like this. And also try to midline epidural pad. You have to find the midline epidural pad. Can you see here? This epidural pad is the midline. So we have a good orientation for it. And I'm going to the cranial area with a superficial drilling first, like this. Superficial drilling first. And then you can go more deep area like this. The basic is okay, and I want to make a ribbon flower island. We only need a drill. Actually, joining is very, very important. Compression area, I call it a dangerous zone. So in the compression area, we cannot insert any kind of instrument, including pencil or QRS. And normal zone, no compression zone, I call that intermediate or normal zone. Normal zone, we can insert 1 minute punch or instrument. So we are here, I am exposing yellow ligament with a drill like this. Okay, and going to contralateral area like this. Yeah, and try to expose the eye like this. Superficial boundary is the most important here, and here, and move to the inner area. We can go like this. Alert please, alert please. Okay, conversion. Cutting, please. Cutting, please. Stop. Conversion. Okay, thank you. Conversion. Okay. Conversion. Here is the outer contralateral outer ligament flavum. Okay. Cutting again. Stop. Cutting again. Cutting. Okay, stop. Here is one level lower intralaminar area, okay? We are near here, okay, three. And we want to do more, okay? And here like this. You can do it here, like this. rotational cord is our goal of our surgery, so I am doing only do please, very hard. And we know very here is here. We know very the attachment of ion from is Y cell, not embryonic cell. So craniolateral part is here. We have to go more craniolateral here. Y cell attachment. I want to show you Y cell attachment of ion from. And we have viewed orthopedic here. I mean, ion from is when you follow the attachment line, ion from, you can meet the low marginal pedicle here. So if you go here, we can reach the contralateral pedicle here. So we have to go here to separate ion from here, like this. Right, you can see the attachment line of ion from here, just like I said. Yeah, Okay, yeah, we are here. Separation of ligand from with the drill. Okay, without insert of any instrument, we can separate ligand from like this. And also to out like this. You can make like this. Can you see here? Okay. I did a more small side diameter, small side. What kind of size do you have? Only one? Do you have another this? If you have a small size head, please prepare different kind of this. Yeah, we can see here, okay? And we know very well careful. RF, okay. Suction, take care, suction. No suction, no function. Suction. Where is suction? Okay. I will do my operation, okay? Coagulation. Coagulation. Cutting shortly. Cutting shortly. Cutting Coagulation. Cutting. No. Fluid. Check the fluid. Coagulation. No fluid in foot. Coagulation. Okay, coagulation. Do you have this? Cutting. Give me this. Right, take care of the suction, okay? Okay. This is a contralateral. This is a contralateral IAP. When I do this, we can find the contralateral SAP. Always you have to expose the contralateral SAP. In cervical foraminal decompression, you also expose the contralateral superior articular process, medial wall of superior articular process. So I'm trying to expose, change middle. No, move to reverse. It is not working. Do you understand? Hold it. Okay, three please. Okay. This is ipsilateral. This is ipsilateral IOP here. Here we go. Other please. Check the line. Please check the line. Okay? Coagulation. Then I call you repeat the roll, okay? Coagulation. Okay. Coagulation. Shortly cutting. You have to remove this is outer organ problem, okay? And try to expose your distal lamina. Wait. Coagulation. Cutting, please. Cutting, please. Pituitary, please. Pituitary. Okay. We are doing here is the outer organ problem. So, partially removal of outer organ problem, which is disturb the visions. Okay. Give it curate. Small size, very small size curate. Other please. Okay. Coagulation. I need small head of coagulation. You know very well. This is a distal lamina, okay? Distal lamina, and from here, if you follow the distal lamina, you can find the coagulation. You can find the cutting. The most important thing is the following stuff. Coagulation. Curate, please. Coagulation. Here is a proximal margin of distal lamina. If you follow the proximal margin of distal lamina, you can expose medial wall of SAP. Cutting. Left stop. Cutting. Stop. Cutting. Short. Cutting. Stop. Coagulation, please. Coagulation. You can find it here. Some medial wall of SAP. Digital, please. Okay, wait. Coagulation again. Cutting. Okay, let me stop. Coagulation. Here is a contralateral area. I'm trying to expose the contralateral superior articular processor. I'm trying to expose. This is distal lamina cutting. Distal lamina and stop. Correct. Can you correct, please? Okay. We know very well, this here, this is a distal lamina. So we have to expose the attachment line over ligament from yellow ligament to the distal lamina here. And I will follow, this is some big, quite big, too many punchy. Too many punchy. This ligament flowering disturb the vision, so submitted more figure. So I will partially remove this one to watch contralateral side. So you can see here, partially remove of outer ligament flowering like this. The attachment line of ligament flowering here and here. We are here. Give me curate. My target is curate. Please expose the, okay, here, we are here. I want a smaller one, too big. You can see here, this is a contralateral SAP. So now you have to find the contralateral pedicle. Down there, please. Other first. Conversion. Cutting. Okay, it's good. Cutting. Please. I know. Here, maybe here is a contralateral pedicle. So, sorry. This is distal lamina, and so you have to expose the medial wall of the contralateral pedicle. The ring is not working. So we need a sharp needle means Here please, RF please. Neutral. Coagulation. Please check the line, please, cutting. Okay. Cutting. Coagulation. If you have three prepared, let me know. Please, thank you. Where's the line? Oh, easy, much more better. Where? Okay, I think, wait a minute. Okay. Ready to be there. Forward the pivot is possible. Left side the pivot. Not working. Wait a minute. Yeah. Section, please, no section. No section? What can I do? I'm looking for the medial pedicle, inferior pedicle. You can find, now looking. I cannot believe it. Okay, it'll be back. Looking for the pedicle, okay? Oh, why? What? Yeah, I don't know why. It is a very simple problem. Usually here is a pedicle, and after finding pedicle, we can become brave, okay? So finding pedicle, this is a contralateral SAP, this is a contralateral SAP, and we are moving to the cranial like this, okay? We can find, this drill is very good, this is very good. Thank you for drills. You saved my life. And if we make, where is section? You can see here, okay. I'm looking for the pedicle, okay. This is a cancerous bone. Be careful, be careful. Medial oral pedicle, checking the punch, oh, okay. Punch, submit punch, please. Okay. So I'm looking for the pedicle. Finding pedicle is the most important thing here. So we can find the pedicle. Okay. Yeah. So give me because yeah. Okay. No. I have to focus on it. Okay. Don't talk. Yeah, this is if you find the medial oral pedicle outside the pedicle, medial pedicle, there is no nerve. Do you understand? So finding medial oral pedicle, and then here outside is the safety zone, so you can become braver. You are really become braver. Do you understand? So I'm looking for this is a cancerous bone. Usually this cancer bone is a pedicle bone. Careful, please. Alright, please. careful, be careful. Coagulation, 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 coagulation. Okay. Good. 3. Line, please check the line, check the line. This is the SAP, this is the facet joint, and I'm going to cranial part like this, okay. Conclude the monitor. If possible, please conclude the monitor. If possible, please conclude the monitor. This is impossible. Reverse is impossible. T3. Only one direction rotation. Impossible. Okay. This okay. This is the inferior distal lamina, okay? You can explode. Okay. Possible? You can make bone just like pillars. Irrigation please. Do we have a different river, more strong, more bigger and more strong? Cutting board, just like a cutting board, do we have? Yeah, same drill, with the same drill. Yeah, irrigation please. Yeah, this is a distal lamina, okay? I want to explore the epidural space. When you drill here, the color of bone will become pink. Pink means that we are near the epidural space. So making this hard color into the red color is very important. Alright, please. Check the line, please. Always coagulation. Continuous coagulation. Cutting. Coagulation. We know very well. Midline. You have to always check the midline, okay? Head of butterfly. Cutting. Okay, stop. This is calcified area, but be careful. And look for the midline. You have to always keep in mind, keep the midline, okay? Keep the midline, the most important thing. Okay. Check the line, please. Oh, I don't know why. Oh, shit. Here. Do we have a cutting bar? Irrigation, please. RF, please, RF, please, RF. Okay, change it. Be careful. Dr. Boy, be careful. Code is opened, okay? So, okay. Coagulation, be careful. Coagulation. Okay. Coagulation. You can see this is a calcified problem. This is a code, okay? Coagulation. Here is a midline, so do please cutting it. New drill. This is change new drill, okay? This is very good drill. So change new one, okay? Check the power. Is it full power? Not full. It looks not full power. Check it. Do you have a cutting bar? Change it. Reverse also possible. Reverse possible. Which is the reverse? Left or right? Okay, when I call reverse, clean it, okay? Turn me. And check the input. Give me the please. Reverse. It's too sharp. I think we need a really weapon. Be careful. Right. Please check the foot. Okay. Reverse, okay? No input. Okay? Okay, make it more higher. I don't know why it is not good. Okay. Okay, check the line. Please. Okay. Oh, no. There's nothing. Cannot see anything. Oh shit. Previously, this one. Save it, please. Save it. No, previous one. Course, new one. Previous new one, please. RF, please. Coagulation. Okay, stop. Shortly cutting, please. Okay, cutting. If you prefer to let me know, coagulation. Thank you. Okay, this is good. New one is very good, okay? Okay. You have checked where is the midline, okay? Always keep in mind, here is the midline, okay? You can go to the midline here, okay? So, we are safe until here. And the rings. To separate even from the bone. Reverse, please. Only one, okay, it's okay. Yeah, here is the tension line organ problem. You have to be careful here. Be careful here. You need a separation organ problem. Okay, we are here. Okay. Pituitary, please. Pituitary, please. Okay. Other, please. We know very well. Inside over here, inside over here, inside over here. This is the cord. Can you see here? This is the cord. So you have to know. Please. And we can go, because here in the middle, we can go more laterally. Yeah, so I will go superficial bone drilling first, like this. Superficial bone drilling like this. And move to the more deep area, move to the more deep area. Move to the more deep area like this. Okay, and the more deep area like this. We are going to a more deep area. The support of SAP is the most important thing. Okay, remove it. We can find the middle wall of SAP from the distal lamina. This is the distal lamina. SAP and distal lamina is one body. So you can find the SAP from the distal lamina. Okay, so
what is the size of the diamond ball you are using?
Yeah, there is no available ball to this. We have only one drill. But sometimes side cutters such as a matchstick delivery is very useful. But we have some limitation for the instrument. But I can do it. I am doing my best. So I believe the result of my surgery must be good. So believe me. Please believe me. Now just before I found the pedicle. This is the medullary bone of pedicle. Do you understand? So here is the medial wall of pedicle. So lateral part of the medial pedicle. Here is the safety zone. So we can become brave. Like this. Okay. We can go cranially like this. I need a new deliver. Change it. Okay. We have okay. And here is distal lamina. We are going to here. Like this. Over the experience of 112 cases with bipolar, I don't have experience of post-operative weakness. But nearly all of my patients, their symptom is improved immediately. So, progression. With this method, I believe we can treat progression. Cutting. Okay, stop. Cutting. Stop. I don't know why it's so cold. Okay. Three, please. For the coordinated decompression, you can make your bone into the pink color, okay? Make it transparent. Change it. Whether you like that letter. Please change it frequently, new one, okay? It is not working really. no. Same way you do. Okay, you do well there. Do you understand? Okay, we are here also.
So we'll
We are going to close our like this. Okay. Here bone, okay. We are here also, Okay, be careful. If you use a different types of deliver, your surgery becomes more faster. I like to use ever surgery, cutting ball, and the diamond ball. Let's think we can use all kind of this. But yeah, here you can see here you TV safety, okay. You have to here. You can see the second. This is the second legal problem. Digital please. This is too big. Smaller one. Maybe short one is best. It's good. I need a small head. Head is too big, okay? Small head, digital process, please. If you have, okay. No, I don't like this one. Okay. Okay, deliver please. We are here. So there is no division between bone and dura. So here you enter the bone, we can find spinal cord here. Yeah. So
a 60-year-old lady, severe back pain for 5 years, difficulty in walking, difficulty with balance issues, activities of daily living have been hampered. And this lady was osteoporotic. Now, if you look at it, the lumbar spine has an oblique takeoff, there's a coronal imbalance, there's a kyphotic alignment of the lumbar spine, which is causing all these problems. So this is the whole spine X-ray. Resolution is not good, again because of obesity, osteoporosis. Couldn't get a good X-ray over here. So initially we kept this lady on teriparatide for almost a year to improve her bone quality, high protein diet, and later on the plan was to reconstruct the lordosis. So what better than doing a anterior lumbar interbody fusion that allows us direct access to the disc space and helps us to cut the ALL, restore, put in lordotic implants. So this surgery is done in a supine hyperlordotic position. My incision was slightly paramedian to the left side of the umbilicus, and from there we devise this retroperitoneal plane, identify all these good structures in the retroperitoneum, the aorta, the right and the left common iliac vessels, the ureter. The ureter goes away with the peritoneum, and then you access the disc spaces, do a good discectomy, and put in these ALIF implants. So this is the ALIF implantation that we did from L2 to S1, and that's the final C-arm shoot. The good thing about ALIF is that it gives you a wide interbody which sits on the ring apophysis and has a much better stability than the T-lif cages, which seems to be narrow and they have a higher tendency to sink down. And you can put in a big bone graft chunk with the ALIF cages. So this is the next day standing X-ray of this patient. I got almost a 50-degree coronal correction. I got some lordosis over there also, which is now matching my PI. So pelvic incidence 60 degrees, my 68 degrees, my lumbar lordosis was 58 degrees. So this is half job done. This is the patient walking next day, still looks imbalanced, and then 3 weeks later we get her back to the OR and do a posterior spinal fixation. This is a exposure. In this, there are various strategies of fixation that we need to use. I've done S2AI screws. I've done sublaminar wires on the concavity to translate the spine. Sublaminar wires are powerful. They help us to translate the spine. And then you'll observe it. As we translate the spine, you build in more lordosis. This is the coupled motion of the spine that happens over there. And then we pre-bend the rod to give a good lordosis and a gentle landing at the thoracolumbar junction. And these are the intraoperative images, S2AI screws. What is remarkable over here is that the top 4 screws, they are cement augmented, and there's a UIB plus 1 vertebroplasty. That again is to prevent PJK or PJF. And then put in a lot of bone graft, decorticate the bones, and that is the patient standing in next day, walking around. From here, we could have a very good coronal as well as a sagittal correction. Again, we could not get good lateral X-rays. We got a CT that shows 45 degrees of lumbar lordosis matching my PI minus LL goals. So that's the sagittal coronal corrections, and very well maintained at the end of 1 year, good bony fusion across the interbody area, and still holding. That's it. Thank you.
Yeah. Very good, very nice, Mayur. I mean, we have experts here who will be commenting and coordinating things. Dr. like Massimiliano, Dr. Park will join soon. Dr. Sergey is here, and we have national faculty, Dr. Patkar sir, Dr. B. A. Sharma sir, Dr. Ajay Chaudhary sir here, and rest of the faculty. Please join for the discussion. Yeah.
Congratulations, challenging case and optimal results. As a matter of fact, just to understand the rationale of first starting with the ALIF and then with a posterior pedicle or instrumentation infusion, what should happen just in case we should start with the posterior pedicle correction and then one stage combined or staged in 3 or 7 days later on? Anterior ALIF.
Yeah. So once we put in posterior pedicle screws and rods, the spine literally gets locked. So it is difficult to recreate the anterior column later on. So then putting in anterior cages, you won't get that much of lordosis. Also, doing the anterior first, you get good releases so that the posterior correction gets easier. So doing the reverse way, in fact, there are certain reverse scenarios wherein there's posterior fixation already done and now we want to do A-lifts. We have to go back, front, back. You go in behind, remove the rods, do a A-lift and then put in the rods and then recreate the lordosis.
So to perform A-lift before does not make more complex posterior instrumentation? Doesn't
No. We have to plan the A-lift and the A-lift plates well. If you look at that, we've used 2 hole plates and those screws are dead into the midline. That won't hamper me putting in pedicle screws. Definitely, I have to be very careful that I don't penetrate my pedicle screws into the end plate, which can push out my A-lift spacers. That is something that we have to keep in mind. Other than that, no major issues.
2 more questions.
Yes, sir.
How can you ensure or block or lock A-lift without screws? I didn't see screws inside the cage.
Not in the cage, but this particular cage design that I have, we have a plate onto the cage. It's like a separate plate which we can put in. There are other cage designs which we can put in screws through the cage, but we don't have that in India yet.
Second and last consideration, according to the literature, the right approach for A-lift is the right one compared to the left one.
Yeah.
Because to the need to avoid venous network, which is more consistent on the left side. Why did you choose the left side? You are not alone, because many people, contrary to the literature, prefer left side.
I'm more comfortable doing it from the left side. The reason is that when we go in from the left side, the first structure that we land on is the left common iliac artery. And it's much better, much easier to retract the artery and then work below the vein rather than retract the vein directly. The chances of getting an arterial injury are very low versus venous injury can happen. So this is much more comfortable, or at least this is the way that I have been trained and very comfortable doing all this from the left approach. If it's an isolated L5S1, I'm very comfortable going in only on the right side. Yeah. The iliolumbar vein that doctor is talking about. Yeah.
To go on the right. But I think studying the MR angio images or contrast MRI images, that gives you a very good idea as to where the ascending lumbar vein and iliolumbar vein is. And I don't think it makes a difference right or left as long as you know where the venous anatomy is.
Right.
I personally feel always the left side is better because it is easier to handle the arteries than to handle the the IVC on the left side, because you went right up to L23.
Yeah.
So I would definitely feel that the left side would be better.
Yeah, and I search for the iliolumbar vein and I ligate it and I cut it, so makes things easier to mobilize it over. Thank you. Thank you for your questions, sir. Very nice questions. Thank you. Thank you, Patkar, sir.
Yeah. Thank you, Mayur, for starting with the case which you have not done today, right? Yeah. So a totally different perspective. So till we meanwhile, till we start, like all other delegates and Dr. Park joins, we can have a lecture by Professor Patkar, sir, on anterior approaches and his innovations in CV junction surgery. And I encourage all delegates, my residents, to please be active and ask questions. You can ask any silly questions. And good questions are always welcome. Yeah. I how you talk. Huh?
I'm ready. I just want to call.
You should have a topic. नहीं आप बैठो सर वीडियो ऑडियो भी दे रहा हूँ ऑडियो सब मास्टर को एक ही लाइन में बिठा देता हूँ इज इजी फॉर मी एक लोग नहीं ना बहुत सारे लोग जगह नहीं till we set up, we can have a look in OT4, sorry, OT3.
Oh, sorry.
Just to see what's going on there.
Thank you.
Yeah, Professor Park. Thanks.
The three is most important.
Yeah, come back to.
If I try to cut it down. For everybody.
Professor Park.
With me. Yes, yes.
Thank you very much.
Thank you very much for having me.
Yeah.
Yes. I believe that this office is successful.
Yeah.
People are different type of cutting there. Not only not the speed of myself to become faster, but I am very good. I am very happy because I believe myself is successful. Thank you so much, everyone.
Yeah, you can hear the big round of applause for you.
Thank you, everybody.
Yeah. Yeah, please, like Rajesh, please bring sir here so that we can start to meet the master session.
Okay, as this is opening up, I thank the organizers, of course, Professor Kale, Professor Dattaraj, and they keep on calling me repeatedly, whether I am good enough or not, I don't know. This is the third time I've come to AIIMS to show my work on anterior surgery. And I'm also facing a little problem like Atul. It took some time for people to accept that Atul described posterior C1, C2 fixation. I've been talking about submandibular work since, I think, 2000. My papers are there in Journal of Surgery. Can you hear now? Still more? Okay. So my papers have been around since 2000, but still they have not yet got recognition from Western world. Just 6 months ago, the British invited me to the Society of British Neurosurgeon and gave my presentation the best prize, in the Society of British Neurosurgeons conference. So I will tell you one thing that stop me when you get tired, because I am passionate about this and I keep on talking, and somebody might get upset or they might not like it. So whenever you feel that it is enough, let me know till you got something else planned. What has happened? Yeah. So I'm going to talk about my journey through anterior atlantoaxial fixations. My first paper was published way back in 2000, when most of them in the literature were related to cadaveric studies and cadaveric analysis, etc., etc. I have no disclosures whatsoever, only gratitude to my mentor, Professor Ramani, and my wife, who is my anesthesiologist for last 35 years. No disclosures. Professor Masmiller was there, in the ICRAN meeting. You remember, Professor? And this was when I presented my work in Blackpool in 2000. I was representing India, and last year in Korea. Anyway, the story begins that atlantoaxial joint, the predominant motion is rotation, and if you can stop the rotation, that is the best fixation. As recent as 2020, there is nothing, the gold standard of fixation is passing a screw across the joint. If you can do that, that's fantastic, but there is a 8.2% risk of vertebral artery injury, especially because the vertebral artery does not read the textbook of anatomy and sometimes is high riding. And it was Atul who described this posterior lateral mass fixation C1, C2 way back in 1994, but the world kept on calling it AIIMS technique, AIIMS technique, AIIMS technique. On many forums, I destroyed that myth till this paper was published, which also mentions about me how reinventing the wheel, we had to bring it down from the Western world and say that this was described in India. Anyway, one shoe does not fit all. The entire literature of posterior fixation still revolves around the anatomy of the vertebral artery. Today you saw how Sharat Chandra was showing, and for the young surgeon sitting over there, it is not very simple. It takes years to reach a stage where you can start dissecting the vertebral venous plexus, the vertebral artery, etc. And this was the technique which I had described, a new entry point, a subfacetal entry point. There is no need to pass the screw through the pars like Atul or through the pedicle like AIIMS. but you can pass the screw directly under the facet joint. This technique was published by me way back in 2016. And then I went on to devise a Steffi construct for describing the posterior C1, C2 fixation, that this could be done and you could manipulate the C1, C2 joints. The C1, C2 joints can be manipulated like this. If you bring the C2 towards the C1, the atlantoaxial dislocation is one well corrected. And if you put a spacer in the joint, the basilar invagination will also be corrected. There was no need for any complex instrumentation, just a pedicle screw construct which was made by Jeon for me. If you will see that the recent literature also mentions that in some ways, this of the surgical approach and decreases, it makes it superior to Megal's screw technique. And you will find that recent literature, you'll find many places where there's a lot of talk about anterior surgery coming up, and there was in 2022, there was an editorial on my work in the Spine Surgery Journal of India, and how this technique will eventually replace posterior surgery. And Gopal has written that this technique is a good technique as compared to the gold standard of posterior compression. Why did all this come into existence? Because if you study, the weight transmission is in the lateral masses, and your implant must be sitting, orthopedic principle, close to the joints. So when you do a posterior C1, C2 fixation with pedicle screw rod, it is actually like an external fixator, where the rod is a cantilever principle, that the rod is far away from the actual point of this. And 2013, in Japan, I had gone and presented, I had done demonstrations, and then published my work in Japanese spine surgery, where I had first mentioned the use of plates to fix the C1, C2 joints separately, extrapharyngeal. And the large number of cases were published by me. See, you have to remember that Nagel was an orthopedic surgeon. He was not a neurosurgeon. Most of the spinal surgery was developed by orthopedic surgeons. It was from behind. It was Cloward, Smith Robinson who came up with subaxial anterior surgery of the spine. When I began in spine surgery, when we started doing Cloward and Smith Robinson, the older generation, they were frightened that the esophagus will tear and the carotid will burst, because we inherited from Nagel. Charles Pager, he described laminectomy from behind. Whenever you want to fix any vertebra, you must ask yourself, where is the force nucleus of that vertebra? Where is the line of weight transmission? Where is the best quality of bone? And is the technique safe? And can the technique be done by any recently trained neurosurgeon easily, without a lot of gadgetry, without O-arm? Because 95% of the people in our country work in a resource crunch areas. Surgery essentially should be simple. If the surgery is looking complex with lot of instruments, nowadays they come with big boxes with lot of instruments, out of which hardly 10% are used, and there is a screw to open the box and another to close the box also. So don't pay attention and don't get exacerbated by the boxes. In atlantoaxial joint, you'll notice the weight transmission in the front, and therefore the fixation has to be in the front. So this was the classic anterior atlanto transarticular screws, which are described by many people before me, beginning with Barber, with Vaccaro. It's just that I used it more frequently. So this is how I fix the patient to the table. And I don't use any, I keep the skull traction on for manipulation of the head. And this is a case of odontoid fracture. You can see classic odontoid fracture, which has got impacted, but then with extension and under anesthesia, it has got distracted. So I will just, so this, you see, this is like an anterior cervical fusion. I always measure the distance from the anterior cervical disc, C2-3 disc, to the fracture, which is usually about 1.5 centimeters, and the cautery is sheathed. And you'll go and I found a fracture. See, the fracture is being reduced with the right angle retractor. And once the fracture is reduced, I will put this is trying to get the fracture into control by impaling the body of C2, and a plate is fixed. This is a VSP plate, whereby as I tighten the screw, there's a compression in the fracture. And there you can see the joints on both the sides. You saw how much difficulty is there when you are dissecting from behind. You have to keep on telling yourself about the vertebral artery, the C2 root. From the front, it is just another anterior cervical fusion, which you have done hordes of them. And then you can see the transarticular screw being passed bilaterally in addition to the plate. And most important is that the operation is in supine position, which is the natural position of reduction, and you can test that your fixation is rigid on the table by lifting the head, rotating the head, and you'll find that it is completely rigidly fixed. So for those who are new, this was the first probable surgery of craniovertebral spine in our kind of mythology. So for this is the position of the patient. The patient is supine, with the head slightly turned to one side. I have the skull traction, there's a mild extension, the incision on the submandibular region. So these are the steps which I am showing on a model, and then I will show you on a cadaver and a real human being. And this is the only important structure, the hypoglossal nerve. And once the hypoglossal nerve is out of the way, and if you put a blunt finger like you put for subaxial spine, you will be straight onto the C1, C2 joints. This is a cadaver where you divide the platysma. After you divide the platysma, you reflect the submandibular gland and identify the digastric tendon. Once you identify the digastric tendon, disconnect it from the corner of the hyoid bone. You have to do this operation once on the cadaver, and then you'll find out why we are doing surgery from behind. You stop doing posterior surgery. Now, the only requirement is that in extension, the angle of the mandible should be at the level of C2-3 disc or upper part of C3. That means there is no kyphosis, and which is in 95% of the times. And once that is there, then any C1, C2 is approachable extrapharyngally, submandibularly. You must ask for the X-ray. I just now went and saw the X-ray for tomorrow's case. And you can find this blunt plane dissection, ventral, anterior to the carotid and the esophagus. Just put your finger and you will be straight onto the C1, C2 joint. These are specialized retractors which I use for tubal retraction. Extra long retractors which I use. And once you put them inside, this is no great technology. This is not rocket science. Anybody can do it. And you can see, you can identify the midline with your finger, and the joints are little anterior to the surface of the C2. So the joints are on either side. The vertebral artery is far away. The most important part of C1, C2 fixation is the hardening of the joint. How you put the drill up, how you prepare, and it is done much more easily from the front than from behind without any fear of bleeding. So either you can pass this transarticular screw like that, which goes upwards, outwards, and on the lateral it should reach the posterior end of the lateral mass. 5 millimeters below the joint, going upwards, outwards, child's play. The next way to fix the joint is to put a plate across. This is how it looks. Far away from the vertebral artery. There's no need to divide the C2 root. No worry about the venous plexus bleeding. So this is how, you see now this is the case of fracture, basilar invalidation, I think, I don't remember. The first thing is to remove the soft tissue between the atlas and the odontoid and create instability. In fixed deformities, create instability. See, I am removing the soft tissue between the atlas and the anterior surface of the odontoid. Then I will impale the odontoid and pull the odontoid towards the arch of the atlas. That is the joint there you can see very easily. Now I am making a drill at the lower surface of the odontoid process. I'll put a tap in that and lift up the odontoid towards the anterior arch of the atlas. And then I will pass the transarticular screw. So this you can impale the odontoid, then pass the anterior transarticular screws, prepare the joint, put bone grafts. You can see the screw go up into the lateral mass. Don't do repeated just once. And the tap also, I prefer nowadays not to use. I made a special instrument which is slightly pointed. I don't like to tap too much because once you tap, you spoil the threads. Let the screw come with good thread. Let the screw tap be self-tapping. This video is a little bit old, so I assume this is a standard screw about 20 to 26 mm going across from the facet of the C2 into the lateral mass of C1. Anyway, the other way is to put the plate. I'll go on to show you some examples. So these are some examples of how it is done. And these are some examples you can see. The end point of any fixation has to be fusion of the joint. If you're not getting fusion of the, don't focus on the implant. There is this instrument and this wire and this thread and I'll pull from. If you can't get this at 6 months, thank you very much. You must get a joint which is bony fused at the end of 6 months. So this is a case of fracture odontoid which is displaced. Now this was the construct which I described. Any fracture of the odontoid, displaced, undisplaced, can be treated from the front by putting a compression plate across the fracture and passing bilateral transart. There's no need to turn the patient and do another posterior. In America, still, my last visit I saw fracture odontoids or os odontoidum. They are doing transoral excision, then turning the patient, then doing posterior C1, C2 fixation, which is, I think, very, very morbid. This is doable very easily. End point should be that the fracture has reformed, the odontoid has reformed, the fracture has fused, and the joint has fused. That is the treatment of fracture odontoid. Displaced fractures or unstable fractures. In stable fractures, yes, you got options like passing a screw. Now this kind of fracture, you see, displaced, impacted, is reduced by cutting. You have to make the situation unstable by cutting the longus coli, by cutting the rectus capitis, impale the odontoid and bring it back into position, then pass the transarticular screws. You can manipulate the odontoid fracture. And you can see this. I have used that hole on top, you can see was used to manipulate, bring into position, and over a period of time you can see fusion across the joint. Then I went on to put cages into the joint, and this was described as, wedge is a simple machine where you can put a wedge cage into the joint and bring. See, from behind you cannot put wedge-shaped cages. If you want to correct deformity, the cage has to be wedge-shaped. Now they are bringing wedge-shaped cages for lumbar spine, which can be opened up after putting from behind. But the standard cages, today morning also what Sarat Chandra showed, the cage was a straight cage. But if you want the atlas to be pushed upwards and backwards, you need a wedge-shaped cage. And this was published by, again in 2016. Anterior facetal realignment and distraction for atlantoaxial subluxation with basilar invagination, a technical note. So this is how it is. There's a lot of bone available in the front. Without any struggle, you can push the cage inside, and depending upon how much you want the odontoid to be brought down, there's 0% risk to vertebral artery, venous plexus or C2 root. You have to create more instability. In any deformity, if you cut, what is keeping the patient in the flexure, in the atlantoaxial dislocation? Is the rectus capitis. The posterior muscles are extensors. When you're doing surgery from behind, you're destroying the entire posterior tension band. And then saying that now I did this and the muscles are never going to get reattached because the implants are there. The muscles make the whole construct weak if you have put implants over there. When you do it from the front, this is how you can reduce any deformity. Cut the rectus capitis, cut the longus, put the osteotome, correct and push it upwards and backwards, you are going to get a reduction. This got published again, Neurospine as, cage and APS in Neurospine way back in, I think, 2020, or I don't remember when it was done. But the concept was similar and easy. If you can push a cage, wedge-shaped cage inside, you will be able to bring the odontoid down. That is the concept. And you have to get fusion, and for that you have to be able to fix the plates over in lateral mass of C1 and the body of C2. So anterior retropharyngeal, this was the technique, comprehensive technique. Then I went on to make this, for any odontoid fracture you can reduce from the front, whether it is displayed posteriorly or anteriorly. And this plate was made by Jeon for me. Direct compression reduction fixation, simplifying odontoid surgery. And then various other publications. Torticollis, another interesting concept. Look at this child, You can see most torticollis is because of maldevelopment of the superior facet of C2 on one side. Study the 3D CT scan and you'll find that the superior facet of C2 on one side is maldeveloped. Where's the pointer? And the trick is to open that joint, refashion it, and fix it. So this is what I've done in this case. And this is a child after 10 years, he comes back to see me, and this is how he is, So after 10 years also, the fusion is holding, and you can see his torticollis has got corrected. But yes, there are pitfalls. See what happens in anterior surgery still, just now one navigation company is working with me to make this tracker for anterior surgery. But still, neither Medtronic nor the other navigation companies are able to make a good tracker for anterior spinal surgery. So there are pitfalls. Sometimes the screws, implant gets fixed wrongly. The screws don't go properly. Sometimes the screw goes too medially. Sometimes the screw, it over distracts or in an abnormal position. Sometimes, the marginal mandibular nerve can get distracted and you can get neuropraxia. Sometimes the implant can walk out. Of course, now we got locking screws and all. And then sometimes I become overconfident, and I just quickly finish the operation only to realize that instead of going into the atlas, I pushed the atlas upward and the patient woke up with a torticollis and then I had to redo it. So these are the entry points, 5 millimeters below and then going upwards and outwards. And then the lateral, it should go to the upper posterior end. But then patients don't read textbooks. You get patients with this kind of situation where you can't pass an anterior transarticular screw. See this kind of situation, it's not easy to pass anterior transarticular screws. Sometimes the screw goes far out, sometimes the screw goes far in. And you can have various complications like loosening, sometimes you're drilling again and again. So various problems related to transarticular. Anybody who says he doesn't have complications is lying or is not operated enough. There are many who claim, 100% success. They're rubbish if anybody talks about 100% success. The biggest problem which I found was that the screw used to wobble in the screwdriver. As with repeated autoclaving, the screw starts wobbling. So you see this is a typical example of the screw wobbling. As the screwdriver becomes old, it starts wobbling. So now this is a new screwdriver which has been made for me by Jeon, where the screw gets locked into the screw head. The profile of, there are many screwdrivers, you will lock the screws, but the profile of the screwdriver is very big. And when you try to go, you can't see anything because under the microscope it becomes difficult. So you need a very narrow head where the screw gets locked. So these screws, they come in, even 4.5 mm, 3.5 mm, 4 mm, and salvage screws of 4.5 mm. So this is a very old slide. I had some complications. Of course, anybody who says doesn't have complications. Necessity is the mother of invention. Research is search again. And nobody's knowledge is original. We get it, except for Beethoven, who was a prodigy. He was almost deaf and produced so many music video, So this was a case where you can see that there's basilar invagination. The vertebral artery is curving dorsally, like it came in morning in Dr. This one's case, Sarat Chandra's case. So I went back to the drawing board and I felt that, if we study from the front, it is very easy to fix a good plate and open the joint, distract the joint. And on table, because you don't have navigation, I should make the holes, put the screws and check whether I'm going in the correct direction. And this was the technique where, the step goes bicortical and the other two go in the lateral mass. Then you can see this, how the odontoid has descended. You can see the bone grafts in the joint. The joints are opened up. That was the purpose of the operation. Of course, this got published as a novel implant and concept for treating. This was published 2 years ago. Now it is more than 3 years. Another example of pre-op, post-op. And it gives you the fantastic opportunity to drill the joint. You can put a deep burr and drill the joint and garden the joint properly before you can put bone grafts inside. So you can see this, I drilled the joint. This is the technique. Where you are going to pass the screw. Make little small drill holes. So you know exactly where you are going to drill. Take an X-ray and check that these screws are in the correct position. And once you have done that, then you are ready. You can pass up. You take 3 screws, pass them, take an X-ray and see that everything is going correct. And then you can put the plate and pass the screws. And of course, the body screw should be bicortical. So this operation is, is now registrar's operation. I usually just go to see my registrar, finish it, and in the end, I just go to check that the implant has been properly put or not put. The entire fear of C1, C2 fixation is destroyed completely when you simplify the technique. So you will see this example. This is a displaced impacted odontoid fracture which has come to me after about 3 months, and you see it was going inside. So this is opened up and this implant is put. So this is the direction and this is the center, and you can go up to 4 mm screws, 4.5 mm screws. And the secret is to open the joint. Of course, this is what Jeon is making for me. Now we are coming out with this new, I'm not interested in any kind of, royalty. I just make the implant. I tell him what I want. He makes them and I tell him, you sell, make your money. But tell them that this was devised by me. Even if they don't tell it is not important, I hope patients become better, So this got published again in Case Lessons in Journal of Neurosurgery I think 2 years ago of the various Then my videos are there in JNS for those who want to see. These can be accessed by anybody, both the techniques, the posterior technique of the subfacetal screw and the anterior technique. Anybody wants to see the videos are accessible. Then the other thing which I want you to see the difference, You are disrupting all these muscles, and here you are disrupting only the longest scoli and little bit of this. Am I supposed to stop?
No, I mean, like, my registrar is very happy when you say that this is registrar's operation and you are doing the case tomorrow, and service is so happy. I mean,
so, you can do it.
Yeah, sure. So
see the difference. I'm supposed to stop now?
Yeah, I mean, we can proceed with the meet the master discussion, and you are the master who has to coordinate it.
Okay. So I'll stop. This is what I want. If this point you get that only that, see the difference in what kind of damage you are causing by doing posterior surgery, when you can get the same results by anterior surgery in 95% of the time with a simple lateral X-ray that the mandible is going up. Thank you very much, my dear friend.
Yeah. Thank you very much, sir. I mean, this difference perspective matters a lot, and I mean, just yeah, Professor Masmala.
Congratulations. Really, I'm stand-upping because you deserve all appreciation for your wonderful experience. Just a couple of considerations. As far as I know and I understand, there are 2 ways to perform your beautiful intuition for screwing by anteriorly C1, C2. Submandibular and C3, C4 claward technique, classic for C2 fracture screwing, classic. The advantage of the classic way to approach is the better angulation of the screw. They are fitting much better if you introduce them starting from C3, C4. You have less risk to damage hypoglossal nerve. Otherwise, if you perform a submandibular retropharyngeal approach, McAfee approach, the risk is to damage hypoglossal nerve and also to damage superior laryngeal nerve. And moreover, the angulation of the contralateral screw is perfect, but the angulation of the ipsilateral screw can be a little bit to be corrected. And that's why the ipsilateral screw is shorter than the contralateral, which is longer. I add only one more consideration. I published a few weeks ago a simplification of McAfee approach, 3 steps, but there is an enhanced risk to control at the best only contralateral joint. Otherwise, ipsilateral is much more complicated to be controlled. Thank you again.
My only comment is that the odontoid screw is for a simple, stable, posteriorly inclined fracture. If the fracture is anteriorly inclined, odontoid screw cannot be done, or should not be done rather, if the fracture is anteriorly inclined. 1. 2, if the fracture is associated with atlantoaxial instability, then the odontoid screw is redundant. The prime requirement for an odontoid screw is that the fracture is stable. The cruciate ligament is intact. If the cruciate ligament is disrupted, the odontoid screw should not be done, which many people end up doing and end up in trouble. If the fracture is anteriorly inclined, the odontoid screw cannot be done. That is the only argument. But of course, odontoscopy is a good operation for many patients. Thank you very much.
Excuse me, sir. I've just got two questions to ask for.
Sure.
How often is the incidence of dysphagia after this operation? Now, this is part one. And how difficult is to place ipsilateral C1, C2 screw anteriorly when you are practicing it?
Honestly speaking, everything is a kind thing of experience. Regarding the ipsilateral screw, the trick is to take a burr and first take the screwdriver in your hand and burr a little bit of the anterior cortex of the C2. If it is what prevents the ipsilateral screw is the anterior hump of the C2 body. So you drill that and you got your trajectory for the ipsilateral screw. Number one. The second question which you asked was this way. This operation is behind the nasopharynx. It is far above. There is no dysphagia. This is the question which everybody keeps on asking me. This operation is not like subaxial spine, where you retract the esophagus. Here you are behind the nasopharynx. So there is almost never any disease. Patient starts having tea, coffee in the evening and full diet next day morning. You see the Chinese literature now, it is studied with transoral TARP plate, where they feel that no posterior surgery should not be done. Only anterior surgery and anterior plate. They put a reverse U-shaped plate. It is called the TARP plate. Thank you.
Sushil,
good evening, sir.
just a minute.
Sir,
How do you measure the length of the screws for C1 and
I
C2?
just went down and sat down. You have to sit on the CT console. And on the CT console, take the bone window settings and measure from the joint up to the upper outer margin on the AP and on the lateral.
Yeah.
And plus, if you're passing transarticular screw, then take the thickness of the facet, superior facet of C2. So the CT scan tells you, again, you must have, of course, a collection of screws on table. So
yeah. And C2 body, which is bicortical. So
you
we just
measure it on table. And I never pass it bicortical at the first shot. I will stop at 4 threads and take a C-arm, and under C-arm I'll do the final tightening, lest I pierce the dura. But it has to be bicortical.
Yeah. And is this T plate available commercially?
Yeah, Jeon is making it.
Sir, good evening, sir. Dr. Gopinath from here. Sir, recently I had visited NTSI in Pune. Dr. Kiawat, I guess.
Yeah.
He is doing transoral fixation of C1, C2 things. So what is your take on that, sir?
I do not accept, see, I've done a lot of we were the pioneers at Sion Hospital of transoral surgery and heart shell rings for C1, C2. I had visited Krokar. Even Arnold Menezes came many times to Sion Hospital. I rarely saw a patient of transoral surgery in our circumstances heal with primary intention. They always heal with secondary. I don't know, Dr. Kalu must have done many. They always heal. And God forbid you open the joints and all. If the infection gets in there, then thank you, you are going to get osteomyelitis also. So I do not accept this theory that you can do transoral surgery very safely. There's always a risk of bad infection and sometimes fulminant infection. Because the patient is lying in bed. Most of these patients are, as it is, quadriplegic or wasted, their nutritional status is poor. And in that, when you do transoral surgery, and if God forbid it gets infected, you are going to be up shit creek without a paddle.
Sir, I discussed with him and he said that he had done around 10 cases up to now. And his defense was that like we put dental implants, those implants don't get infected.
Dental implants is a completely different matter. This is in lying down position where all the saliva pools.
Okay.
The saliva and the secretions pool in the nasopharynx when the patient is lying supine. Dental implants on the mandible maxilla, they are far away. There is no collection over there.
Okay.
And one swallow doesn't make summer. You have to do many. Any experiment, again I tell you, don't follow any surgeon if only he is getting the results. Any experiment, sodium plus chloride must be sodium chloride in New Delhi, it must be in Rome, it must be in Russia. The operation must be replicable. It should be simple and anybody should be able. If it is looking complex, the operation is not evolved, the surgeon is not evolved.
Oh, thank you for the sorry. Thank you for the wonderful lecture. I'd like to ask that I'm very worried about the complication if it's anterior approach. So especially for the old woman or man over 80 years old, if your patient is more than 80 years old, what kind of surgical procedure you choose?
I will do posterior surgery. After the spine has to be supple. You should be able to extend the spine. In elderly people, they already the disc space has settled, fusion is taking place, they are kyphotic. Don't struggle in that kind of situation to do anterior surgery.
Okay.
Those patients should, of course, it's not that, there is no one single road to Rome. There are many roads which go to Professor Massimiliano's house.
Okay, thank you.
I'm not going to go there, don't worry.
Yeah, thank you very much for a nice discussion, sir. So, I mean, if I read it, meet the master session, and our moderator today is Professor Sushil Patkar. Sir, please here. I mean, you're supposed to, make sure that you get all discussion done in timely manner. So, I mean, less than 10 minutes?
No, one each case is for 10.
Yeah, less than 8 plus 2.
8 plus 2, okay, fine.
So, I invite, please here. Yeah. So, I invite Professor Ashish Tandon, sir, to please start with this case.
Thank you so much, Dr. Dattaraj. Well, I've got a few cases. I've brought in 3 cases and it will be open for discussion. The first is a male in his 4th decade, gradually progressive weakness in all 4 limbs for 3 years, bedridden for 2 months, no grip, features suggestive of severe compressive cervical myelopathy. So this is the SAG MRI and axial images. So the case is open for discussion.
What is the diagnosis? Who wants to say what is the diagnosis? This is a post-contrast MRI, obviously.
Yes. I've just brought in post-contrast in the interest of time.
Very good. Anybody wants to take a take of the diagnosis? Yes, sir. Neurentric. So, do you have a T2-weighted image?
We don't. I've just got these images. And we know... sorry, sir? Sir, I'll cut the chase. It was a schwannoma.
I know, it was a good. But what you are doing, you are showing something in burqa. You are not showing all the images.
Yeah.
So this is a neurofibroma, there is no question. It's
Yeah.
a long multi-segment neurofibroma. Okay. What did you do for the patient?
So, this patient basically, this was another cut. So as you can see, a little bit more on to the right side. So the challenge was that we were trying to push for fixation. He did not agree for that. So we did a C2 to D3 laminectomy mainly to the right side. And thankfully we could achieve a complete excision of tumor. Preserving the roots was the major challenge. And patient, as I told you, did not afford fixation.
What fixation you are thinking of? The laminectomy?
No, I was thinking of lateral mass and going down because it was a long segment laminectomy that was required, and he was in his 4th decade. So my first advice to him was that I would like to fix.
Facet screws were a good cheap option?
So at that time, this was about 8 years back. So at that time, I think lateral mass was the in thing.
Did you consider multi-level hemilaminectomies? In the morning we had laminoplasties.
I did not consider laminoplasty as such. Not a very big fan of laminoplasties in view of the neck pain and things like that.
So this patient, if it is tumors on one side, a multi-level hemilaminectomy could happen?
Yeah, absolutely. So we went more towards one side, and the other side was well preserved. Even on this side, we did not entail in touching the facets a lot. So just a little more extra onto the right side. And this was what the post-op was. We could achieve a complete excision. So basically I brought this just to demonstrate that size really does not matter. and we can easily, if we a patient can achieve good excision.
Dr. Ashish?
Yeah.
Did you had to divide the dentate ligament or the dorsal roots at some of the places?
No root excision.
Okay.
We went in between the roots and gradually excised it.
So
the good thing was the tumor was sort of coming out on its own.
Suckable. That is, the tumor decided it wants to come out.
Exactly. So it made my life easy, and it's 6 years, now in fact 8 years post-op, he's doing fairly well. No evidence of deformity, and we're pretty happy as of now. Yes, sir.
Go back to the MRI.
Axial cuts. Yeah, what was that entering into the foramen on the left
No,
side?
that's the root. The tumor wasn't going inside the foramen. Yeah, it is, but it wasn't going, it was just compressed.
You have done a follow-up contrast MRI.
Yeah, we have done it, yeah. So next is 72-year-old retired female. She suffered a fall leading to severe dorsal pain about 3 months back. Progressive weakness after the fall in both lower limbs for almost 1 month, became bedridden for 2 weeks, lower limb powers 1/5, jerks brisk on catheter. So again, few representative images only. This was the D8 osteoporotic sort of fracture. She had multiple fractures, and there was compression. So again, thoughts on this?
CT, where is the CT?
CT, I think I haven't brought the CT. I've brought the, hold on. No, I haven't got the.
So where was the pain?
Dorsal, mid-dorsal pain.
When you press, you have to check if there are multiple fractures. Now, for example, D6 and...
yes, he had D12 fracture as well.
So the new one was painful or the old one was painful?
The stir was D8, stir positive. She had already undergone vertebroplasty for the D12.
For the D12?
Yes.
Okay. And her pain was more on the
dorsal. And not just the pain, she was severely paraparetic. She had become bedridden.
I would look at the CT scan first and see where the combination is, where the fracture is bad. Because this D12, what you're showing, is still showing a fluid level, or is that a cement?
There is a fluid level, but I think
this is a Kumail's lesion, so that means the vertebroplasty was not very good. It was a wish-wash vertebroplasty.
But she did not have that pain. She was more concerned there, and she was paraparetic with numbness
from
D6 downwards.
D6 downwards. So obviously now the lesion is the D8 lesion, which is creating trouble for her. First, get a CT scan done. I have published a paper. If you are in doubt with multiple fractures, do a technetium scan. The one which is recent is the one which is the most bright. But that apart, if D8 is the problem, and with so much of retropulsion into the spinal canal, what would somebody like to do for this patient? Patient is developing weakness in one leg. The CT scan I wanted for 2 reasons, is not only how the fracture, but also the status of osteoporosis in the spine.
Yeah. So in this lady, we had a DEXA scan with a score of -3.5 in the spine.
Rather than, see what happens many of the times, they do the scores and all. What I've noticed in osteoporosis, the last place to lose bone is the pedicles. Many times you'll find a lot of osteoporotic spine, but the pedicles are still preserved and strong. Yes, even the lamina are strong. So don't go by just DEXA scan, do the CT scan and study these structures and then take your call what you want to do on the patient. So what does anybody want to do? Anybody wants to take this patient and treat this patient in the crowd? The youngsters? Nobody?
Dr. Rajesh? Surya? Anybody?
Sir, I would plan for a D8 laminectomy with percutaneous fusion at D6, D7 and D9, D10 with an option of fenestrated screws and probably cement augmentation.
Yeah. And what would you do for the compression?
We'll do a laminectomy, sir, posteriorly laminectomy. Just make a small midline incision at the level,
So
at the edge, and do a
leave
laminectomy.
the anterior compression as such.
If we can go laterally, drill the facet little bit, and if you can just hammer it down, if it's mobile, then would go ahead, otherwise just leave it as it is.
Okay.
All these questions will be answered by the CT scan.
Yeah, I agree.
And many times on positioning, you can get a correction. You can even do a vertebroplasty on table with the pedicle screws. What else? Who else wants to?
I think, sir, the very important consideration, suppose we had a CT, though I haven't got it, CTs and X-rays, there is a significant retropulsed fragment.
Correct. To be forewarned,
and the power is 1/5.
To be forewarned is to be forearmed.
True.
Yeah, so what you did?
Okay, so I'll show you a quick video and a technique also that I use. So one side we put in screws, then from the left we went, and we went transpedicular. We sacrificed one of the roots, but what the important thing that I wanted to show was, after we have sort of removed part of the vertebra because we thought that there's significant compression, we took a 30-degree scope here. So we took a 30-degree scope, and with the help of the scope, we excised the anterior part, and then there was a tough bone, cortical bone, which was compressing the cord. So we used ultrasonic bone knife, and we went flat. So this is the planar, and with the planar we could safely drill that cortex which was compressing, and then brought it down. And thereafter, once this was, and it's quite safe, it's extremely safe, it goes straight. We do not have curved ultrasonic bone knives, unfortunately, but because the trajectory is straight, we are able to achieve a good sort of decompression of the anterior theca. Once that was done, we put in and negotiated a cage, and we fixed on the other side. So there was rapid neurological recovery over 6 to 12 weeks, and at 2 years follow-up, she walks unsupported, independent. For a year, we gave her medical treatment for osteoporosis. And as the gentleman suggested, she was severely osteoporotic. We had cement augmentation, screws, and cage. So this is what we undertook. Plus, we have done here 6 levels. There was another case, as you suggested, 2 levels above and below, and he was good for 3 months, and then there was a lot of implant failure. So for osteoporotic, I would rather suggest longer segment fusions than just the 2 levels above, 2 levels below.
Here you injected the cement through the screw?
Through the all.
Because in many of the vertebrae screw has retropulse, the cement has retropulse.
Yes, it has.
So sometimes they say
so these were not fenestrated screws, we did all, and we put in thicker paste.
But it has come in the spinal canal.
Yeah, but it was thick paste. I think when we were screwing, it has gone in, gone out.
Show your post-op X-ray.
Yes, sir.
Included lumbar spine also, 2 lumbar spines for the screw.
I'm sorry, sir?
Because that lower level is not taken care of.
So that was, the vertebroplasty was done before. So we finished it at D11. If I would have taken it to D12, then I would have had to cross the junction and I had to take it to L12. So I stopped at D11. So just to prevent crossing the junction, I stopped there. And I think I was lucky that we gave treatment for osteoporosis, and this, over last 4 years, this D12 has not given us trouble, though it can give trouble. And in fact, so very surprisingly, this patient now comes not for all this problem. She says that she has developed restless leg syndrome after a couple of years of surgery. So she is under treatment for restless leg rather than any of these spinal issues.
What is your opinion of the first screw on the left side and the fourth screw on the left side? Are you satisfied with the position of screws, or you would like to have medialized them?
Yes, I think the top one can't be sure because that is a little tilted. It's a little tilted, and we should have a CT to truly suggest whether it is inside or not. Yeah.
But it is better on the AP X-ray to see the tip of the screw medial to the screw head. Otherwise, you are restless, you know.
And I think we will use at least 2 crossbars.
Yes, at least 2 crossbars.
For this number of screws, at least 2 crossbars.
Okay. Okay.
Yeah, so nice. Like, I mean, so many learning points. Yeah. So, what is about the CT?
We have a CT, though we got it after a year, because again, this patient's follow-up was very slow. She was bedridden, she's not coming. So we got a CT after a year or so. And
actually, in osteoporotic spine, you may put the screw correctly, but when you are negotiating the rod, sometimes because the rod manipulation, the screw moves laterally.
Yes.
So you have to be careful and do the pre-op. Don't get in any implant. Don't remove the patient out of the OT without doing a proper, correct AP and lateral X-ray, and be really satisfied. And then only ask the anesthetist to start reversing. Because once the patient is out and then you do the X-ray, then you are in a sorry state if your screws are not proper.
Yeah, true. Very nice learning point. This commonly
so because today was a day of lot of.
I mean, we can have a next. We are already running.
Just for one last video.
Yeah.
If you just please, couple of minutes. So this is one last case. This is hard calcific lumbar disc, and brought in just because there was biportal. And, I'm a fan of uniportal, so uniportal.
No, again, you have to, I will accept it is hard calcium after you show me the CT scan.
Yeah, I'll show you in trop. I'll show you in trop, sir. So here, separating as in biportal, we separate the ligamentum flavum. And here separating the ligamentum flavum from the underlying theca, opening it up, going till the IAP, in fact junction of IAP and SAP, going absolutely bang lateral, though here did not require to drill, just separate it out, the ligamentum flavum, and here there was a large superior cranially sequestrated sort of a fragment. And the important thing to note is that we are not retracting at this point of time. So the root is not being retracted. And here you'll soon find, this is the calcific. Here in the midline, towards medial side, it's free, but here is the calcific annulus, which I am upcutting. So typically we have the annulus, which is the calcified portion, and the rest of it is soft. So here it was all calcific. And there was a still bony fragment, which after we did some internal decompression, we removed. So here we are separating the theca, the root, which was a bit stuck. Here there is another bony fragment that you can see. This we could squeeze out and then excise it, and finally the root was freed to our satisfaction. So this I just brought to highlight that even uniportal calcific disc is possible. This is again open for your comments.
Yeah, Professor Park. Yeah. Yeah, please.
Yeah, I mean, yeah, even the herniated disc, even if it is much more better, because the retraction of lower compared to bipolar, unipolar is very easy. So we can show very well. Yeah, retraction of lower and removal of hard disc is unipolar is more better. Yeah.
Yes, sir.
Yeah, thank you very much, sir. Very nice case.
So,
Yeah. For next case, I request Dr. Samir, please present his case on CV junction. Dr. Dandabani, please be ready with your next case on anterior meningioma. Quick radiology, important finding, plan, and what you did. So we'll have case presentations, then we have series of lectures before we again relax today at different place.
Good evening, my respected teachers and my dear friends. Here again, I am coming back to the craniovertebral junction anomaly. So this is just one representative case of the multiple cases, and which is a very simple technique which I follow in order to achieve a complex reduction for any CVJ anomaly. So this is just a representative case. So she's a 35-year-old unmarried lady with a short neck, twisted neck. She was wheelchair bound, unable to do any fine motor movements. And incidentally, it's also associated with a so-called Mayer-Rokitansky-Kuster-Hauser syndrome, wherein there is a Mullerian agenesis, and she had a dysmorphic one-sided absent kidney and cervical scoliosis also. So this was a patient, and I'll directly come to the CT scan. So wherein you can see a good basilar invagination, nicely malformed joints, which are causing the which are ultimately leading to the so-called basilar invagination, and also you could see it's not working. So bilateral inverted variant of the anomalous vertebral artery. This is on the right side. This is on the left side. Both the arteries are passing again in front of the joints while in the posterior. As you can see, the anterior arch is also deficient, and the posterior arch of the C1 is also deficient. So I follow the technique of Dr. Sarunke, wherein we do the aggressive drilling of the C1, C2 joint in order to open up the joint. So I'm just going to show you a small video. So here the joint is being exposed. On the left side there's a vertebral artery which is separated using a dissector. It's held back using a dissector. As the joints are exposed, the cartilage over the joint is sharply cut, and it is again followed by aggressive drilling of the two important points, two hillocks, I would say. One is a posterior superior portion of the C2 lateral mass, and another is a antero-inferior portion of a C1 lateral mass. Drilling is achieved in such a fashion that the joint becomes completely floating over each other, so that a retropharyngeal space should be visible either through the naked eye or with the help of a microscope. This is a blunt hook which I am trying to put. This drilling of the suboccipital portion is done in order to accommodate for the C1 head. Because if you keep the C1 head outside, it may not be biomechanically stable. So C1 has to be butting against the C1 lateral mass. C1 screw has to be butting against the C1 lateral. So that's why this suboccipital drilling is done, so that this can be achieved properly. So as Patkar sir always insisted on a good gardening of the joint. So after the good gardening and the drilling of the joint, bone graft is packed in. A lot of bone graft is packed in, which I take from the posterior superior iliac spine. And then after that, as the C1 gets defined properly, the C1 standard trajectories are used for putting the C1 screw. and C2 screws bilaterally. So the idea here is to completely mobilize the joint, make the joint floating over each other, and get rid of all the slipping tendencies. The so-called basal invasion is nothing but a sum total of all the displacements in all the axes. So be it a vertical displacement, be it a horizontal displacement, or the anterior-posterior ones. So after putting the screw, the next problem comes. The screws are usually they are at a different plane. So it is difficult to put it in a small rod. And that's where the this technique comes into play, wherein the long rod, whichever is available with any of the set, can be just curved like a hockey stick, and the curved portion is hitched against the C1, and C2 screw is used as a fulcrum. This is not nothing new really about it, because all these techniques are, all these methods are described previously with the help of a different instrument. So this is a highly reproducible and a simple technique. So as you can see, the long head of the rod acts as a joystick, wherein we can achieve any amount of dislocation correction, because all the three planes have to be corrected: anterior, posterior, lateral, vertical. So all this can be achieved with the help of a long head of the rod. And as the C2 screws is tightened, that remains fixed. And after that, using a drill or using a rod cutter, long rod cutter, this rod can be cut. So as you would observe over here, as soon as the C2 screw on the ipsilateral is tightened up, the dura gets opened up properly. So dura between the C2 and C1 gets opened up properly, and there is a good venous drilling. This is just a C-arm X-ray serial shoots, wherein you can see the C1, C2 screws, which are tips are part away from each other. As the rods gets aligned, they come aligned with each other. This is just a small animation trying to prove my point. So this is nothing but a very, very, very simplified portion of a standard DCERT, the translation technique, wherein all the components of the fusion, compression, and reduction, everything is achieved in a entirely proper fashion. So this is a post-op CT scan. Doesn't work. So which shows the adequately reduced odontoid, well placed, bicortically placed C1, C2 screws. Both the vertebrals, the left side and the right side vertebrals, are well preserved. And this is an MRI after 1 year, which shows a chronically myelomalacic cord, but it is well decompressed. CVJ surgery, I believe, is probably the next most gratifying surgery as compared to EDH evacuation. So a happy patient, a patient who has regained a finer movements, is probably the most gratifying. Thank you so much. Thank you very much.
Yeah, so the only one thing which I would like to comment is when you extensively drill this bone.
Yes, sir.
There is always a danger of taking off all the cortical bone, at least from those areas.
Yes, sir.
And then when you have the cancellous bone exposed,
yes,
then comes the danger of the cage or the graft, whatever you have put. Many times it's a cage that can sink inside the vertebral body above or below.
Sir, I usually don't use cage,
and
unless
once you have the cortical bone is not there, and then you try to leverage with your rod, the pull out can become easier. That's all. Otherwise, very well done.
Thank you so much.
I have one comment.
Yes, sir.
Well done surgery, obviously, but a few technical points that I would like to understand. You used it as a lever, correct?
Yes,
That's
like
good.
a joystick.
And then to negotiate the rod into the U of the head, you have to rotate it medially, right?
Yes. Sir, in this case, because there was a rotational component.
Yeah. What I would suggest would be that once you put the locking nuts partly, not completely, you can rotate back it to the vertical area,
yes,
and that will give you more maneuverability in pulling back the head. The curve of the rod was in the vertical plane, no, on the horizontal plane,
yes,
rather than the vertical plane.
Okay.
It's just a comment.
Yes,
I think well done surgery.
Very well thought.
Yeah, it's a very fantastic what you have shown, but only my problem is that the atlas and the occipital condyle are not fused. So you are trying to say that you are pulling the atlas and the skull back, or only the atlas back, because if there is no malalignment between the atlas and the occipital condyle, then just to use one screw to pull the whole skull with the atlas and the occipital condyle back is too much stress on the rod. I would say that the technique is good. You should also include the occiput into it. And what I feel is that we used to use like a reduction screw in L5S.
Yes, sir.
And pull this backwards. Because if there is a potential joint between the atlas and the occipital condyle, then the post-op X-ray should show that your atlas has come back. Have you done the CT scan and seen that?
Yes, CT scan is done.
What has happened? Has the atlas come back in relation to the occipital condyle?
Sir, this is not a single case. I have done around 162 cases so far, and I have a follow-up of around 8 to 10 years.
So what do you feel? You feel the whole skull moves backward?
Yes, sir. So it is not only the C1 which I am trying to pull back. There are two things, two arguments to this question. So as I have told, this is a translation also. It does not act only on the C1 pulling back. It also, the curve, whether the C2 is also pushed forward. Push forward. Secondly, all the pulling and pushing tendencies because of the extensive joint drilling and all the ligaments are, so the slipping tendency of the floating joint is nullified. So my idea is that the joint pressure has to be perpendicular to each other. So even if the implant fails, this structure does not depend on the implant. Implant is just to correct the
till the fusion takes place.
The fusion, yes, just to assist the fusion. It is just a buttressing plate.
So you must have got some follow-ups with where fusion has taken place.
Yes, sir. Yes.
Very good. Very
Those
good.
follow-ups are there. Even very, very long-term follow-ups are also available.
You should show them,
Yes, surely. I'll come up with, this is just, Datta told me to show one case, so that's why I have come up with this one.
And
good.
One thing.
Thank you so much.
I am to be yeah, one question from Dr. Pankaj Singh.
Yeah.
The thing is that we think by this this bending and all those things, ultimately it is the length of the C2 the screw. If you have more outside, it pushes it anteriorly, and the compression. We
Yes,
think
sir.
that we have made this curve, that curve. Ultimately, it is the compression which works.
So this is where the compression also
And the
appears,
length
because
of the
the moment we take the C1 above it,
compression
the
and
rod compresses.
in that small part you cannot give the credit that you have bended or whatever this is. This is just this much.
Yes.
1.5 to 2 centimeters.
You can manually also, I mean, using the rod compressor, you can do that.
The length of the C2 screw, which is outside, it, pushes it anteriorly, and the compression. That only two things work. But we think that by curving or all those things, but ultimately the compression and this.
Yes.
Yeah, thank you very much. Very nice discussion. So now I request Dr. Dandapani to show some endoscopic anterior meningeal surgery. We may have many cases, like as we are short of time, we'll finish some of the lectures, and still we have time, then we'll have more cases. Tomorrow maybe like we'll start early for the cases and talks.
Respected teachers, my dear friends and colleagues. So I'll just show, because I think there is not much time for discussion.
We'll discuss. We'll discuss. You show something else, I'll discuss.
So this was a 60-year-old female patient who had a funicular pain and spasticity, and this is the MRI. As you can see, I think the diagnosis is obvious, that there is an anterior spinal IDM centered on T1, T2, and it looks like meningioma, and it is purely anterior, and the cord is flattened out posteriorly. So what to do for this? Any?
We'll have video presentation today. 5 minutes.
So for lack of time, so I think whether anterior or posterior approach, definitely the posterior is more familiar, and in the posterior, whether midline posterior, and if we want to do midline posterior, we have to do more on one side, and or we can do a posterolateral approach, and to choose whether right or left posterolateral approach, and what to do to the facet. When you are doing very much lateral, then you may have to sacrifice the facet and fixation, is it needed or not, and here the T1 root is coming close, should be. So what to do, how to deal with it, and dural tail, how much to excise, and then we cannot close, and what is the feasibility of MIS. So this was our plan. So we wanted, because the tumor is very much anterior, and we wanted to create a gutter laterally, so that the tumor can be rolled into the lateral gutter through MIS, and that was the plan, and this we had published in World Neurosurgery. So I'll just show a small portion of the video. so this was the incision. We gave an incision based on the X-ray, and then it was a paramedian incision centered on the most the lowest point in the axial view in the O-arm, and then we did that inferomedially. Whatever muscles were there, we we cut them horizontally, and then we put in the MIS retractor, and then we sacrificed one facet joint. And the literature says that if you sacrifice one facet joint in the dorsal spine, you don't need to fix. And we sacrificed the T1-2 facet joint, and we did a far lateral we removed the pedicle and that lateral junction. We exposed the root, and the tumor we identified it was in the axilla of the root. So we did a lateral durotomy. These things were done under 3D exoscope, and we extended the incision anterolaterally and coagulating the dura, and once we coagulated the dura, made it avascular, we tried to disconnect the tumor from all around, because only when you disconnect the tumor can be rolled, because it's a meningioma. Schwannomas could have easily been slit, and here the dura over the spinal cord is not opened to make sure that we don't retract the cord at all. And using angled instruments, we tried to roll the tumor into the lateral gutter, and once the tumor was rolled out, then the anterolateral part of the dural tail was coagulated and excised, and then confirmed with angled endoscopy. So this was using the angled optics. We are looking at the medial aspect at the spinal cord. We are seeing that the arachnoid is preserved. So this was a purely extra-arachnoidal surgery, as if one may call it. And then the dural tail is confirmed to be totally excised. And this is the post-operatively, we documented a complete excision. So this was the extent of bone removal. And this is the gutter we created, and there was no instability in the post-operative. So this is the post-operative MRI. So this is there in world neurosurgery, and this technique and other anterolateral tumors we had published in the spine journal, JNS Focus, and another just one interesting case, just one more slide. So this patient came walking to our emergency. So what to do? There is just one more slide. This is the last. So this patient came walking to OPD.
Any youngsters?
Takers.
Youngsters, yeah. Anybody?
Dr. Siddharth, very young. Dr. Shweta.
So how many days is having this?
This patient came within 2-3 days.
2-3 days. The injury was 2-3 days old only. What he had, just pain in the back?
Not even pain. He was mostly asymptomatic. Someone had referred for surgery. He was not willing that. He came to us. So he was not much symptomatic at all. No, but if you realign, and there is a risk that he can become totally paraplegic, isn't it? So we'll so how many people would if you go by books, I think what Dr. Sachin is telling is definitely that is the recommendation. You have to realign, reduce and fix as per the textbook. But there is a high chance of such a kind of gross dislocation. It can make a person completely paraplegic.
Even if not operating on this case, will finally lead to what you are saying, because a small trivial trauma can lead to that.
So if you operate also, there is a risk. If you don't operate also, there is a risk.
Well, let's ask younger people. I mean, let me go there. Let me see, like Rahil, come on. Revan, any opinion? You can say, don't do anything, send him home. You can say something, please.
Sir, we should operate on this patient.
Operate and do what? That is the thing. Yes, we can do something, but what to do? See, there are two elements of surgery. One is kind of reduction, and another is fixation.
At least to prevent
further damage.
So do you want to reduce and fix?
No, sir. At least we can do an in situ fixation and laminectomy to further prevent the damage.
Yeah, that's a very good suggestion.
Yeah. So, Gopi? I have very less experience on this, sir.
Yeah, very nice answer. I like it. I like it.
Answer.
By evening you will have experience. Don't worry. I'm pro on this one.
Yes, we did not have much experience. We had to discuss this with so many neurosurgeons, and then
as
kind
the
of take a
patient is
decision.
intact, we can do a in situ fixation and do a wide laminectomy. That would be
Laminectomy.
Yes.
Okay, in situ fixation is okay, but why you want to do laminectomy? Because patient is not having symptomatic compression of the spinal cord.
But
Kind of
during,
radial this is
instrumentation,
unstable,
there can
but
be
there is no
small-
compression.
During instrumentation, there may be some mobilization of the body or the.
So you want to do
abdomen.
laminectomy first and then fix?
Yes.
Big fixation, like fix up to laminectomy. You're a junior guy, like, yeah, hello, anybody? Any suggestion? What do you think?
No idea.
Perfect. This is also nice answer. Chinman? So, yeah, please proceed.
Yeah. So again, this was a very rare case, and we discussed with so many neurosurgeons, and finally we decided that, as Dr. Sachin told, this cannot be left alone. So conservative option was not at all there. So this is unstable. So definitely it needs fixation. But the question is whether to reduce, because you don't need decompression, because there is no compression at all, symptomatic. So we did not want to do decompression by doing laminectomy, but fixation had to be done. But again, kind of reduction is very risky. So we decided to do in situ fixation as was suggested by our dear friends. So, and then we decided to do in situ fixation. And again, this is a long segment. So in situ fixation, long segment, we initially thought of doing open. But then, because we had warm navigation, we decided that we will do a percutaneous pedicle screw fixation. And we skipped that level. Here the challenge was not for putting the screw. The challenge was to insert the rod. Rod insertion took a long time. And we wanted not to reduce, but at the same time, we did not want any kind of manipulation. And so this is the result. This is the end result after surgery. So thank you.
No, it's very important now. Are you relying on rods here? Huh?
Pardon? No, go back to the post-op CT.
Posterolateral also.
Show the post-op CT. I would have passed that screw into the vertebra in the front if at all I wanted to fix in situ.
You want the pre-op CT, sir?
No, I'm saying the screw in the vertebra below. You left one vertebra.
Yes.
I would have passed that screw through across into the vertebra.
Yes, this has gone. This screw here, this screw actually is going little bit till here.
Okay, because that is the best way to fix that.
Yes,
Then it's not going to move.
No, because here it is not thin, we can see some artifact. This screw actually went through and through across this space into the opposite.
But was that by plan or was it by accident?
Yes. No, because there was no way to put kind of putting a screw here was impossible, because the screw head will be so deep. There is no way we could have connected the rod.
Did you not consider an anterior surgery where you go and kill and it would have reduced?
Yes, anterior surgery was considered, but again, because of the morbidity reduction, there was always risks involved. So again, our team, as a department, we discussed this in our meeting, and then we decided that posterior would be the simplest and safest. But then we decided whether to do open or MIS. That was controversial. But we always had a plan that if MIS was not feasible, I thought I'll do open.
So now you are depending on rods, no bone fusion.
No, sir, means once we put in the screw and the rod, and posteriorly in that posterolateral area, in that screw hole itself, we put in bone chips.
Sir, just one point. You have fixed it in situ, but what about the spinal alignment?
Yes, you can see the patient.
No, but so there are actually two fragments you have just fixed in situ. So long term
See, I totally agree. this is not an ideal thing, but a patient, we wanted to preserve the neurological function.
So how about putting the patient prone under anesthesia, under neuromonitoring, and trying to give traction to reduce it, because it's a 3-column injury? Highly unstable.
Anterior, it will not reduce by traction.
So that is a, so
This one, I can agree that if you do anterior.
Our second option is anteriorly.
Correct.
If you are not able to get
Very good to reduce, and I definitely agree with that plan. But we decided that because this patient, he didn't have any symptoms, he was not even willing for surgery. So for a patient who is not even willing for surgery, we did not want to do such a morbid procedure. That was the.
Sir, I had one.
What is this level, sir? D10 or D9?
This was in the mid dorsal. Kind exact number I don't remember.
Maybe around D7 or D8.
Yeah, somewhere in
Why,
the mid
why
dorsal.
can't we go laterally transthoracic approach, remove the lower body? That will give you some possibility of alignment also and longer duration stability.
See, any posterior, any posterolateral approach also, complete reduction is very risky. I can agree anterior reduction, anterior approach would have been very good, it would be safer. But because we didn't want to do a very kind of high risk procedure, we did with this.
Sir, I had one question. If we have fixed this and you said this patient presented within 3 days of the injury, if suppose he has delayed deficits, neurological deficits, how will you proceed one? And is there possibility that
I don't know, I don't have answer. No, but I think that question, if this patient would have come after 1 month, I think then I would have just advised conservative treatment.
Professor Kalasaw, we are waiting for your opinion.
So 1 month, if this patient comes after 1 month of trauma, would you do surgery or would you advise conservative treatment?
I think these patients very lucky because this first lucky because traumatic spondylolisthesis without symptoms. And second time became lucky because you operated him and make very wisdom decision because traumatic spondylolisthesis it's very dangerous for reduction and the decision very good. I can congratulate you.
Most of the seniors recommended this. Don't do kind of just do a minimalistic fixation.
Very simple and reliable. It's all our surgery should be very reliable and simple as more as possible.
Professor College, what will you do when you see this case? Like, you can change the slide?
I think the same.
Same.
Yeah, if the same thing, if the patient comes after 1 month, would you change the plan?
Will be anterior fusion interesting.
I make a very short comment.
Good balance. We don't treat X-ray picture.
Absolutely.
Yes. This is a wonderful words. Actually, this is what our kind of.
He's stealing my
we don't need
words
to
right
treat
now.
the scan.
I was saying that we do not operate X-rays. We operate the patient.
Yes.
Just in case the patient is asymptomatic, that means that deformity is consistent with a neutral clinical status. So we can freeze it, we can instrument and fix. But I noticed that you put 3 screws below and 2 screws above the dislocation site. I think that this hardware is, in my personal opinion, quite a little bit asymmetrical, and I should add 1 more screw above in order to make more symmetrical the construct. Moreover, I ask you, beside the neurological physical examination, did you perform a neurophysiological assessment, somatosensory and motor evoked potential in order to catch some subliminal sign consistent with something progressive that we don't like?
Yeah. No, but there were no soft neurological signs also. Okay, what about if this patient would have come after 1 month? Would still people prefer surgery, Dr. Sachin? If this patient would have come after 1 month?
Yeah, I would still
do surgery.
operate because this patient has a risk of kyphosis, there is already kyphosis. If there is further trauma any time in his life, he can have sudden neurological deficit. So I will operate him even if he presently.
Find that those two, whatever are getting fused,
If bridges are there, then you will not.
then you can leave them alone. Otherwise, whether he comes after 1 month or whether he comes after 6 months is not important.
Okay, thank you, sir.
So one of the most important thing what we learned, like you have planned it, but relying only on the implant, any case you plan may be not the answer, right?
Sir, one point I want to add. It's excellent presentation, sir. Sir, is there any role for a controlled traction, something called as a femoral distractor, what we use in orthopedics?
I don't have much experience. Does dorsal spine reduce in traction? Can anyone?
Yeah, I have an experience of post-traumatic listhesis in dorsal spine, and I have tried even without opening the patient, putting the patient under GA in prone position and giving traction by pulling the legs as well as the shoulders. And
See, basically, there is in this case there was a kind of locking mechanism which will not reduce just by traction, but you'll have to go and destroy. You'll have to kind of drill the bone. That's what.
In this case, I will never have done MIS. I would have gone in. Doing corpectomy from the posterior lateral approach is not that difficult, and there may be risk, but there is not 100% risk. And I think that I can easily go from the posterior lateral approach and do the corpectomy and make a space there, decompress the cord anteriorly, and fix it in a better construct.
Thank you.
Excuse me, sir.
If there is any complaint, you can do a corpectomy.
Yes.
So it's already fixed.
Okay, doctor, no more questions. We are running short of time. Thank you very much for the excellent presentation. And let's now get on with the next session.
Yeah. So, I mean, again, it is the part of the Meet the Master sessions. We had beautiful presentation of the cases. Now, we have time. So, we will have first a lecture by Professor Kolezo, video lecture, video presentation, please. After that, Professor Rajakumar Deshpande will have a small lecture on tubular minimally invasive spine surgery. On today's case, Professor Park also will have a short lecture after that, and then we'll see.
I'll see that is all tired. I'll show you two short videos. First video about pedicle subtraction of total. It's short video. Yeah. Some technical tips and tricks. This patient is 68. Oh, sorry. Can you? Yeah. 68 years old and was operated 4 years before me, and idiopathic scoliosis may make correction, but flat back and sagittal imbalance. And we doing pedicle subtraction osteotomy at L3 levels. We begin with resection transverse process. Then we make resection posterior part of the facet joints, lamina. And usually we do the surgery to high experience surgeons from both sides. And we don't change our position. And in that time, surgery more quickly, needs more short time, and better to do it. we perform resection posterior elements. We removing pedicle screws from L3 vertebra with keystone resection posterior. Resection pedicles. And another side, the same manipulation. Making resection facet joint. Then we make resection vertebral body with osteotome. One side. Now we're doing with ultrasonic scalpel, but this video was recorded 5 years ago. At that time we're using just simple osteotome. And with spoon we remove sponge from the vertebral body, and we always do correction on the fourth rods, short rods for make correction at the level of pedicle subtraction osteotomy. And we make a triangle, a basic welt on the posterior part of the vertebra and thin in anterior part of the vertebra. Then making fixation, and after this doing posterior compression for close the zone of resection vertebral body. One side and then other side. Usually pedicle subtraction osteotomy give us at least 30 degree of correction on the one level. And when spine is completely fused, this resection give us possibility to make correction lumbar lordosing, restore lordosing, and correction sagittal imbalance. Step by step we make compression. Make revision spinal canal after close the defect, and then we put long rod for restore fixation thoracic and lumbar spine. It's X-ray during surgery, and after correction, after pedicle subtraction osteotomy. Now from this patient 5 years after surgery, and she feels quite good, no pseudarthrosis, no fracture of the rod, and stable fixation. We call it play of the rod when we are using 3, 4 rods for correction. And maybe next video, maybe you have question. And after surgery, good sagittal imbalance correction. if you have a question, I will show you VCR, short video too. Can you start next video?
I think it's a very nice technique that you have shown. What is interesting is you removed the previous rods and did a segmental kyphotic. The correction was with the, only at one level, and you kept the small short rods, and you use the old rods or fresh rods again to do that. It's like a double rod technique on each side.
Because 2 years after previous surgery and spine is completely fused and impossible to do correction in thoracic spine. But the main problem is sagittal imbalance because patient couldn't walking lumbar.
So how did you decide on the degree of resection on the L3 body?
We planning surgery on the special program, SurgeMap.
Surgery,
And we using this program.
Okay, please. Very nice.
Yeah, very nice. So how do you ensure that the anterior cortex is intact while doing a PSO? And if there is any disruption of the anterior cortex, do you anticipate any problem in the correction?
I use some tricks. For example, in this vertebral body, we're doing pedicle subtraction osteotomy. We're introducing pedicle screws. We remove it, and the pedicle screws 45 millimeters, 6.5 diameter. I'm feeling the hole and can estimate what's optimal. How can I go to the front? And,
yes.
No more. And usually we always do drilling with tap.
Yeah, that's a
lateral part of the vertebral body, feeling, make X-ray, and it's very simple and reliable technique.
Yeah, thank you so much. Thank you.
Maybe next. It's congenital deformity from the patient 16 years old, very 90-degree kyphotic deformity, no neurological symptoms. And we perform classic VCR technique. We preparing rib, 3 ribs from one side and from the other side. Cut head of the ribs. With finger we touch anterior part of the vertebral body. Because we need to remove all vertebral body. Then we cut transverse process. Then we do rod for prophylaxis movement after resection of vertebral body and pre-contouring rod and making fixation on the apex of kyphotic deformity. Then we can work on the anterior part of the vertebral body without risk that can be dangerous displacement up part of the spine and down part of the spine. Then we do laminectomy. Now it's better do with ultrasonic scalpel. Now in that case we use high-speed drilling. This carries on do laminectomy, resection of the ligamentum flavum, resection of the pedicles. Of course, we're doing neuromonitoring and making control. We should coagulate epidural vein and sew up the roots in thoracic spine, usually one roots, and cut them because it's not functional in thoracic spine. Then we sew up nerve root from another side, because without sew up the root, impossible to make resection of the vertebral body. And it's need for mobilization of spinal cord for resection vertebral body from posterior approach. It's PVCR, posterior vertebral column resection. Working with one side, step by step perform resection with using Kirison, spoon, one side, then other side. We leave posterior part of the vertebral body near the spinal cord and make resection this posterior part only in the end of surgery with using a special spoon for break posterior part of the vertebral body and bone bridge under the spinal cord. This way making a little compression and introducing cage in vertebral body for prophylaxis shortening of the vertebral column and spinal cord. Because it's dangerous for neurological problems. After this, we do X-ray and detect optimal position of the cage and make correction with shortening posterior part of the vertebral column. Step by step, one side, the other side. This patient has deformity near 90 degree. We need from 30 to 40 degree of correction of thoracic spine, and only shortening posterior part of the vertebral column is enough for making good correction. We're using working with rod for decrease kyphotic deformity. Maybe you have seen this technique today when I surgery congenital deformity. In the end, we make compression for fixation cage in anterior part of the body. Cage should be very stable for prophylaxis of pseudarthrosis. step by step we're doing shortening posterior part, and after surgery, before from the right and from the left after, and very good correction after surgery. Thank you. If you have any question.
Thank you very much, sir. Any question?
Yeah, so here. So we all know that PVCR has a high rate of complication, 15 to 30% as far as literature is concerned. So what is your indication for PSO, and when do you prefer PVCR?
I think that high rate of complication was in the past. Now, and nowadays, we have big experience in pedicle subtraction and vertebral column resection. We make different equipment, ultrasonic scalpel. We have never monitoring. We have high experience surgeons, cell saver. We have everything. And I think that nowadays, if you do right selection of the patient and do the surgery with good plan, level of complication not very high. Maybe as usual surgery what we're doing every day. It's my opinion.
When do you do PSO, and when do you go in for complete vertebral column resection?
Usually, pedicle subtraction osteotomy we do very often in revision surgery after flat back syndrome. In Bechterew disease, ankylosing spondylitis, vertebral column resection we usually doing in congenital deformities, especially thoracic, thoracolumbar spine, and in revision scoliosis and very severe scoliosis when patient very won't be have very good correction. But of course, we always patient say that it's quite dangerous treatment, and always thinking what we do, at what patients should be selected for this surgery. And I think for last maybe 5-6 years, level of complication not very high, not very high.
Yeah, thank you very much, Professor. Thank you very much. Like, very nice. So now, guys, stay tuned. We have two very interesting lectures by our two invited faculty. One is by Dr. Raja Kumar Deshpande, and another is by Professor Park on what the case he did today, ossified post PLL removal. I mean, so and these will be recorded. These are available on our SpineCon. They will be always available as a reference to go again and again. So we are making this content available for you. So Professor Raja Kumar have this lecture, and then Professor Park will have his lectures. So with Professor Park we'll end our day, right? And also tomorrow, like we have our departmental faculty will be presenting complex cases. Dr. Sachin, Dr. Pankaj, and so many people will be presenting tomorrow. So maybe we'll start sharp at 4 p.m. tomorrow.
Once again, I thank the organizers for this wonderful workshop conference. And I see a lot of people still are at this late hour. Actually, this was a slightly long presentation, but I'll cut it short in view of the fact that it's getting late and everybody is wanting to go. So let me start. So lumbar tripod fusion has become a standard of care now. why I say standard of care now is that when we started doing surgery about 25, 30 years ago, we were all doing simple laminectomies or stephy plating with, bone on the lateral aspect of the plate. Then we started doing clips, TLIFs. We started putting iliac crest grafts. And then we gradually have come to, doing TLIFs and minimal access. And the safety and the outcomes of surgery have improved significantly and qualitatively. So, options for lumbar interbody fusion are still a lot other than TLIF. We have OLIF, we have HLIF or ALIF, and nowadays we have minimal access, OOLIF. That's something that's coming up. So these operations are performed typically minimal access nowadays, and it is becoming very easy to learn for people. All you got to do is learn the steps. So I will say how to go about doing this again. We had a demonstration yesterday. So you basically do for degenerative disease at one or more levels, for back syndrome, for spondylolisthesis, and it begins with getting X-rays, dynamic X-rays, standing, AP and lateral. And of course, you get a MRI, lumbar spine, whole spine screening. And nowadays, last few years, we're getting a whole spine X-ray. Look for spine sagittal alignment. Yesterday, we had a small class about how to approach sagittal balance in a very simple fashion. So let's start this case. 56-year-old lady with low back ache, progressively increasing with radiation to the left lower limb, numbness in the left lower limb, left ankle, dorsiflexor, and BHL weakness. She had a hyposthesia of L4-5. And this shows an MRI which is a grade 2 listhesis, with of course the foramen being completely squashed. Flexion, extension, neutral X-rays confirm the same. Whole spine hip joints. You can measure the joints, Yesterday, I think, I'll remind yesterday what I showed. Yeah, can see? Yes, it's two. You have a brighter light? So just to remind youngsters, yesterday I said pelvic incidence is between 45 to 50 or 50 plus or minus 5. Lumbar lordosis should be plus minus PI, isn't it? So in this particular patient, the PI is 47, the LL is 55. No. So the balance is pretty good, but the patient has pain. I don't use any frame, just a natural frame. I don't use a frame on top. I normally use a floor neutral position. And yesterday we showed the skin incision and how we mark it. You saw the same thing yesterday. We use a matrix retractor. You can use any retractor. We use this retractor simply because it has a capability to expand and have angulation. Very convenient to use. And I use this special disc removal discectomy instruments. The most important thing is to understand what a discectomy means. You just don't be in a hurry to do a little bit of discectomy, pushing the bone, lift the bone and the graft and come out. Make sure to do a good discectomy. I'll skip the video for lack of time. And you use any kind of graft like PEEK or titanium made cages. You can use that. You can use a banana, bullet, whatever cage you want to use. But make sure that you place it in a place that you want to do it. Do you have the pointer? Otherwise, try to place it in the anterior part. That's the important thing. And try to place it in the center. Because these are bullet and banana cages. I think placing it into one side will give not a great optimal weight balance.
And if you keep it right in the front and you gently compress posteriorly, you get a decent lumbar lordosis. Now, many times you are asked, what happens if there is a single level and you don't bother about sagittal balance? It'll come back to bite you after a few years. And I have started, some of them I have devised myself. And you can do the pedicle screw fixation, open or minimal access. I think all of you are now very familiar. But what I want to show you is a technique which is called a rocking technique. I don't know how many of you use it. And this is a very interesting technique which I've described and it's in the literature. You can put pedicle screws and you can rock like this. You see? And you can reduce the listhesis. This technique will not necessarily make the screw loose. Please understand. I'll play it again. Oops. You can use it like this and the screw won't become loose. Make sure, but the screw are very placed medial. And you can see the X-ray again. Use this for grade 1, 2, 3 listhesis, grade 4 listhesis. It helps in reducing the listhesis. The other technique that I use is, I don't know how many of you use this. Once you clear the disc space and if it's still rigid, you use this these trials. Someone put that here. You use the trial to go anterior and break the ALL. You can go anterior, push it all the way here, not completely, about half of it should go. 2-3 places it stretches and relaxes the ALL, and then you can easily reduce the listhesis. So you can use several tricks to reduce the listhesis. Okay, and you get a very good result. So you can do it multiple levels. You can have a degen with a listhesis and a degenerated disc. You can do that. Multi-level. Yesterday I showed some scoliosis, degenerative scoliosis, like this. It can also be done. Minimal access. One of the things that we do is feel that you can only do with this. You can do 1 level, 2 level, 3 level. If you want to do additional level, you can use a matrix instead of the quadrant, small hole. You can have another level. Just add another half an hour extra, but you can get a cage here if you want. And you can get a correction. And as I told you yesterday, correction of lumbar lordosis to what extent you want is still a debatable issue, but if you want to get a good lordosis, try to see what is the optimal level, and if you can reach 60-65% of it, it should be good. You can use additional gadgets, navigation, 2D, you can use a robot. Of course, you need AIIMS. And make sure that you avoid having pedicle breach and screw malposition. All of us have done it. Now, one of the things about screw position in minimal access is that if it is inside the canal and if the patient has a symptom, don't hesitate to go back immediately to replace it. Get post-op X-rays if you want or scans to confirm it. Ideally, if you are using any navigation material, navigation machine to put the screws, intraoperatively get a check X-ray, C-arm to make sure your screws are in position. It saves you a ton of trouble post-operative. So there is a lot of classification of the screw positions, etc., etc. And we discussed osteoporosis. Osteoporosis means that you should be very cautious in using screws. Use larger size screws. Don't tap too much. Make sure the patient has had teleperitoneal therapy. If you can wait for the patient to have better bone quality, and you can use bone augmented fenestrated pedicle screw fixation. Now, what happens is when you're trying to put a screw in minimal access in an osteoporotic patient and the screw becomes loose, there are many ways of doing it. You can use a bigger size screw, or you can use a fenestrated screw, or what we do is we inject slightly liquidy bone cement into a loose screw hole, wait for just a little bit and put the screw in, and it holds nicely. So I have got a lot of patients, but for lack of time, I think I'll close now. Thank you very much for your attention.
So great. We have our final talk now. Professor Park will take us through the journey in ligamentum flavum hypertrophy.
Thank you. It is a very hard day and very exciting day, and I'm happy and I'm very interesting. So just before I had live surgery, so I would like to summarize my method for removal of thoracic ORF. So for safe removal of ORF, I like to have a staging. I would like to briefly introduce my mess. So making stage, we need several types of drills because we cannot insert the punch or instrument in the compressed area. So drill is the most important surgical tools. And at the same making the drilling stage. Before you roll on problem, I would like to complete the drilling stage. So the essence of drilling is very important. Cranially, original organ problem, and bilaterally exposure of bilateral SAP, and caudally distal lamina, upper marginal distal lamina is some margins for drillings. And then I separate the ligament problem from the bone. So this is also I believe is important because compression area, I believe here is a dangerous zone, so you cannot put a punch or other things. And the important thing is find the medial wall of pedicle because cord is inside of medial wall of pedicle. So if you find the medial wall of pedicle, you can drill very, very bravely and speed up. So I call here safe zone. And no compression zone. No compression zone is an intermediate zone. At intermediate zone, I can put the 1 minute punch or other instruments. So this is another concept for this is joinings, and this is when you open the dura, water is split the dura and the rapid membrane. So during the dura tear, rapid membrane is very easy preserved. Believe. So you can with the preservation of rapid membrane, you can remove dura problem. This is a video for okay. Usually I start my career at the spinal line junctions. And outside superficial bone drilling first. And remove of ventrally bone. This is here is the cranium. And expose the ligament membrane. Here it looks like the midline. Sorry. So I'm drilling contralateral. This is a med stick river. Expose the contralateral SAP. and looking for the medial pedicle, looking for the pedicle. When you find the pedicle, your surgery becomes safer and easier. So how can I find the pedicle? Medullary bone of pedicle is very good surgical anatomy. I mean, there are medullary bone between lamina and there are medullary bone in the pedicle. So finding medullary bone of pedicle is important. This is a distal margin of upper lamina, distal lamina, and make a pink color like this. This is a proximal margin of distal lamina. So finding SAP, if you follow the upper margin like this, you can meet the middle wall of SAP. So from the proximal margin of distal lamina, you can follow it here, and you can expose it medial wall of SAP. And then because here is a no compression zone, so you can put 1 milli punch epidural space. And remove it. Yeah, separate the ligament flavum from the bone. This is a cranial area here. I'm also separating from the bones. And dissections. Here is the contralateral side, in the middle area. Yeah, cranial separations, because here is no compression area. So the most important thing is any compression area, we only pull upward. Without compression, pull upward action is the most important. Yeah. So without any compression, we can remove the ossified ligament flavum. This is a post-operative fragment. Post-operative CTs. I wanna show you briefly show you another case. It is some interesting case. This patient is very severe. Very severe, calcified OLF. I removed the OLF, dura and the OLF together. So this is OLF and dura, but we can see preserve the arachnoid membrane here. So removal of dura and the OLF together, and we can see the arachnoid membrane here. And with the patch method, we taco seal. Taco seal is a kind of a stick patch. So we can cover the taco seal instead of iodura. Several pieces of taco seal. Because the arachnoid membrane is intact, so post-operative for these patients there is no leakage of CSF. So bipolar surgery to close over dura, closing dura is a patching method. Sometimes you can use a vascular clip, and patching. This is a final view of patch mast. So post-operative, this is a post-operative MRI. So I believe some medical staging and the separation to the angular related exposure or dura and the patchiness is useful for the removal of ligament problem. Thank you so much.
Oh, thank you very much, sir. So nicely demonstrated. I mean, it was.
Professor, fantastic. The whole day was very so much informative with your talks. For an old monkey like me, now he cannot learn new tricks. How much advantage does biportal surgery have over tubular surgery? How much advantage in terms of evidence over tubular? I'm using the tubular system. Should I stop and should I learn biportal, or I should continue now with the tubular?
Yeah, it depends on pathology. For interbody fusion, bipolar is easy, have advantage for making fusion bed. Bipolar surgery needs a more longer time to remove a facet joint. So, and for decompression surgery, we can see bipolar, we can come close the camera more closely, so easily magnification. So outside bleeding, but if you come close our camera to inside, outside bleeding doesn't have problem. But tubular surgery, outside bleeding disturb your visions. So I think tubular surgery, bipolar surgery is helpful. So I strongly, especially for the older surgeons, strongly recommend to run.
How much evidence you have got to prove that one should biportal is better than tubular surgery? Is there any long-term studies which show that biportal is better?
There are many comparison paper is several many, especially for compression, microscopic decompression and uniform time. But comparison of tubular is very rare, I believe. But interbody fusion, there are many comparisons, tubular surgery and endoscope surgery. Usually endoscope surgery longer time, but fusion rate is nearly similar. Yeah, and easy for and more good advantage for preservation of normal structure, muscles and other things is more well preserved in bipolar surgery.
Thank you, Professor.
Just a comment and last observation. I was very struck by all your experience and what you showed us in the operating room. So really congratulations for your outstanding knowledge of this interesting modification of the tubular endoscopic old-fashioned approach in a new style, a new feature. My only concern is the risk of CSF fistula. And normally, according to the literature, when we have an important CSF fistula as the one that you showed us, we have to convert endoscopic into microsurgical open approach. But in your beautiful experience and demonstration you gave us a few slides ago, you showed us how it's possible to seal the fistula with the Tacosil. But I have some concern about the way you put the Tacosil over the injured dura. As far as I understood, there was not an overlapping of the entire CSF fistula, and I didn't see any glue along with the patch. So can you better explain your technique, and is it possible to have a look of the post-op MRI 2-3 months later on? Thank you so much.
Thank you. Yeah, actually, yeah, I have also taken 3D MRI. Okay.
Patkar sir, I'll just quickly share my experience on your question. So I was doing tubular surgery for more than 10 years, and then I took up uniportal, and I was taking a couple of hours to do it. My VAS scores were, there was no difference between tubular surgery and uniportal. So then I gave it up, started doing tubular, but then when I saw the resurgence of uniportal, I came up, jumped again into the bandwagon. And this time I persisted, and the duration of surgery reduced from 2 hours to an hour. And that was the point when I saw a good difference between the VAS scores.
I don't deny that. I am asking evidence.
Yeah.
Thousands
So,
of patients done by many people.
So in our unit, we have study done by my fellows, and though the numbers are not huge, they are in 2 digits, double digits, but still we have now evidence that there's a difference. Also, we have good number of publications stating that they are at par or better.
Yeah, any other question? Yeah. Thank you very much, Professor.
One last comment. Professor, what is your opinion? Should one first learn open surgery and then learn biportal, or they should start directly with biportal? Because there are many youngsters here. Should they first become good open surgeons and then learn biportal surgery?
So what
or they should start with biportal surgery?
Yeah, thank you for a wonderful question. Yeah, someone who has a lot of experience for open surgery, microscope surgery, he easily become wonderful bipolar surgeons. Someone who started bipolar surgery firstly, I think it's some problem. So learning microscope surgery first, and then move to the endoscope surgery, also good mess.
I think that is a fantastic advice you are giving to the young people, because what happens after such workshops, everybody wants to buy a biportal endoscope and start with biportal surgery without having learned proper open surgery.
So very nice statement, and we appreciate it, sir. Yeah. Ramesh Dodamani, have a final question, please.
Professor, regarding the ligamentum clavum ossification in the dorsal level, where you have already a compressed cord, so you use the irrigation with some pressure. So is there any chance that it can cause deficits by causing more compression, because already the cord is critically compressed?
I think it's a very good question, because if you maintain the good outflow, the pressure we can maintain the pressure average about 5 millimeter HCA. So when you maintain good outflow, compression of cord by the hydrostatic pressure does not matter. But some doctors blocking of outflow, but to make a good vision, increase input press, they make a big problem. Intracranial problem, pulmonary embolism, can see, also called compression. So if you have a good maintain of outflow, I believe hydrostatic press on cord does not matter.
Thank you, Professor. Thank you very much.
Yeah, thank you very much, sir. And we are at the end of the day. Let's go to faculty club. It's just walking distance. Just have a walk on the right side. Our team will guide you, and we'll meet for a gala dinner.